Or do you expect that the comorbidities have changed? That the reason the stroke equalization risk has equalized in both the
Huge change in comorbidities now. Nowadays we are in a very bad state that we have to tell the parents that your son is having hypertension and you have to give medicines regularly. 30-year-old person comes, mild dizziness. You see the BP is 180 by 100. Mother is fine. She doesn't have hypertension. I think a lot has changed now. Lifestyle has changed us a lot.
Last question, sir. Let's say if you are if a person with stroke is already on NOACs and you want to go ahead for an elective surgery, or let's say from my side I tend to go ahead for a renal biopsy, how many days prior to that can you stop it?
So the half-life is around 12 to 18 hours. It is 1 day sir, for DOACs. For acetylcholine and warfarin, it is 3 to 5 days.
So do you advise if the other risk factors which you mentioned, that is mechanical heart wall, ABS, if those things are not present, can we stop it off, or do you have some period of, let's say as Dr. Shashidhar said, that if you are going for stenting, you need to wait for at least 6 months or so or 1 year before the stent becomes a bit, the endothelialization of stent happens. Is that, do you have that kind of rule in stroke? Or is it like, because he has not developed any stroke for at least a period of 3 months, probably you can directly stop it, go ahead for an elective surgery or a biopsy and then restart afterwards?
Sir, this is for anticoagulants, you're saying? Not sure.
It would be caused by effect, yes. For example, Kaplan syndrome. I cannot stop.
Absolute cases are not. Let's say patient was developed stroke.
If the patient has developed a stroke with minor things, let's say he does not have any absolute indication like ABS, mechanical and mechanical wall. If those things are not there, he has developed just an embolic stroke.
Embolic stroke, okay.
I think so.
We can stop it.
Yeah.
We can stop
We
it.
can.
Thank you.
Thank you.
Guidelines suggesting more duration, not 1 day. For
DOACs.
Some in guidelines, some suggesting 3 to 5 days.
Same for DOACs.
Yeah, DOACs. For thrombolysis, are you okay? If you skip 1 dose, you can do it. But for elective surgeries, 3 to 5 days.
Because as mentioned, this 3 to 5 days, if you have some sort of the antidote is present, that will be better. Because there are some case reports in our renal transplantation.
Yes.
So patients who were on NOACs and the patient did not reveal that they were on NOACs and they got a call for disease donor transplantation. They think that transplantation is a better, means it will change their lifestyle. They want to reveal those stats. The moment you do it, they'll have a massive bleeding. They'll have a huge hematuria which you have to just keep on giving fluid, packed cells, and FFPs we need to keep on having it that way. So prior to that, we used to always say that at least 3 to 5 days before we can stop it off based on the half-life as you said. Thank you.
Just one general question. When you talk about these scores, where you put gender or you put something which is very, very like Santosh said, that is there a real difference between the male and female?
Yes.
Then only the gender plays a role. So many of these scores, because I said through the PG thesis protocols, and I see that they're comparing scores, and many of those scores are not very relevant to the Indian scenario. So are there any validated modified scores, and also recommendations, like he said, grapefruit juice? My God, who's going to drink grapefruit juice unless they are the top Jubilee Hill people who are having grapefruit juice with your thing? But average Indian doesn't
Most
have.
of them do not have.
So what do we do for our Indian patients? Is it possible to make a score, make a recommendation which is more relevant to our thing?
Most of them are adapted, but we do not have a validated charts and has
I mean, how difficult
we
would
need
it be
a
to
large.
validate it? Because all of you neurologists are here.
That's a knowledge gap. We should do it.
If you compare the data, probably Indians will have higher amount of data which we can do it. But probably what is required is a consensus based on.
Any other question? Shall I move on to next? So the next presentation is on BP management strategy. So it will be a brief for 10 minutes. So what is hypertension? And then ischemic stroke in window period, eligible for IVT, how do we go about? And ischemic stroke in window period, eligible for endovascular therapy. And beyond window period and long-term management. So as I was just saying, why hypertension? There is no awareness. People feel hypertension. You take 1 month medicine. If it becomes normal, we'll stop it. And it is one of the it is a top risk factor for stroke and cardiovascular disease. Many of the patients say, I don't have any symptoms. Why should I really take? Then none of the family members have hypertension. Why should I have? These are the common questions now we get in the OPD. You start antihypertensive, they take for 1 week, or they might not even start. Then they'll tell, okay, I'll see for a few days. So this is OPD BP checking. It's not stroke and. So 30 minutes, at least they should not have exercise. Many of the times they walk, they go up, down and all they come. So you advise them to take at least 5 minutes rest. Caffeine should be avoided for at least 30 minutes. In the cuff, validation is necessary. Digital is accepted, it is a part of acceleration. The principle is used, which is correct. Patient have to relax at least 5 minutes, and the foot should be on the ground. And we should not talk while checking the BP. At least 2 recordings, and then average has to be done. This is a new guideline. Normal is less than 120 and less than 80 diastolic. Elevated is 120 to 129 SBP, and diastolic should be less than 80. So when diastolic goes up 80 to 89, it is stage 1 hypertension, and more than 90, it is stage 2. Same with systolic, 130 to 139 is stage 1, and more than or equal to 140 is stage 2. So when do we start therapy? So in selected cases, 130/80 has to be taken, especially in acute stroke or if there is acute cardiac event. Eligible for IVT, suppose patient comes in window of stroke and we see that eligibility criteria, there is no other contraindication except BP. So the BP has to be lowered less than 185 and diastolic less than 110. So this recommendation has come from the observational studies. There is no randomized trial that okay, we normalize 185 systolic and 200 systolic. There is no such data. Few papers are there where they said there is protocol violations, and when the patient had uncontrolled hypertension, hemorrhages happened. So these are very few. So exact BP at which the risk of hemorrhage increases in this patient and the second patient will not be able to tell. But one thing is clear, higher BP, higher chance of hemorrhage. So what shall we give if the BP crosses 185/110? Labetalol 20 mg over 2 minutes, it can be repeated once, and nicardipine 5 mg per hour IV. So it can go up to 15 mg per hour, and clevidipine 1 to 2 mg per hour, maximum 20 mg, 21 mg per hour we can give. So other drugs are hydralazine and enalapril. So after IVT, what is our plan? At least 24 hours, the BP should be less than 180/105. But it should not go down so much that it is less than 140. So the target is it should be less than 180/105. So suppose if patient comes with mild to moderate severity and who have been treated with IVT, intensive SBP reduction is not recommended because it can itself cause hypoperfusion and stroke. When there is a carotid disease and we reduce the BP drastically, the result is it can be detrimental, it can cause recurrent stroke, and most of the times that in acute stroke there is a reactive hypertension. So we need not treat so aggressively in these patients. Suppose if they are eligible for EVT, it is same as IVT. The target is less than or equal to 185/110. And as such, there are no RCTs. These are all from observational studies. The recommendation follows the same. Suppose we have a large vessel occlusion, anti-circulation, and successfully recanalized by endovascular therapy, and without other indication for BP management target, intensive SBP reduction is again harmful. So both in thrombolyzed patient as well as endovascular therapy, the intensive management in first few days is not needed. Supposing patients whom we didn't do any thrombolysis, so we can wait if the BP is crossing 220/120, we can go slow, and first 2 to 3 days we need not be aggressive in targeting the BP. And if it is less than 220/120, who did not receive IVT or EVT and do not have any comorbid conditions requiring urgent antihypertensive treatment, initiating or reinitiating treatment within 2 to 3 days is not effective. So where do we really go aggressive? So as I said, there is a reactive hypertension which spontaneously lowers in next 2-3 days. Only in these conditions we should aggressively go and reduce the BP in first few days. Heart failure, acute MI, concomitant aortic dissection, symptomatic ICH, and eclampsia group. So long term, as we all know, in general practice now the first line recommendations are ACE inhibitors, ARBs and thiazide diuretics. If it is not controlled with that, yes, we should go to the second line, CCBs and beta blockers. So in patients who come with TIA or ICH or mild stroke, SBP is 130/80. Our goal is to reduce less than 130/80. So many times in normal practice, if we see 140/90 is the guide, but if there is event, vascular event, and the patient comes with only that single issue, BP has to be targeted less than 130/80. So the target is around 180. There is no aggressive management in IVT as well as EVT. Aggressive in IVT, EVT in few hours, first few hours, because if there is a chance that if the BP is uncontrolled, the hemorrhage chances are there. Non-intervention patients, it should be a slow and steady, and the patient should be aware of this. Thank you.
Always a big bugbear. Mostly after 72 hours, how do we decrease it? We don't have much information.
Yes.
Yeah, therefore, but always we neurologists want to maintain a permissive hypertension, and over next few weeks, at the end of first week, 10%, then slowly over some time we try to target 130/80. Therefore, we like permissive hypertension. We don't
aggressively.
yeah.
Thank you. Good.
Morning, sir. Sir, if a patient presented with acute stroke and the parallel patient is having acute pulmonary edema,
Pulmonary
patient BP is more around 200, systolic 200. So how do we manage? And the patient is still in window period, presented to us. So what are the BP management strategies and targets in this patient? And the patient BP is 200. So we can normalize as guidelines, recent guidelines says we need at least 185/110 before thrombolysis. So we still go for that, or we need to manage the patient first. And the drug of choice in this patient of flash pulmonary edema with acute stroke.
Flash pulmonary edema.
Yes, sir.
So, Levetol may not be a very good choice in this patient. Hydrazine. The target is brain over. Definitely, we have to save it. So, thrombolysis has to be done. So, permissively, you can go up to 190, 185. If it is 200, yes, we should try to give a medicine. So, not Levetol. There are other medicines.
If I just add, for example, that's a flash pulmonary edema, isn't it?
Yes.
Therefore, you give Lasix, isn't it? You have to give the Lasix. It's not that you have to have 200. You have to bring it down to 185, right? Therefore, Labetalol has very short duration fraction. Others we don't have, right? Clibidipine and all we don't have. Therefore, it's not that it has to be more than that. It has to be less than that. Therefore, for a flash, what I would do in a patient if I see, I'll give Lasix, stabilize, put on BiPAP and thrombolyze. If the BP is not beyond around 200/110, I'll give short Labetalol, then I will go for a thrombolysis. That's the way I would do it. Then So definitely, what is the cause of flash burn? Is it acute MI or all? I'll definitely ask my cardiology colleague to. Would you suggest that?
Yes, sir. So it can be to hypertensive heart failure also. Acute MI, so definitely diuretics is the drug of choice for breast cancer. Up to 180 you can go. Sometimes we can use diuretic and we can start on the CPAP machine
Yes.
to reduce the pulmonary edema. Then you can simultaneously go for thrombolysis. It will take hardly 2 minutes.
Yeah.
So the one thing about the furosemide is the patient, in a patient of flash pulmonary edema, patient can be hypovolemic, euvolemic and hypervolemic. Both things are possibility. If we are giving the patient, if we are initiating 20 to 40 mg of furosemide, the patient can be in normotensive or a hypotensive patient. He can land up after resolution of this, he can land up. And the part of furosemide we are using because of the vasodilator effect it has. And nowadays for flash pulmonary edema, the use of furosemide has come down and the use of NTG has been used very widely nowadays. So in normal hypertensive patient, if we give Lasix, like we can go up to 300 mg of Lasix in the patient to come down on the BB requirement which we need for the patient to normalize. So in that patient, because of the hypovolemia,
Yeah. 1 second. Hypertensive, Lasix. Hypertensive, not sure, bypass. Nothing else. Very bad, morphine can be given. Right? Therefore, when the volume status you don't know, you are feeling that's a hypovolemic, hypotension is there. That's a very rare combination when you will have a flash pulmonary edema. Normally we associate flash pulmonary edema with a hypertensive crisis. But we have one patient, you don't want to give Lasix, put on, strap him on BiPAP, you will have it in the emergency. Then the air hunger is there, you can give a shot of morphine. That will take care of that. Then thrombolysis. Don't delay thrombolysis. That's the basic part. Now the contraindications of thrombolysis have come down drastically. There is nothing. You don't need anything. You just need a RBS, you need a BP reading, and you take a consent and you can just thrombolyze.
The standard care of pulmonary edema will be always the same. That is, you need to change, either reduce the preload, reduce the afterload, reduce the cardiac output, or reduce the volume. So the same three principles will always go ahead. So once you do it, probably pulmonary edema will start settling down.
That was a very fruitful session. Thank
Thank
you,
you,
Professor.
sir. Thank you.
And we close the session. Thank you.
Thank you, sir, for the wonderful presentation and the session highlighting the importance of individualized anticoagulation strategies and blood pressure control in recurring stroke. Now I request Dr. Praveen sir, Santosh sir and Dr. Shashidhar sir to hand over the memento to Dr. Ashok Vardhan sir.
Sir. Sir, close. Close. Okay. Sir, look here, sir. Sir, look here.
I request Dr. Anjia sir to hand over the mementos to the chairpersons.
Sir, sir. Okay. Sir, look. Okay. Sir, sir. Sir, look. Sir, sir. Okay. Sir, look. Sir.
We request the following dignitaries to come onto the dais for the lamp lighting ceremony. Dr. Sudhir Babu Sir, Principal, Kamini Academy of Medical Sciences and Research Center, LB Nagar. Dr. Andrea Sir, Medical Superintendent, Kamini Academy of Medical Sciences and Research Center, LB Nagar. Dr. Kamlesh Sir, Consultant Neurologist, Kamini Hospitals, LB Nagar. Dr. Lavanya Ma'am, Consultant Neurologist, Kamini Hospitals, LB Nagar. Dr. Annie Hassan Ma'am, Dr. Swami Sir, Dr. Ratnachari Sir, Dr. Santosh Sir, Dr. Shashidhar Sir, to come on to the dais for the lamp lighting ceremony. Dr. Jalil Sir,
That women also.
I request Dr. Andrea Sir to speak a few words about today's issue.
Good morning. Principal Dr. Sudhir Babu sir and our senior doctors, Dr. Swami sir, Dr. Santosh, Dr. Delhi, and our neuro physician, Dr. Kamlesh and Dr. Lavanya, and other doctors, senior neurologists, and other doctors, ladies and gentlemen. I am very happy to be associated with this CPD on ischemic stroke beyond window period. So what I can see out of the last lecture, there is a lot of advancement in treatment with regards to neurological disorders. I hope all these lectures will be of great use for the neuro patients in particular and other doctors in general. Thank you.
Now I invite Dr. Kaushik, our intern, to come forward and render the prayer song to invoke blessings for today's program. Thank you.
श्रीगणनाथं भजाम्यहं श्रीकरं चिन्तितार्धफलदं श्रीगणनाथं भजाम्यहं रञ्जितनाटकरङ्गतोषणं सिञ्चितवरमणिमयभूषणम् आञ्जनेयावतारं सुभाषणं कुञ्जरविनुतं त्यागराजपोषणं श्रीगणनाथं भजाम्यहं श्रीकरं चिन्तितार्धफलदं श्रीगणनाथं भजाम्यहम्. Thank you.
Thank you, Kaushik. Let us.
I request Dr. Kamlesh sir and Dr. Jaleel sir to hand over the mementos to Dr. Anjay sir and Dr. Sudhi sir.
Sir, look here. Okay. Sir, look. Sir, cool boss. Okay.
For chairing the next session regarding secondary prevention of stroke management, role of antiplatelets and statin therapy, I request Dr. Kamlesh sir, consultant neurologist, Kamini Hospitals, LB Nagar, Dr. Ratnachari sir, Professor, Department of General Medicine, Kamini Hospitals, LB Nagar, and Dr. Ravikant sir, consultant cardiologist, Kamini Hospitals, LB Nagar, to chair the session.
I request Dr. Kamlesh sir to introduce the speaker of this session, Dr. Reshma Sultana ma'am.
Good morning. Now the next speaker is Dr. Reshma Sultana. She is a consultant neurologist and assistant professor of neurology at NIMS. She completed her MD General Medicine from Usmania and DM in neurology from NIMS. Her areas of interest are in demyelinating disorders and immunology. She has authored 44 peer reviews, publications, and 4 book chapters. Received award at NIMS and was invited to attend the prestigious ECTRIMS Winter School 2026. So please welcome Dr. Reshma Sultan.
A very good morning, everyone. At the outset, I'd like to thank the organizing committee at Kamini Hospitals, especially Dr. Lakshmi Lavanya, for giving me this wonderful opportunity. So for the next 40 minutes, we'll be talking about the secondary prevention of stroke, and it will be subdivided into two topics. First, we'll talk about the antiplatelets, and then we will be addressing about the statins. So antiplatelets, dual versus single, when to start and when to stop. This is always a provocative question, and on a daily basis we come across so many patients. We know that there are indications for DAPT, we know that there are indications for SAPT, but still we are stuck sometimes. So the outline of my talk will be case-based approach mostly, and then we'll talk about the recommendations. We'll discuss about the indications of single antiplatelet therapy, dual antiplatelet therapy, time to initiate the antiplatelets, and the latest guidelines on antiplatelets and antiplatelets in special scenarios, and then we'll have a take-home message. So this is the first part of the lecture, and then we'll discuss more about the statins. Well, the risk of stroke recurrence, we know that 7-day risk after a transient ischemic attack is 8%, and 1 month later it is 11.5%, and 90 days later it is 17.3%. In minor strokes, the 7-day risk is 11.5%, and 15% at 1 month, and 18.5% at 90 days. So we are most worried about the first initial week and then the 3 months. After that, for a year, we are worried, and after 1 year, we know that our patient is going to do well. So this is what we know when a patient walks in and has a TIA or a minor stroke. So what the antiplatelet therapy does is, it plays a vital role in the secondary prevention of recurrence of this ischemic stroke. Most of the times when I'm talking about antiplatelets, I'm trying to address the non-cardioembolic. I think Dr. Ashok Vardhan Reddy has given a lot of inputs about the anticoagulants and the cardioembolic part. So we are mostly addressing the non-cardioembolic. So we'll go case by case. Since there's so many residents, I think you can just volunteer and give me your inputs as well. So we have a 49-year-old man who's a smoker and diabetic. He presented with right upper and lower limb paresthesias of 6 hours duration, and clinical examination just showed some cortical sensation loss in the right upper limb, lower limb. His NIHS was 4. So from this, we know that we are dealing with some non-disabling stroke within 6 hours, and the NIHS is only 4. So it's a minor stroke. So this is the flare imaging. Small cortical infarct can explain everything. The diagnosis is clear that it is a left MCA infarct with right sensory stroke. The TOAST classification is important. So I keep emphasizing even to my residents that when they write the diagnosis of a stroke, it's important to incorporate the TOAST classification. And the risk factor here was smoking and diabetes. So what will be your next step? What would you guys do? Would you guys go ahead, thrombolize the patient, ask for any additional investigation, or will you straight away start antiplatelets and be done? You can volunteer, 1 or 2 can volunteer. So how many will raise their hands for thrombolysis in this patient? So nobody wants to thrombolize this case. And how many want to start dual antiplatelet right away in this case? You don't want to do either of the things, it's a challenge for the patient. So we have to do something. Either you do thrombolysis or give a dual antiplatelet. So basically, because the NIHS score is 4 and the patient presented within 6 hours, if you have a scope to do perfusion imaging, which these days I think has become a very common practice, because the guidelines and newer trials are based on perfusion imaging, I think we should go ahead and do a perfusion imaging. And because this is a non-disabling stroke, I won't put my head too much into thrombolysis or convincing the family for thrombolysis. But despite the minor stroke, if the resources are available and say your perfusion imaging is showing a huge area of penumbra or a large vessel occlusion, you can still choose reperfusion therapies. So there is no class 1 indication, but yes, we can still choose when you have a perfusion imaging and enough evidence to dictate that there is a large vessel occlusion. But if the resources are lacking, then you can start the dual antiplatelet as a stroke prevention strategy in this particular patient. So in minor strokes or in lacunar infarcts, what are the trials saying? Most of you must be aware of all these trials, but I'll just talk a little bit about the MATCH trial, which was predominantly for acute ischemic stroke in high-risk patients. That is, at least one additional cardiovascular risk factor was considered in these patients, and they started on the dual antiplatelet, and mind me, the duration was 18 months in this. So MATCH trial said that the dual antiplatelets can have more hemorrhagic transformation. So it didn't really help. And then SPS3, we know that it is for clopidogrel and aspirin. Lacunar infarct, it's a no-brainer. We all know that lacunar infarct, it is dual antiplatelets, but the duration was 3 to 5 years. So when the duration is prolonged, more than causing benefit to the patient, we end up harming them. And chance trial, which most of the times in the rounds when your consultants are talking, it's based on this, that when a minor stroke or a high-risk TIA walks into your clinic or the EMD, you load them with 300 mg of clopidogrel and 75 to 300 mg of ecosprin, and then you will, from day 2, you'll keep them on dual antiplatelets for 21 days. And this is for TIAs and minor strokes. Point trial said you can extend it up to 90 days, and Thales trial used ticagrelor and aspirin. This was also for 30 days. So what is the final input out of this case is, input and output is, when you have a minor stroke or you have a high-risk TIA, dual antiplatelets can be given for 21 days followed by a single antiplatelet agent. You cannot stop the single antiplatelet. If the patient develops some problems on single antiplatelet, we will see in the upcoming cases what else can be done. So this has to be emphasized and re-emphasized that for 3 weeks is good enough. You can extend it up to 1 month. The maximum duration is 3 months. Longer than that, you are not going to give any benefit to any patient. So next is case 2, a 60-year-old gentleman, diabetic, hypertensive, alcoholic and smoker. He presented with transcortical mixed aphasia, right hemiparesis of 2 days duration. NIHS is 10. So the previous one was a non-disabling one, whereas here because aphasia is there, the NIHS is 10. And patient also reports that for 2 weeks he had had this transient symptoms which came, which went away. And he had poor control of vascular risk factors. So when I'm not talking in detail about other investigation, take it for granted that other investigations are normal. So this is the infarct which you're seeing. What you're seeing is that these are all the perforating artery infarcts, the border zone infarcts, and it is showing a distal MCA stenosis, but extracranial imaging is normal. So we are talking about a left distal MCA infarct with transcortical aphasia and right hemiparesis. We know that MCA is a problem, so we are giving it a toast 1 classification. And of course the risk factors, smoking, alcoholism, hypertension, diabetes. In India, I think most of the times there are more than 1 risk factors. So what will be your next action? The most important thing is you need to do a human-based imaging techniques to confirm the mechanism of stroke. I think MRI is easily available, go ahead and do. And then, since this patient is having the ICAT, so whenever you have intracranial atherosclerotic disease and a stroke which is lasting more than 24 hours, the DAPT is an ideal choice in this, and the basis for this statement of mine is the Sampras trial. So we all know what happens in ICAT, and especially the South Asians, and in India the ICAT prevalence is so very high. So whenever there is intracranial atherosclerotic stenosis, there are so many ways how stroke can happen. The plaque may be fragile, ulcerated, it will rupture and it will give rise to some distal embolization. The plaque can grow and cause a hemodynamic compromise, that's another mechanism. And whenever this plaque is there, it can actually grow into the branches in and around the major blood vessels, and it can cause the penetrating artery infarct. That was the whole point why I tried to show the that's why I was trying to show this perforating artery infarcts as well. So all this can happen in an ICAT. So what are the trials telling? We all know about the Sampras trial, which we need to be very, very sure about. They say that 325 mg of aspirin, I think in India most of us are scared to give more than 150 mg. So 325 mg of aspirin, 75 mg of clopidogrel was used for 3 months. There are other trials, like CARIS trial, they use the transcranial Doppler ultrasound. In Nizams, we are doing it very frequently now since the machine is available. We look at the microembolic signals, and depending on the microembolic signals, we can predict that this is a high-risk ICAT, and we put them on dual antiplatelets. Problem with CARIS and LACIT trial is only 7 days they have given the treatment. Claire and CARIS trial, they give dual antiplatelets but only for 7 days. So Sampras is the one which dictates most of our therapy in the ICAT. Then we have VISIT trial, similarly aspirin plus clopidogrel for 90 days. INSPIRES trial is one more, where we are extrapolating so many things from INSPIRES trial. So this is the latest trial. They say the same thing, that 300 mg clopidogrel followed by 75 mg plus aspirin. You give 100 to 300 mg for 21 days. So this trial says that even for ICAT, 3 weeks of therapy is enough. But still, I think most of us end up doing this 90 days period for ICAT. So the final output from this case is, in a case of intracranial atherosclerotic disease, go ahead for a dual antiplatelet, that is for 90 days, followed by single antiplatelet therapy. You are never stopping the single antiplatelet therapy. So next case is a 34-year-old man with diabetes of 2 years duration. and no other risk factors. He presented with history of right upper limb weakness, more than the lower limb weakness of 1 day duration. Again, NIHS is 4, it's a mild weakness, and he was worked up extensively and no etiology was identified. This is one of our cases. As you can see, that some amount of CSO involvement, basal ganglia involvement, and as you can see, the cerebral peduncle of the midbrain also is involved. MR angio looked absolutely normal. We worked them up, we did TE, everything was done including TCD, nothing came up. So this is multiple territory infarcts. You know that this is a lenticular striate artery infarct which is involving the deeper portions, and then the midbrain infarct could be because of a small branch over there which can be from posterior parietal artery, superior cerebellar artery, or a PCOM. So we don't know the etiology, we classify this patient as toast 5. So that's my diagnosis of this case. So whenever we are confronted with toast 5, in India most of the times the problem is resources. So we end up classifying them as cryptogenic or ESUS, which is embolic stroke of undetermined source. And mind me, cryptogenic and ESUS are not synonymous. For ESUS, you necessarily should have intracranial atherosclerosis of less than 50%. You should not have any major intracranial atherosclerosis. You should not have a cardioembolic extensive evaluation. The latest guidelines say that for 30 days at least we need to do the rhythm monitoring. Only then you can those patients will qualify to be called as ESUS. And that's the most important thing, 30 days. And then TCD extensive. They even recommend that cardiac imaging in the form of cardiac CT or MRI also is required. Sometimes it becomes a limitation for us. And once we know that it's a cryptogenic stroke, see, in a cryptogenic stroke, in this patient I would have chosen a single antiplatelet. This is again provocative. Some of my colleagues might say that I will give dual antiplatelet because it's a minor stroke. You can give. It is a class 2 recommendation, you can give DAPT. So it depends upon so many factors. Whenever you have a minor stroke or a high risk TIA, you don't have to think too much if you're starting on a DAPT. You will be okay for 3 weeks. And beyond that, single antiplatelet is the most important thing. If we have access to knowing the clopidogrel metabolism and all, your antiplatelet agent choice would depend upon those things. So the trials, we know about all these trials. The Navigate ESUS trial, they have compared anticoagulant versus antiplatelet. In Navigate, they compared rivaroxaban 15 mg with 100 mg of aspirin. In Respect ESUS, they compared the dabigatran with aspirin. In Atticus, apixaban and aspirin. Arcadia also apixaban and aspirin. So in these 4 trials, they didn't really find any benefit of the anticoagulant. So final output is again that single antiplatelet will suffice. In some special situations, dual antiplatelets can still be given. This CHANCE-2 is a new trial. In 2024, the Chinese people have published this trial, very interesting, where they took the patients who have a CYP29, loss of function, they have poor metabolizers or intermediate metabolizers, and they compared. They tried to give ticagrelor with aspirin, clopidogrel and aspirin, and they proposed that if there is a polymorphism which is common in Asians, then clopidogrel might not be the best choice. So they were proposing that aspirin ticagrelor. I think most of the clinicians have already started prescribing aspirin, that is 75 mg with ticagrelor 90 mg. So we do this, ticagrelor has to be given weekly. So that's important. So the output finally is that when you have an embolic ESUS and then you have a cryptogenic stroke, single antiplatelet is safe. You don't have to break your heads for anticoagulants. But the most important thing is if whichever trials are showing that anticoagulants are slightly better, they have found that there is some kind of a cardiac source. So that's the implication of that. And case was a 29-year-old woman with 12 weeks of gestational age who came to the EMD with abrupt left-sided unsteadiness and facial droop of 36 hours duration. One day before this presentation, she had 2 episodes of transient left-sided weakness and numbness lasting for a few minutes, and NIHS was 2 when she came to us. Small particle infarct, but what you can see here is the patient is having a dissection in the almost distal part of the cervical IC. You can see this, and you can appreciate even the double lumen over here. So pregnancy, first of all, young patients coming to you, dissections should always be thought. Pregnant patients, dissections even more, you will be thinking about it. Cortical infarcts, so you will think about dissection even more. So there's a right MCA cortical infarct, post 1 with right ICA dissection in pregnancy. So pregnancy will bring us new challenges because you can't give everything which you can give a general population. So what will be your next action in this particular case? When there is extracranial dissection in pregnancy, you can treat it with anticoagulants. In acute stage, by convention, what we do is we can give 2 weeks of parenteral anticoagulants. Ideally in dissection, if it is extracranial. Intracranial, we are scared of giving anticoagulants because trials have shown that subarachnoid hemorrhage can happen. So extracranial dissection, make sure that it's not intracranial. That's the first thing you discuss with your radiologist, and you will see it by yourself as well. And then you will treat with anticoagulants for 3 to 6 months. It is believed that in 3 to 6 months, recanalization happens. There are no current recommendations which say that at 3 months we necessarily have to repeat. But I think as a good clinical practice, you can definitely repeat it and see and be sure of recanalization and be confident of stopping the anticoagulant. If anticoagulant is not a feasible option, aspirin is always there for your dissection. So trials, the CADIS trial, RECAD trial, all these trials are telling that anticoagulant and aspirin, when they compared, aspirin was not inferior to the anticoagulant. So you can still give 300 mg of aspirin, a little higher dose than usual. And recently on DOAX also the trial has, a lot of study has been done. So in this paper by SEB et al., even the DOAX were performing as good as your vitamin K antagonists. So in dissection, I think this is the only condition where you can still think of stopping the antiplatelet if you have ruled out other atherosclerotic causes. Either anticoagulant or antiplatelet, it's your choice as a clinician, you can take a call on that. We usually give 2 weeks of parenteral anticoagulant followed by a single antiplatelet for 3 to 6 months. That's the safest thing what we do. So anticoagulant or antiplatelet for 3 to 6 months is good. As a good clinical practice, please repeat it imaging to look for the recanalization. I think this slide was shown by Dr. Ashok sir, so I will not re-emphasize again and again on that. And I just told that whenever you feel that the risk of bleeding is less, anticoagulants you can give very comfortably, but if you feel that the risk of bleeding is more, go for antiplatelets. That is the gist of this table. I'm not going to again reiterate the same thing. Moving on to the case file, it's a 55-year-old man with history of stroke in the right MCA territory 2 years ago, and he was already on aspirin 150 mg. Compliant with medication, presented with left hemiplegia and dysarthria, diabetic and hypertensive for 10 years. NIHS was very, very high, and patient required decompression. As you can see, again, he developed in the same territory, huge infarct, required the decompression. So the right MCA infarct with mass effect post-1 with right MCA stenosis, again in the same territory the patient developed despite being compliant on ecosprin 150 mg. I think this is what a common clinical scenario which we all face, that first thing we'll ask about compliance when we're sure we don't know what to do, we switch the other antiplatelet by using the logic, and what the trial says also the same thing. So why did the patient develop stroke despite using the antiplatelet? If you have an opportunity, try to establish it. So beyond the routine investigation, what we can look for is the antiplatelet agent resistance. I think after the end of the talk, we'll discuss with Annie and ma'am also if that facility is available in India. At least in Nizams, what we do is aggregation, platelet aggregation tests is what we do, where we measure the ADP and we measure the collagen. The normal percentage, we have a turbidometric analysis of this. So 60 to 90% is normal. If the patient is on good dose of aspirin, compliant, then his collagen percentage will come to less than 30%. If the patient is on clopidogrel, then his ADP level should be less than 30%. So by this platelet aggregation method, that is what we do, and that's available in Nizam. So we do it in our patients, but not very routinely. Then the other thing is you can look for the clopidogrel. You know that for clopidogrel to become an active agent, it is the cytochrome P dependent metabolism. So CYP polymorphisms also can be looked at, and even that is being done on a research basis in Nizams. So whatever I do, that's the same thing. And when you know that the patient is developing stroke on the existing antiplatelet, you have 2-3 options. One thing is that the most convenient option is change the antiplatelet agent altogether, or you increase the dose and watch, or you add another agent. What most of us will do conveniently is we add silastazole. So these are the things what we do. Ticagrelor can be given in the place of clopidogrel when it is required. So this was a paper which was published from Nizams by the CPD department. So they showed in cardiology patients that whenever there is a CYP2C19 polymorphism, the stent restenosis was more common. So if you have an access, try to do this. So the point I wanted to tell is precision medicine would be the best thing, but that may not be an option as of now in India. Moving on to the next case, a 22-year-old lady was there with 3 episodes of TIA affecting the right upper limb and aphasia she had over the last 4 months, and she presented with anterior aphasia, and MRI was done. So what I'm trying to tell is from 4 months a young girl is having multiple episodes, and this time she came with a proper aphasia and anterior aphasia. Look at this MRI, can you tell what could be the underlying disease? This is a no-brainer, anybody can answer. What is this? Supraclinoid ICS stenosis in a young patient? Yes, it's moya-moya. So it was a moya-moya syndrome or disease, we don't know. We need extensive evaluation for that. And patient underwent a left MCA STA bypass surgery in Nizams. And after the surgery, within 24 hours, the patient developed global aphasia. She was not at all understanding what was being spoken to, and look at this MRI immediately after the surgery, she developed bifrontal huge infarcts. So now, antiplatelet agents, they can be used to prevent ischemic strokes in patients with Moyamoya disease. There are no clear guidelines as to which has to be used, but whatever trials we have, aspirin is the most common agent which is being used. If you want to add another drug, like in this case, post-surgically, you want to salvage the brain, you can choose another antiplatelet, and as per the trials, which are mostly based out of Japan and Korea, silastazole is safely given. So that's what we've done in this patient. We gave 150 mg of aspirin, we added silastazole 100 mg, and we followed her up, and it's 3 weeks she started speaking and the rehabilitation is being done. So Moya, the recommendations are single antiplatelet agent is better. Which one? It's aspirin. And if you have to add one more because of unusual circumstances, go ahead and add silastazole. Then case 7 is a 44-year-old man, a smoker who had a TI and extracranial atherosclerosis of right ICA. So this is very common. My friends are there from, who've done a lot of stroke intervention, Dr. Jagdish and all. I keep asking them what to be done and all that. So they underwent right ICA stenting, and the intervention radiologist left it up to the neurologist. You decide what you want to do with the antiplatelets. This is a common scenario. No? Intervention radiologist do the procedure, the patient comes to us, and it's our headache afterwards. So what the recommendations are, to give dual antiplatelet agents for 3 to 6 months, and aspirin and clopidogrel combination is the best one. And after that, you switch to a single antiplatelet agent after 3 to 6 months. That you can decide. Why this 3 to 6 months period is chosen? That's because re-endothelization of the metallic stents is supposed to happen within 3 months. The whole, whatever is required, that will finish off in 3 months. So the final output is whenever you have some kind of a procedure, if the neurologist is doing the procedure, you don't have to worry. If the intervention radiologist is doing the procedure, know this, a dual antiplatelet agent for 3 to 6 months followed by a single antiplatelet agent. Okay? And next case is 45-year-old man presented with left upper and lower limb moderate weakness with dysarthria, which had been progressing for more than 20 years. The family was unwilling to undergo any revascularization procedures, and NIHS was 9. MRI had a right lenticular striate artery branch infarct. So now this is a progressive stroke, not willing for revascularization. There is some stroke which is there, and nothing has to be done, or what has to be done, we don't know. So there is one trial called Rescue BT2 trial. In this trial, we can initiate the patients on intravenous tirofeman. So what is the dose you give? We start on 0.4 microgram per kg per minute for 30 minutes. This is followed by 0.1 microgram per kg per minute for 48 hours. Along with this, you will put 100 mg of the aspirin. That's for at least 90 days. This is what we have to do. So just mind me, who are these candidates where you can give tirofeman is? Revascularization is not possible, but the stroke is progressing. So that's number one. The other thing is, you have done some revascularization, but still the patient is having the progression of stroke, and you have means to look for early bleeding tendencies and all. You can still go ahead and do this. I think 2 patients in the last 6 months, we have put them on tirofeman. One was posterior circulation, one was anterior circulation. Both of them are doing relatively okay, and their progression stopped. So this is something which we can do when reperfusion therapies are not an option. So a quick summary of what we have learned. So when do you give single antiplatelet agent? You have a low risk TIA, that is ABCD2 score is less than 4. You give a single antiplatelet, and if you have done IVT, wait for 24 hours, you will finish off the imaging. There is no hemorrhage or nothing. You can start after 24 hours aspirin or clopidogrel, depending upon what you people follow in your institute. So CPD trial have shown clopidogrel for even the gut things, but aspirin is feasible in India, so it's okay to start aspirin. Say the patient is not undergoing IVT and it's a large stroke with NIHS more than 5, non-minor stroke, then you have to start aspirin immediately. You can choose alternatives like clopidogrel. As a monotherapy, ticagrelor in Socrates trial has not been proven to be that good, but other trials are coming up which say that ticagrelor also can be given. And thrombectomy without IVT, single antiplatelet can be given in large strokes. So what are the indications for dual antiplatelet therapy? High risk TIA, that is ABCD2 score of more than 4, based on so many trials, chance 2 point and tails. Lacunar infarcts, give a dual antiplatelet. Minor non-disabling cortical infarcts, NIHS less than 5, give a dual antiplatelet. And yeah, that's the thing. And in ICAT and in ECAT, you can give, based on INSPIRE's trial and the SAMPRE's trial, a dual antiplatelet. Duration is TIAs and minor disabling, non-disabling strokes, 21 days. In case of ICAT, ECAT, you can give it for 3 months. When to initiate the antiplatelets? If you are not taking up the patient for any procedure, you start immediately. You don't have to break your heads about that. And if you're taking up on some kind of a procedure, you can wait for 24 hours to repeat a CT and then you can start the patient on antiplatelets. The earlier you start, the better it is. Sometimes when there is ICH and all, and the patient needs to be on antiplatelet, wait for 2 weeks. Sometimes you can assess and start the patients earlier also. So this is a common scenario, we get referrals from our colleagues that the patient is undergoing some procedure, kindly recommend on what has to be done for aspirin, clopidogrel, or even anticoagulants. I won't touch upon anticoagulants because Dr. Ashok Padaledi sir has already covered. So aspirin, you can actually continue. You can tell them that if the bleeding risk is not very high, you will not have some catastrophic bleeding, then you can just continue aspirin. Do not have to stop at all. But if the past history is there and the patient has a very high risk of bleeding tendency, then maybe you can stop it only a day prior to the procedure. Clopidogrel, ideally 5 to 7 days prior to the major surgery or minor surgery, we need to stop. And you can restart 24 hours after the surgery. Statins, they don't have to be stopped. So latest 2026 guidelines, it's the re-emphasis of what I just told, that try to start aspirin as early as possible. Within 48 hours is the most important thing in non-cardioembolic strokes. And in non-disabling strokes, it's a dual antiplatelet. So that's what has been emphasized and re-emphasized again and again. So when you have an access to clopidogrel metabolism studies, then try to do that to have a more precision-based medicine. And if you have, so antiplatelet therapy is recommended for patients with antiphospholipid syndrome or systemic lupus erythematosus without a history of stroke or unprovoked venous thromboembolism to prevent the stroke. And antiplatelets in special scenarios, I'll quickly run through this. So in post-thrombolysis, you wait for 24 hours. If there is a large artery atherosclerosis, you do dual antiplatelets. In ICAD and ECAD as per the INSPIRE trial, and for 90 days if it is ICAD. ECAD 21 days is still okay. High GI bleeding risk if you have, you can add ecosprin along with PPI. Clopidogrel and PPI is not a great combination because PPI can interfere with the metabolism of clopidogrel. If there is clopidogrel resistance, choose some other drug like ticagrelor. In CKD patients, try to give a single antiplatelet, clopidogrel is preferred. If the patient has a GI bleed, try to prefer a single antiplatelet, or if they are on oral anticoagulants, try to give an SAPT, that is single antiplatelet. Thrombocytopenia also, even if the platelet counts are less than 1 lakh, you can still give a single antiplatelet. In case of peripheral arterial diseases and acute ischemic stroke, you can add cilastazol to aspirin, even in Moya the same guidelines. And if the patient is having some sort of aspirin-related complications like bronchospasm, very rarely, you can still go ahead and give clopidogrel. So single antiplatelet or double antiplatelet, I think it's very clear. If you have some major stroke, it's single. Minor, it's dual. The rule of thumb is that only. And when to start as early as possible, except when patient is undergoing IVT, EVT, and duration keep it 21 days in minor strokes and in ECAD and 90 days for ICAD. Best antiplatelet agent, of course, that we do not have based on the head-to-head trials. Of course, CPD trials show clopidogrel is better, but precision medicine is the need of the hour because I think we all are very different from the Western population where most of the data is based on. So that was the first talk. I hope that is clear. And now for the next 15-20 minutes, we'll talk about statins. That is dose, mix, timing, intensity, when to start and when to stop. So the outline again will be like that in the form of role of statins in stroke, dose of statins, adverse events, intensity of statins, when to start, when to stop, and myths and facts. I'll ask you people, you can shout whether you feel it's a myth or fact, and then we'll have a take-home message. So stroke, of course, we know is one of the leading causes of human death. And what happens in stroke is not just the occlusion. There is something beyond occlusion that happens, which is in the form of lot of endothelial dysfunction, thrombogenesis, lot of inflammatory response, a lot of oxidative stress damage, and angiogenesis. So statins are not just to lower the cholesterol, they have a lot of anti-inflammatory effect. Like you can see, you don't have to remember all these biomarkers. What I want to show in this slide is the statins can attenuate the inflammatory damage by affecting these biomarkers. It can modulate thrombosis, it can improve the endothelial function, it can facilitate angiogenesis, and it can reduce the oxidative stress. So it's not just the cholesterol lowering, so statins have so much role beyond the cholesterol lowering. So they inhibit the formation of isoprenoids, which play a key role in the cellular signaling and control of cell functions like proliferation, differentiation, and migration. So statin therapy, and that too high-dose statin therapy, is what is required. And the trials have shown that pre-treatment has reduced the severity and intensity of the stroke. So what is the average relative reduction in the LDL cholesterol concentration with different doses of statin? Just look at this blue part. At least 40 to 80 mg of atorvastatin and 20 to 40 mg of rosuvastatin is required to lower the LDL by 50%. So that is what you need to remember. And so many adverse effects our patients will be reporting. We have myalgias, we have CPK elevation, we have transaminase elevation. I think this awareness is there in the patient that the moment you write a statin, they themselves will tell it will cause body pains, I don't want to take it. But the trials have shown that it is very, very less. Say for example, you treated 10,000 patients for 5 years, then only 5 patients may have a real myopathy. The non-specific myalgias and all will settle with time. And new onset diabetes is something which is reported. And the biggest fear is hemorrhagic strokes. So the ones who are on existing statin therapy, as soon as there is an ischemic stroke, we have a tendency to stop the statin. Whether we should stop or no, we'll learn in the upcoming slides. Yeah, so intensity of statin, what is a low intensity therapy is when the LDL cholesterol reduction of less than 30% is required. We are not doing that. At least we need 50% or more. For that, we need at least moderate to high intensity therapy. So, like I said, that you need a 40 to 80 mg of atorvastatin and 20 to 40 mg of rosuvastatin. So we will restrict to these statins because those are commonly used. And the stroke cholesterol guidelines were given about the high intensity statin has to be started in those people with clinical atherosclerotic cardiovascular disease including stroke, and when there is primary elevation of LDL of more than 190. If a patient is a diabetic whose age between 40 to 75 and LDL cholesterol between 70 to 190, and those aged between 40 to 75 with 10 years ASCVD risk of more than 7.5%. Online calculators are available. How will we know this risk? We do have Prevent. There is Prevent ASCVD Prevent scale, and all online calculators are available. On that you will put all the data. You will get what could be the 10-year risk of having the atherosclerotic cardiovascular disease. So the guidelines, what they say, I will just summarize and I'll tell you in brief. Whenever there is no clinical atherosclerotic disease but the patient is at a high risk, you have to lower the LDL cholesterol level to less than 70. But if the patient is having a clinical atherosclerotic disease who's already got a stroke, belongs to that high risk category, decrease the LDL to less than 55. So that is important. And to get this goal, you need a high dose statin. So 80 mg, 40 to 80 mg is what you need to give for atorvastatin. If it is rosuvastatin, give 20 to 40 mg. So most of the times people are scared of that 80 mg of atorvastatin. They keep asking us, when to stop, what to do. Ideally, don't stop. High dose statin is the thing which they require in strokes. What we do is 4 to 12 weeks later we repeat the state. I don't think most of us do that. We are only focusing on aspirin, clopidogrel. I think it's a good clinical practice to ask your patients to come back with a fasting lipid profile after 1 month and look at the LDL cholesterol, which is the most important indicator for further atherosclerosis. If it is not less than 70, they say ezetimibe can be added. Ezetimibe is available in India, so you can give a combination of atorvastatin and ezetimibe. And this is very important, and every 3 months you should keep repeating it. And this PCSK9 inhibitors, I have absolute no experience with that. Monoclonal antibodies are also available in India. They are prohibitively expensive. In a month the cost will be around 1.5 lakhs because we give 420 mg monthly, or even subcutaneously we can give it on 2-week interval. So that is what is the recommendations of statins. So the trials, of course the trials are emphasizing the same thing, that whether it is Prosper, Sparkle is of course a landmark trial where they showed that 80 mg of atorvastatin in stroke and TIA with 1 to 6 months reduced the fatal stroke risk. The Jupiter trial was about this rosuvastatin with high CRP, and I think you know that they took the normal people there and they showed that the pre-treatment statin or a pre-stroke statin decreases the stroke severity if they develop a stroke in future. So that's the use and advantage of having a statin. So Eureka is again rosuvastatin versus placebo in statin-naive patients. This Fourier study is for the cardiologists. So where I have no experience with this, so I'm just telling from what the guidelines are telling. The PCSK9 inhibitors are the monoclonal antibodies. You give 140 mg every 2 weeks subcutaneously or 420 mg monthly. So they have been shown to reduce their LDL more intensely to less than 55 if atorvastatin and ezetimibe alone are not doing the work. So when to stop the statin therapy? Ideally, you should not stop. So that is the most important thing. The dosing also, you should not come down unless and until there is some requirement. But there are some exceptional situations like a decompensated liver disease, or when the patients are planning pregnancy, or the patient is having a rhabdomyolysis. So that is the indication. Just having myalgias or mild elevation in CPK, no. Maybe you can come down on the dose of the statin or choose an alternative statin, but you need not stop it. But rhabdomyolysis, we just had a patient who had an MI, increased the dose of the statin, and within 2 weeks had necrotizing myositis presented with AKI. We can't re-challenge. So in rhabdomyolysis, but what the studies are telling is that more than 90% of the patients, when they are re-challenged with same or other statin at a lower dose, they are actually tolerated well. So I wanted to answer these questions. In the acute phase of stroke, if the patient is already on statin and the patient has gotten an acute ischemic stroke, will you withhold the statin? It is wise to withhold. Myth or fact? I want you people to please participate. You can just tell myth or fact. Yes, this is a myth, so you need not stop. So the studies are telling that you can continue. In the acute phase of stroke, statins can cause hemorrhagic transformation. Is it a myth or a fact? This is a fact, yes, this is a fact. But again, there are so many trials and studies which are telling that there are patients who are the high-risk category ones. If you can do the SWI imaging, you will know about the microbleed status. You can predict which patients will have a high bleeding risk. So of course, based on that, you can decide whether to continue. But yes, they do have a small percentage of increase in the hemorrhagic transformation, especially in the high-risk patients who are the ones who have previous bleeding, who have many microbleeds and a larger stroke. So pre-stroke statin use is associated with more collaterals or a smaller infarction size in patients with acute cerebral ischemia. Is it a myth or a fact? Yes, this is a fact. Embolic stroke doesn't need statin therapy. Myth or fact? So this is again a very provocative thing, because embolic stroke, the guidelines are not there, but there are 1 or 2 trials which have been done, and they have shown that even in embolic stroke, the statins do have a role. Statins can cause rhabdomyolysis and necrotizing myositis. Is it myth or a fact? This is a fact, but very, very rare. Do not counsel your patients that you may develop this and all. You have to put it in a very, very wise manner, that they do not opt out of taking the statin. So the next thing is, high dose of statin use are associated with a high incidence of symptomatic ICH in patients with ischemic stroke after IV thrombolysis. Myth or fact? This is a fact actually. When there is an IV thrombolysis, so they can have slightly, but absolutely no guidelines saying that you should not use the statin, but you should be aware that there have been case reports and in trials also they have seen this. Re-challenge with statin in case of adverse events can be tried. Myth or fact? Yes, fact. Muscle pains during statin therapy should preclude us from continuing the therapy. Myth or fact? Yes, this is a myth. De-intensifying statin therapy is a rule in stroke. Myth or fact? This is a myth, yes. But when we were doing our residencies and when we used to attend conferences, Subhash Kaul sir told us that what he does is 80 mg of atorvastatin he gives for 3 months, and after 3 months he looks at the fasting lipid profile. If the LDL comes down to less than 70, he tries to come down to the dose of 40 mg. This is what we learned from his vast experience in stroke. So that's one anecdote which I wanted to share with you. Statins, if indicated, should not be avoided in patients with pre-existing liver dysfunctions. Look at what I have written: NASH and compensated cirrhosis and compensated liver diseases. Can you still continue statin? Yes or no? Myth or fact? Yes, this is a fact. If it is decompensated, you need to come down. Otherwise, you can give. This is a busy chart, but very, very useful. In this, what we are trying to tell is, primary prevention is trying to give when the LDL cholesterol is more than 100, you have to give statin. So that is the most important thing. Try to bring it down to less than 70 with high dose statin alone. If you can't do that, add ezetimibe. If you can't do that, I just told about the PCSK9 inhibitors which has to be done. So this is very, very important. And LDL cholesterol targets in those individuals who have hypercholesterolemia, which is severe, already had a stroke, the target LDL is less than 55. So this is the rule of thumb, and try to remember. So this is a very useful flowchart for us when we are looking at patients and we don't have too much time. We are looking at what additional atherosclerotic risk factors, vascular risk factors they have, what is the level of the LDL. Based on that, there are recommendations. The two most important points is if the LDL cholesterol is high and they have an atherosclerotic CVD score of 10-year risk of more than 7.5%, which we can do with the online calculator, put them on statins. If they already developed the stroke, keep your LDL target less than 55. If they didn't develop the stroke, less than 70 is good enough. So the take-home message is statins have a role beyond lowering the LDL levels in acute ischemic stroke, which we just discussed very exhaustively. And high-intensity statin therapy has more benefits than risks. So counsel your patients in these lines. And we have to target the LDL to less than 17 high-risk individuals. But if they get a stroke and other vascular risk factors are less than 55 is the target. Common adverse events like myalgia or transient transaminase elevations should not preclude us from using the statins. Thank you so much, and I dedicate this talk to Sandhya Manoranjana, who was my mentor where I worked earlier, that is in Deccan Medical College. She taught me a lot of stroke, and my friends Dr. Ashok Reddy and Jagdish Reddy, I call them, trouble them a lot during my daily clinical rounds, and they were speakers today luckily. My faculty, other faculty from Nizams, Dr. Rinda, Dr. Surya Prabha Maharaj, and Dr. Seshana, and my cousin Aisha, who helped me with this PPT. Thank you so much.
Thank you, madam, for an extensive talk. And your case-wise also you have discussed very nicely, very useful. These dual platelets were not used by neurophysicians earlier, before 5 or 6 years back, I think. Cardiologists have started dual antiplatelets. Neurologists have started late in ischemic stroke.
So our indications were very few for dual antiplatelets. Yes. So those indications, we never were apprehensive about starting dual antiplatelet. Plaquenil, no-brainer. ICAD, no-brainer. So we give it for a short duration. The duration is important because in stroke what happens is when we prolong dual antiplatelets, the bleeding risk outweighs the stroke benefit. So that's why the lot of trials had to come up and all.
So as I'm a physician, we always try to see if there is any underlying cause. That's why also. And when about the statins, we are blaming statins like anything now. We are stating statin is one single entity. There are 7 drugs are there, and they are latest guidelines. March 26 guidelines are released. They are totally changing the lipid profiles. Thank you.
It was an excellent presentation. So I have few doubts. So what is the choice of SAPT after DAPT after using for 3 months? What would be the choice of?
In an ideal case scenario, if I am given an option, I look at the platelet aggregation studies, I look at the clopidogrel polymorphism studies, and I'll choose based on which antiplatelet resistance is not there. So say for example, the platelet aggregation studies which we do in Nizams, we look at the ADP and collagen levels. That will tell if the ADP levels have come down, when the patient is taking clopidogrel, that means clopidogrel is working. And if the collagen levels come down while the patient is taking aspirin, that means aspirin is working. And when should we take the sample is at least after 7 days of giving the aspirin and clopidogrel. So ideal case scenario, say I put a patient on a DAPT, after 7 days I'll take the blood sample and I'll run these tests. I'll know which drug is acting more on this patient. And clopidogrel, CYP, 2C polymorphisms, for looking at the slow metabolism or a good metabolism also we can study. In Nizams, they are already doing it on research basis. So if I have access, I'll do all this, and based on that, with full evidence, I'll choose the drug. But in a scenario where it is not possible, which is most of the times, in India, we prescribe aspirin because of the cost effectiveness and the ease. So after a dual antiplatelet, 150 mg of ecospirin is conventionally prescribed, sir. If the patient is having a lot of GI intolerance or CKD, then clopidogrel is chosen over aspirin in these kind of situations.
So how frequently we are doing this platelet aggregometry test? Any guidelines for that?
Absolutely no guidelines. In fact, in Nizams, despite the fact that they are doing, we try to retrieve the data because I was giving this talk. I then sat down with the CPT people. Unfortunately, in the last 1 year, we could send only 25 samples. So I think that practice we should increase, but there are no recommendations here. But if the patient develops a stroke on one antiplatelet, I think we should proactively do that. We are starting an MRE project in Nizams where we are trying to recruit patients and look at all this so that we can, decide with evidence of which drug can be chosen.
Okay, so the next thing is what is the role of anticoagulant patient? We suspected a cardioembolic stroke, and how will you start the antiplatelets and what is the role of anticoagulant in these patients?
So most of my talk was actually focused only on the non-cardioembolic strokes, sir.
Yeah.
Cardioembolic strokes, it's usually anticoagulants most of the time because stroke is caused either because of a thrombus, LA dilation, or there is some sort of an atrial fibrillation, which is the most common thing. So in a situation like that, it's usually anticoagulant and never antiplatelet. If there is some kind of reason where the anticoagulants are precluded, then dual antiplatelets, though they cannot act equivalent to anticoagulants, can be a choice in patients who develop strokes in AF. There are 2-3 trials which have shown that when we cannot choose anticoagulants, dual antiplatelets have still tried to cover up for whatever the deficit was.
If we have a clear evidence of, say, a patient is having, say, from our side, mitral stenosis is there and LA is dilated and patient develops stroke, there is any role of antiplatelets in this patient?
No, sir. Valvular AF, most of the times it's AF which causes the stroke when the LA is dilated. Valvular AF, we don't have any other choice other than warfarin. So valvular AF, it's only warfarin, there is not even DOACs rule. But if it is a non-valvular AF, then we can give still the DOACs. Antiplatelets, as of now, if you ask me, if I have to give a crisp answer, the answer is no.
No. So we can straight away start with the anticoagulant.
Especially the scenario you gave, I will go ahead with warfarin.
Yeah. So regarding the statins, from our experience, no, we use PCSK9 inhibitors. So we keep on high doses of statins initially to reduce 50% of the LDL target. So if you're not able to achieve a rapid reduction, so we try to give, if a patient is having a stroke, MI or anything, present with ACS, so we use PCSK9 inhibitors because we need immediate effects. And nowadays we had an inclisiran wherein we are choosing this drug if the patient is having an ASCVD score more than 20 and we don't need a rapid reduction. There we choose inclisiran if we are not able to achieve LDL reduction more than 50% with optimal doses. And regarding the genetic testing, how frequently we are doing in stroke patients?
We in hospital, we have all the CYPs available with us, and we give it whenever the consultants ask for it. And we've gone beyond the research stage. I mean, in India, we've gone beyond the research stage now. So when you made the statement that in India it's not possible, I found it very strange because doing individual gene variants which are known is, we started it when Jagdeep was with us. In 2006, we are doing CYP9, 19, BCORC1 and so on. Same with statin. Instead of trivializing a patient saying that I have got myalgia and you persist, do the SLCOB1 variant. If they don't have it, they say no, this may be more psychological because multiple people look at Google and talk about it. But I think it's unfair to trivialize it by saying that it's not important and just continue, because they will not continue. So just do the SLCOB1 variant, one variant, and 27% of the Indian population have it. All your trials, which one has Indian database, please tell me. No, no. So then either we should have an Indian trial or do what is known as a functional CYP. So CYP 9, 19, BCORC1, SLCOB1, A4. I think you came a bit late because I gave my talk on that and I listed it out. Yeah. Thank you.
Thank you.
Thank you.
Can I one more question?
Yes, please.
I have one when you are labeling it as a cryptogenic or uses, maybe it's in an excess evaluation. But most of the cases we'll see because I'm an industry, so most of the cases we'll see we try to evaluate AF and any valve or any thrombus in any but we don't see this, but patient have multiple areas of embolic stroke and pattern. So in this case, like when I gone through yesterday, like there is two things they mentioned. Like one is atrial arteriopathy, and maybe there is a hypertension. These are two things deciding whether to go with anticoagulation or equosprin, like antiplatelets. So like this is being followed by related of this.
So atrial cardiopathy, we have trials like Atticus trial and all that, sir. In that, antiplatelets were good enough. So if you just have an atrial cardiopathy, that does not qualify the patient to receiving anticoagulants. Say at least 30 days of rhythm monitoring is what is required. So 30 days of rhythm monitoring, if you find an AF during that 30 days, then I think you know it is no longer a cryptogenic stroke or it is no longer an ESUS. So we know that the atrial fibrillation can cause the stroke. So there it's easier to choose anticoagulant. So at least a 30-day period of rhythm monitoring, and atrial cardiopathy with respect to that antiplatelet is good enough, so we don't need anticoagulant in that. And one more thing is the transesophageal echo with a bubble study to look at the PFO. If the PFO, say if the patient is younger than 60 and the PFO can be closed with an umbrella device, we should close it. But beyond 60 years, antiplatelet alone is enough. So this PFO is something which we miss, and we may pick it up during the future evaluation. And TCD is something which somehow lost its charm when it was initially there. So in TCD, when we do a bubble study and all, we can look at the microembolization signals, HITS it's called, high intensity signals which we see. So it's a very simple non-invasive procedure. Based on that TCD also, we can pick up that there is some microembolization which is continuously happening and all. So when you see that even that is there, you can go ahead and give antiplatelets. So when you are in a fix and you are not able to find the etiology at all, or when it is atrial cardiopathy, antiplatelet is good enough. But during your extensive evaluation, if you found that there is AF, give anticoagulant. If it is PFO, cannot be repairable, also antiplatelet is enough.
So how much frequently you see this cryptogenic stroke just make to this?
It is pretty common. So like the literature says that at least 20-25% of the strokes are like that, and we see very commonly these days post-COVID, the young strokes have increased so much that despite the extensive evaluation, we are not able to find the etiology. So I think more Indian data is required, especially the post-COVID era. I think the strokes have increased a lot even in young. Thank you, sir.
Thank you, ma'am, for the wonderful presentation with practical case scenarios.
Now I request Dr. Kamlesh sir, Dr. Ratnachari sir and Dr. Ravikant sir to hand over the token of appreciation to Dr. Reshma ma'am.
Look at it. Look at it. Up. It is close. Look at it.
I request Dr. Kaimal sir, HOD Department of Anesthesia, Kamini Hospitals, MD Nagar, to hand over the token of appreciation to the chairpersons.
నాకు ఇయర్ అనుకొని పోతుంది
Close. Up. Sir, look at sir. Sir, sir. Sir, look at sir. Up. Sir, look at sir. Sir.
Due to time constraints, we will not be having a separate tea break. Tea is available outside the auditorium. I request delegates to kindly collect it and continue the scientific sessions. Thank you for your cooperation.
Giri.
మంజేనా ఏదైనా మనం పోవాల్సింది
అదే బ్రేక్ చేయలేరు అలా చేసుకున్నాను అంటే కంటిన్యూ ఇదే మళ్ళీ ఏం అనౌన్స్ చేసుకున్నాం కరెక్ట్ వేద్దాము కరెక్ట్ వేద్దాం
పోయేదామా పోయిరా
स्ट्रेस आउट रिलैक्स आ गया
थैंक यू
For chairing the next session regarding management of intracranial and extracranial atherosclerosis, I request Dr. Shailesh Mohan sir, consultant neurologist, Wellness Hospitals, Dr. Akhilesh sir, Associate Professor, Department of Neurology, Usmania Medical College, and Dr. Subramaniam sir, consultant, Nuclear Medicine, Kamini Hospitals, Elbinagar, to chair the session.
I request Dr. Akhilesh sir to introduce the speaker for the session, Dr. Chaitanya Koduri sir. I request Dr. Shailesh sir to introduce our speaker, Dr. Chaitanya Koduri sir. We have Akhilesh sir here. We request one of the sirs to introduce Dr. Chaitanya Koduri sir.
Good morning everyone. Our next speaker is Dr. Venkat Krishna Chaitanya Koduri, consultant neurologist and clinical lead for stroke and neurointerventions. He holds a DM in neurology, a fellowship in interventional neurology and stroke, and the MRCP UK. His expertise lies in stroke management and neurointerventional procedures. Dr. Chaitanya has contributed extensively to neurological research with publications in leading journals including Nature Scientific Reports and the International Journal of Infectious Diseases. He also served as the co-site investigator for the Instruct Network. Among his accolades are the Best Poster Presentation Awards on basilar thrombectomy at 18th Delhi course. Please welcome Dr. Venkat Krishna Chaitanya Koduri.
Thank you, Dr. Akhilesh. Thank you, Dr. Lavanya, for having me here. Good afternoon, everybody. And the topic of discussion today is plaque to stroke management of intra and extracranial atherosclerosis. See, we need to have a different perspective about this intracranial and extracranial atherosclerotic disease contributes to more than 80% of vascular neurology. It is a subspecialty on its own, and we need to have a different perspective both in terms of biology, pathology, treatment, and outcomes of this particular variant of disease. So we'll have the perspective initially, vessel developmental biology, molecular pathobiology, and role of genetics in precision medicine, which is being extensively spoken about, advanced biomarkers, and evolution of stroke classification, role of advanced imaging, platelet function and pharmacogenomics, evolution of interventions in both extracranial and intracranial atherosclerotic disease. And we also have to understand that we need to be aware of cognitive impairment in stroke, which is often not looked into, and coronary artery disease and coexisting cerebrovascular disease, and the status of ICAD in India and generally across the world, future directions. So there is a paradigm shift in understanding of ICAD and ECAD over a period of time. From just luminal stenosis to we have evolved into plaque biology, vessel wall composition, the inflammatory component of the vessel, the genetic vulnerability that happens with the polygenic risk, the cognitive outcomes, and then treatment in terms of precision antiplatelet therapy. And then now we have low thresholds to do what vessel subtraction angiography so that we can understand hemodynamics in a better way. So why what the stenosis and what was thought earlier and what we are thinking now? The selection beyond stenosis. The endpoint now is not the percentage of stenosis, it's plaque biology plus hemodynamics. The risk assessment is based on vessel wall imaging and other biomarkers. Antiplatelet treatment is pharmacogenomic guided. Cognition plays a key role in understanding the outcome of the disease. Genetics and interventions earlier based on stenosis, now it is precisely selected on an individualized basis. So why? Because See, both internal carotid and external carotid, internal carotid system and the extracranial and intracranial vessels are fundamentally meant to serve different purpose. They are biologically, embryologically, phylogenetically entirely different structures. Because, extracranial vessels have this rich adventitia, robust elastic lamina. These are adapted for high flow hydrostatic stress. Whereas the intracranial vessels, though they have a lot of anatomical variation, sometimes we see anterior communicating artery, sometimes we don't see, sometimes we see posterior communicating artery, fetal PCA, etc. There is a significant anatomical variation in the circle of Willis. So, and there is a critical collateral reserve in intracranial circulation, either from ACA, MCA, MCA, PCA collaterals, or PCOM, or external carotid artery and internal carotid artery collaterals. So these are entirely different entities developed or evolved over a period of time to serve different biological purposes and supply different areas. So this is the easy image to understand. There is an ophthalmic orbital anastomosis. There is a clival anastomosis at the level of the cavernous sinus. There is a upper cervical anastomosis between the vertebro-basilar system, ascending pharyngeal and occipital artery. So if an artery is blocked, it doesn't mean that it's blocked only, but there is always a collateral circulation which can be there because of which the patient is surviving. So we need not open every vessel. So the basis for this comes when, in birds, in fishes, in amphibians, we don't have middle cerebral artery. Middle cerebral artery is a recently evolved structure. It is only 50,000 years old, phylogenetically, evolution-wise. So, because of the neocortical development, this middle cerebral artery got bigger and bigger from one of the branches of the striate arteries that has been there for a few millions of years. So this middle cerebral artery, which we think is very, very, very important, is the newest developed artery because of the neopallial development in human beings. And this forms the basis for the understanding of the different purpose of intracranial and extracranial vessels. So this is the development of dorsal and ventral aorta. So this is how the aorta evolves over a period of time. And this is the phylogenetic evaluation, how from amphibians to reptiles to fishes to birds. So it adds up a new artery for every, from amphibians to reptiles to birds, and then NCA is seen only after birds and in human beings. So there is one more important concept which we need to understand. There is a phylogenetic circle. So everything within the circle, inside the circle, is being supplied by the, inside the circle, is being supplied by the either striatal system or a choroidal system. This is basically the perforatory territory. Everything outside the system is being supplied by the major vessels or the large vessels. So how this behaves is entirely different from how this behaves. Though we have an intracranial atherosclerotic disease here, it is more likely to cause a perforative occlusion here, or than the possibility of it causing a hemodynamic stroke. So we need to understand that there are two purposes of these vessels as well. At the same time, so this territory, whatever that is there within this circle, anterior to this is supplied by the striatal vessels and posterior to this is supplied by the choroidal vessels. So it is as important to understand this anatomical basis. So this is on probably day 30 of the, this is probably on day 30 of the development. Here you don't see any middle cerebral artery. And then this is the plexiform network. This basilar artery is not yet formed, and then it is randomly supplied, and here it is not from below above, the blood supply is from above below. So these are originally, embryologically, phylogenetically, these are different vessels. One is mesodermal, one is mesoectodermal in origin, and then the purpose is to, for extracranial vessels is adapted for hydrostatic or mechanical stress, while for intracranial vessels there is more or a dense internal elastic lamina, and it is only communicative. It is less elastic when compared to extracranial vessels. Thereby, the pathology remains distinctly different. Here there is a positive or an exocentric remodeling. Here there is a constrictive remodeling, which leads to early luminal compromise. So ICAD, the dense internal elastic lamina barrier, delays smooth muscle migration. Stable fibrous plaques are formed. The failure mode is progressive stenosis or osteal occlusion, whereas extracranial diffuse elastin easy smooth muscle and macrophage inflammation. There is a large lipid core and a thin fibrous cap. The failure mode is explosive plaque rupture and thrombosis. So these are two different entities. So the same is okay. Now the molecular pathobiology. So there is a shear stress, there is LDL oxidation, there is recruitment of monocytes, macrophage transmigration, lipid core enlargement, fibrous cap thinning, and plaque rupture or erosion. So this is how formed. So in plaque microanatomy, we see a fibrous cap, a lipid core, a necrotic core, and calcification. Then we'll keep this. So the implications of this, when you start treating an intracranial atherosclerosis, it is more hemodynamic or perforator occlusion because it causes an earlier luminal failure, and lipid core size is more in an extracranial atherosclerotic disease. So ICAD is less amenable to lipid regression. And then the statin response, obviously when there is a lipid-rich necrotic core, ICAD responds more to this than an intracranial atherosclerotic disease. So these are the treatment implications in terms of the disease. So role of genetics in precision vascular medicine. So this LDL receptor, so we don't study about these receptor levels. These LDL receptor variants or PCSK9, which we can now treat with agoculimab, Repatha, which is available. And then we have a lot of upcoming drugs for lipoprotein A. There is a significant amount of genetics involved in ApoE4. RNF213 is more commonly seen in East Asian population, but still we have limited data in Indian subpopulation. This is of course standardized MPHFR mutation, and this CYP2C19 for hepatic cytochrome P450 clopidogrel activation, this polymorphism. So it is fairly common in Indian population as well. So lipoprotein, this is a forgotten culprit, I think. So we don't do this little a or lipoprotein A, which contributes to genetic risk of strokes. And then now we have phase 3 trials and upcoming drugs. Probably these are expected in another 1 or 2 years to reduce the lipoprotein A levels. So this we've spoken about RNF213 polymorphism. So we need more data. So the difference between RNF213 polymorphism and the regular intracranial atherosclerotic disease is, a lot of times we come across after this LDL is normal, lipoprotein A is normal, and it doesn't fit into the eccentric pattern of vessel wall imaging in MRI. If there is a concentric thickening and if there are no traditional risk factors, if the oxidized LDL is normal and if the lipoprotein is normal, this is one thing which we have to look into because it behaves differently to treatment. So again, advanced biomarkers, not LDL alone, we've just spoken about a lot of other biomarkers. And the simple test is HSCRP. This is a simple test which may give us information about inflammatory burden, but other things are not very practically convenient to do. So this is the spectrum of the biomarkers for lipids. It is ApoB, oxidized LDL, HSCRP, IL-6, lipoprotein PLA2, MPO, BCAM, ICAM, and NFL as a cognitive biomarker. This probably can be done, we can understand things in a better way. So the approach probably would be an imaging phenotype, biomarker signature. There should be a serial cognitive assessment in this kind of population. We have to assess the genomic and polygenic risk, and we also need to have a lower threshold to do an ESA so that we can understand hemodynamics in a better way, and also, which is more important or relevant in this time and age, is lifestyle and environmental trigger, because air pollution is directly labeled as a risk factor for stroke these days. And coming to evolution of stroke classification, earlier we were following, even now we are following post classification, but later on there is also ASCOD, which is atherothrombosis, small vessel disease, cardiac source, other determined dissection. So many of these cryptogenic strokes are now reconsidered as non-stenotic large artery disease with unstable vulnerable plaques, and HR high resolution vessel wall imaging reveals plaque enhancement, eccentric thickening, intraplaque hemorrhage, and arteries appearing normal on DSC or even CT angiography. So this shifts treatment from anticoagulation to aggressive antiplatelet or intensive LDL or lipoproteinuria lowering treatment strategies. Note on advanced imaging, what high resolution vessel wall imaging demonstrates, it shows plaque eccentricity in atherosclerosis and concentrically in vasculitis. If there is gadolinium enhancement, it means that there is active inflammation. It also shows fibrous cap integrity. It can show intraplaque hemorrhage, remodeling index, if there is any involvement of perforators, wall thickness and distribution. So ICAD, it's eccentric with eccentric and enhancement pattern can be there, positive or constrictive remodeling. So other markers for carotid plaque vulnerability on IMT to MRI, intimal medial thickness more than 1.5 millimeter. If there is a lipid-rich necrotic core more than 40% on MRI, it's considered as a vulnerable plaque. If you see an irregular plaque or ulceration, again it could potentially be a source of embolus irrespective of the stenosis. Intraplaque hemorrhage, which we see as a T1 and T2 bright hyperintensity when we do a blood black imaging, a thin fibrous cap of less than 65 micrometer. This is difficult to demonstrate even on MRI because the resolution and the thickness of the cuts is slightly difficult. This is difficult to demonstrate on MRI. And plaque enhancement, post-gadolinium neovascularization or active inflammation. So these are coming up a 70 MRI, PET MRI vascular inflammation, AI plaque quantification, computational flow dynamics, so we can also see wall shear stress mapping. So note on this pharmacogenomics, 30% of Southeast population are resistant to this. And what is important is now standardization is the problem because everybody is doing pharmacogenomics and giving the report to the doctor. The doctor finds it difficult to understand and write a drug. So this is one very important thing. It is not very expensive. It is practically available anywhere. It's 1/4 the cost of an MRI. So please try and incorporate this and so it gives a better understanding about the treatment and will be more confident. And then what is important is it's not only gain of function or not loss of function important, which allele is involved is one thing which is more important. And if we can correlate with the platelet aggregation test, it is all over because there are other mechanisms like a pharmacokinetic mechanisms which can interfere. A person who has HbA1c of 10.8 reacts differently when in a platelet aggregation study when compared to a person who has a well-controlled diabetes. And genetics to an extent are contributory, but there are also other factors which we need to look into. Probably if we can correlate the genetics with the platelet aggregation studies, we'll find better understanding about how to proceed further. So this is the trial data in chance 2 Taylor PCA and population genetics. This is based on the clinical trials. So if there is a polymorphism on star 1, star 2, star 1, star 3, or star 2, star 2, or star 2, star 3, and star 3, star 3, so then there is consideration to ticagrelor. If it is 117 or 11, clopidogrel is still acceptable. This is according to the trials. This is as per the trial data. So note on ECAD intervention. So we have help from carotid endarterectomy to transfemoral carotid artery stenting to now transcarotid aortic, carotid revascularization, direct carotid revascularization. So Earlier, endarterectomies has superior advantage. Meanwhile, there is an equipoise or equivocal evidence between carotid endarterectomy versus carotid artery stenting. Now again, we have advanced stents, advanced hardware. So both are equally good, but it has to be entirely individualized based on case to case. It has to be more complementary than competing. So modern ECAT software, now we have CGARD, layer stent with micromesh design so that it prevents further embolization. Casper and wall stent, these are like closed cell. So there are two kinds of stents. Ones are open cell design stents and ones are closed cell revision. Confirmation, if flexibility is more important, then you go for an open cell design stenting. If rigidity is what you want and if there is a critical stenosis, then you go for a closed cell design stent. So CGARD, Casper and wall stents are closed cell design stents, whereas other stents are open cell design stents. And there is a role of embolic protection devices. Once you do an angioplasty or once you deploy the stent, there is this cheese grating and then it can cause distal further embolization. So there is a role of embolic protection devices. There are 2-3 types of embolic protection devices. The first one, MOMO, is a proximal flow arrest device, whereas Spider-FX and EmboShield are distal embolic protection devices. It depends on the particular situation or case scenario which one to use and which one is better. Note on ICAT interventions, what we've learned from Sampras, because the selection was poor, there was over-dilatation of the vessel and then there was an injury to the perforated vessels. Visit after a couple of years also had to be terminated early because they used balloon expandable stents and which are abandoned. So lessons learned, patient selection is everything. Medical management first, stent only if it is truly refractory, and always try to use low radial force devices preferred for intracranial use, because fundamentally extracranial and intracranial vessels are entirely different. The elasticity is more in extracranial vessels. The elasticity is less in intracranial vessels. So if you deploy a stent, the recoil is going to be more. It is going to be more stiff. So you need to use a low radial force stent. So always very slow balloon dilatation, submaximal dilatation, low profile stenting. These are very important things for intracranial stenting. So modern hardware, we have now gateway or neurospeed. The advantage for this is you can use a single catheter both for balloon angioplasty and at the same time you don't have to take out and exchange or a long wire. You can deploy a stent. So that is the advantage, because more number of passes, more injury, more vessel volumization, more vessel injury, and then more stand of instant thrombosis or institute thrombosis. But gateways rarely available in India. We had a couple of opportunities to use that. Neurofoam Wingspan is the clinical trial based stent. It's standardized. Neurofoam Atlas is the safest because it is the most flexible and it's an open cell design, nitinol based, and then you can just retrieve out of the catheter. Enterprise again is a closed cell. Resolute Onyx is an off-label recommendation. You use it for cardiac stenting, but it is the least expensive of the lot, so you can practically use it for intracranial stenting as well. So cognitive impairment, which is often not looked into when we are dealing with strokes, but I think it's important that we incorporate cognitive assessment routinely, serially, sequentially to understand how it is progressing, because atherosclerotic plaques can cause chronic hypoperfusion, silent embolization, white matter hyperintensities and microinfarcts, and can cause vascular cognitive impairment or dementia. And these are the biomarkers which are practically maybe possible in near future, like NFL and GFAP, phosphorylated tau and A-beta 42 or 42, routinely incorporated in vascular neurology as well. So when there is a coexisting coronary artery disease, sit with your cardiologist. The cardiologist and neurologist should sit together, probably do a combined clinics or something, because we only see CHADS-VASc score and heart-split score. None of us, most of us at least, do not look at susceptibility weighted imaging. Dual antiplatelets, triple therapy, anticoagulation and antiplatelets. in a person who has a lot of microbleeds or cerebral amyloid angiopathy is going to have devastating outcomes with intracerebral hemorrhage. Also, one important thing is when there is carotid stenosis and planning for CABG, always try to do an ESC, understand hemodynamics and collaterals, and then it makes things less riskier. So global ICAT burden, when compared to global ICAT burden, India significantly contributes. There is a difference because in India, ICAT profile predominantly is more than ICAT is more common than ECAT, and that is younger age of onset by 10-15 years because of the high metabolic burden, like diabetes, central obesity, and hypertension, and elevated lipoproteinemia and ApoB are independent of dietary fat intake, and air pollution obviously 2.5 PM mediates vascular oxidative stress, and more growing on urban inflammatory lifestyle and deliberately I put it, urban inflammatory lifestyle and psychosocial stress burden. So it's time that we optimize this demographic advantage. RNF 2131 is one prospective scope. India-specific ICAT registry is the need of the population level. CYP2, C19 pharmacogenomic data is again need of the we have the potential to lead global phase 3 ICAT trials. So now the thinking has evolved from luminal stenosis to plaque biology, genomics. We have a lot of biomarkers which are practically possible this time and age. Vessel wall imaging, don't be hesitant to use vessel wall imaging. It's not very expensive. We need gadolinium contrast, which is very safe, but it gives a lot more information. Pharmacogenomics has to be universally acceptable. ECAD intervention only in selective cases. Stenosis, more than stenosis, also the regularity of the vessel is important. Now we have safe hardware to do interventions. ICAD intervention, the key is submaximal angioplasty, stated very slow angioplasty and low profile stenting. Cognition has to be incorporated in vascular neurology, and India should be the global ICAD epicenter, leading research in intracranial atherosclerotic disease. And before we conclude, I'll share a few cases. So ECAD long lesion, this is a calcific stenosis. So this is an ideal case for carotid endarterectomy than stenting because the lesion is long, it is more calcific. But the family was not willing for a general anesthesia surgery, so we had to stent it, and fortunately we could do it successfully without any deficit. So this is how a vulnerable plaque looks like. So you see the irregular plaque, when we do an angiography, this is how it looks like. So this vulnerable plaque with critical stenosis requires a closed cell design, stiff stent, than a flexible stent. So here the stenosis is short, okay, it is not very critical. Here we need an open cell design stent so that there is more flexibility and it doesn't deform the vessel. So this is another example. It actually, this carotid looks more or less normal when we did a TOF imaging, but this person suffered a right-sided stroke, a tiny infarct in this area. Okay, and we suspected a carotid disease obviously because intracranial vessels are also normal. So here we see we wanted to do a stenting, but when we did a CT angio, see, look at the plaque. This is an ugly looking plaque in the aorta, so we had to stay out of it. And in CT angio, there is a mixed calcific and ugly looking plaque ready to embolize. So we stayed out of it and we gave it to our vascular colleagues, vascular surgeons, and they did it, and the patient did not have any problem later on. So it is always important to assess the arch and the structure and the vulnerability, if there is any vulnerable plaque, before going it for any intervention. So this is a dissection. So this is the lipid-rich necrotic plaque, which is hyperintense. Okay, this happens to be a young person. So initially he suffered a stroke. We did an angiogram, and then we found this. We did not want to intervene because he had a large stroke for the risk of hemorrhagic transformation intracranially. We followed him with medications for almost a month. So now it formed a pseudoaneurysm. It is almost constricting or flow limiting. So then we went ahead for stenting. Here we used a closed cell design CGAT stent with double reinforcement. And then because a lot of area is involved, right from here to here, we had to use 2 stents right from here to here and here to here. This is the landing of the second stent. So ICAT stenting. So now what is important, as we discussed about hemodynamics, look at this area. This area is underperfused. He came only with TIA, he did not even suffer a stroke, but this area is underperfused. So this becomes an indication for stenting in this person. So this is post-stenting. Extra. So the same area is being perfused appropriately post-stenting. So this is a terminal ICS stenting. So we used Credo stent for this. So again, one more case. The same case. So this is post-stenting 6 months IVDSA. This is the stent thread, and then this vessel looks patent. So ICAT presenting with TIA. So this is a cavernous ICS stenosis. This patient is a retropositive patient on ART. This patient did not want a procedure. So we assessed the collaterals. So this side AC is being entirely taken care of by the contralateral internal carotid artery, and there is no perfusion deficit in this area. So we withheld on medical management, and 2 years from the DSC, the patient did not have any TIA or a stroke. Again, one more intracranial atherosclerotic disease. So this is a terminal M1 MCL. Before the bifurcation, there is a critical stenosis. This patient underwent CABG 6 months before the onset of TIA. She did not suffer a stroke but had a TIA, and she was very particular that she did not want a procedure. And her blood pressure was always 70-80. Whatever we do, her blood pressure was not improving, and she did not want a stenting. So I started her on Medodrin so that her blood pressure will increase. And she never had a transient ischemic attack. It has been almost 18 months, she never had any transient ischemic attack now. This is her angiogram because it is only hemodynamic, because otherwise there is only a focal stenosis here. Otherwise, all the area is being perfused. So increase her blood pressure and she is okay. And this is, to your left is the current scan. To the left is the old scan. See, the stenosis did not change in spite of being on dual antiplatelets because of her coronary issue also. These two scans are, this is 2026 April, this is I think January or February 2025. In spite of using dual antiplatelets for 1 year with appropriate risk factor control, this morphologically did not change. And what is more interesting is, see, still there is contrast enhancement here. Still there is an eccentric contrast enhancement here. So dual antiplatelets and statins did not change anything in her. So this is again another case. So we had to continue medical management with no other option. So he himself volunteered to do 3 scans. This is the first CT angio. This is 2025 November, 2025 November. There is a focal stenosis. This is again this is again in November 2025. This is I think 9 months later. This is I think 12 months later. He volunteered to get an MRI done. Nothing changed. So this actually, the stenosis is same or even worse. After 1 year of antiplatelets were not given because of the stroke, but antiplatelets were given because of the coexisting coronary artery disease. He underwent a PTCA. So perforator stroke, this is what we are exactly thinking. So this is a proximal M1 stenosis, and you see a microbleed in the same area. So this is an ICAT causing a perforator stroke. Again, one more ICAT presented with transient ischemic attack, medical management because of good collaterals, this looks like near total stenosis because he had right ICA occlusion. So left ICA is supplying both the anterior cerebral arteries. So he had right ACA and left-sided hemodynamic stroke. It looks critically stenosed, but when you see collaterals, see there is a pecon which is supplying here, there is a pecon which is supplying all this area, and then this is the right vertebral ostial stenosis, but a late angiogram, here you don't see the ICA, you see only vertebral artery. So the vertebral is giving occipital and cervical collaterals. Those are filling the external carotid artery. From there, internal carotid artery is being filled. So because of the collaterals, we left him alone and he is asymptomatic now. So sometimes we have to take that call and do a rescue stenting during acute stroke. This is one of the acute strokes who progressed after thrombolizing. So we had to do a couple of angioplasties and then finally had to, I think we used the neurofoam atlas in this. So this is the second angioplasty and this is the stent deployment. This is the post-angio. This is the final image. So this is a rescue angioplasty. He is a 29-year-old gentleman, MTHFR mutation positive. Presented with stroke. Obviously we expect an embolic stroke and just I went ahead with suction thrombectomy. So because this like a meniscus looks like an embolic stroke, but then after 2 times opening it is again progressively closing. Then I thought 29 years I did not want to stent him. I did a submaximal angioplasty and left it like that. 1 year later it is still like that in spite of being on antibiotics. He's obviously asymptomatic, but then 1 year later he got a scan somewhere and he sent me this image. So it's still like that, but he's asymptomatic. So I did not stent because he had to be on dual antiplatelets for quite some time. We also thrombolized, and stenting is always risky in acute situation. So there is one more case, ICAD and ECAD, coexisting ECAD. The dilemma is what to treat first. So he presented with this stroke. Looks like an M2 trunk occlusion, but I did not want to intervene because it clearly looks like an ICAD, and we have to do a rescue stenting if you open it at the time. This is a very well preserved patient, so maintained hemodynamics. He also happens to have right ICA occlusion, so could be hemodynamic is what I thought. He also had a right vertebral ostial stenosis of around 50%. Left vertebral is completely occluded, but left vertebral is being reconstituted by this cervical branches, and then this is the V2 which is being reconstituted. This is the critical lesion of the left proximal ICA, ulcerated. So the pathology here I thought was more of hemodynamic than atheroembolic, so I did not want to do any acute intervention to prevent complications. So we loaded him with ticagrelor. We continued ticagrelor for over a month, and then we stented on the left side. Now he's completely all right. Interestingly, his cognition has also improved over 1 month, probably because of the improvement in flow. So this is his final image. So atherosclerosis is no longer merely a stenotic disease. The vessel wall is the therapeutic target. And vessel wall biology, plaque microanatomy, hemodynamic reserve matter more than luminal narrowing. Genetics, biomarkers, platelet phenotyping are fundamentally reshaping our stroke prevention. Do a DSA if you are in doubt. Have a very low threshold for a DSA. DSA is almost like a CT angio. We use less contrast in DSA than in a CT angio. So we have better carotid stents, embolic protection devices. So carotid revascularization is more safer these days. The thumb rule is submaximal angioplasty in intracranial atherosclerotic disease, and with modern intracranial devices, we are redefining ICAD interventions. The future endpoint is not simply preventing stroke; it is preserving cognition and brain health as well. Thank you for your time.
evolution, pharmacological interventions, and other interventions in stroke and other neurological diseases. And actually, I had the fortune of working with one Professor V.R. Rao, who was a pioneer in neurointervention radiology, where we used to do a couple of brain scans when he used to do temporary balloon occlusions, and also when he was doing coil interventions as well. And this was a nice presentation.
So, are you regularly practicing testing of lipoprotein profiles in symptomatic strokes?
If LDL is normal, if there are no traditional risk factors, if stroke, I believe, is always cause more than always an effect more than a cause. We have to hunt for the cause. If you don't find the cause, we are mostly used to label it as a cryptogenic stroke or an embolic stroke of undetermined source. So in such cases, I would rather spend my resources on lipoproteinemia or oxidized LDL than do a 1 month counter. So it depends. If we don't find the cause, because these are expensive investigations we cannot do routinely. But if we don't find the cause, yes, oxidized LDL, lipoproteinemia, lipoprotein K later.
Elevated profiles, how are you managing?
I'm using this Repatha. Repatha is there, it's not very effective. Now they've withdrawn this 140 milligrams of Repatha from the market in India. Now only 420 milligrams is available. It does some modest reduction in lipoprotein. We have to wait for this PCSK9 inhibitors.
Yeah, the PCSK9 inhibitors list. We have few molecules right now. And how often are you regularly following up with these investigations? Like in elevated cases, how frequently are you supposed to?
Now we have only 420. 420 is once in 6 weeks dose. So we give 2 doses and repeating after 12 weeks. I only have a handful of cases because it's finally a very expensive molecule.
So in cases of non-critical carotid stenosis, coming to the block characteristic, what are the most important block characteristics that you have to keep in mind to follow up the case to predict the risk of strokes?
So one thing is irregular surface. If you have an irregular surface, thin fibrous plaque, lipid-rich necrotic core, these three, even if there is a 40% stenosis, if there is a 40% stenosis, there is an indication. I have not personally done symptomatic non-stenotic carotid disease, but this is as per the literature. There is a clear entity of whenever we label it, before labeling it as ESIS or something, we have to rule out something called as symptomatic non-stenotic carotid disease. And now we have this plaque imaging which will clearly demonstrate this lipid-rich necrotic core or fibrous cap or ulcerated plaque. So I think that has to be liberally done to understand it. But personally, I have not done any cases of symptomatic non-stenotic carotid disease cases.
Any best imaging modality to follow up these cases? What is it?
T1 blood bag imaging. T1 blood bag imaging gives excellent resolution.
Thank you.
If any patient comes in after 24 hours, as per diffuse dawn and diffuse trial, so if the artery is completely occluded, then how to manage?
When we assess the collaterals and perfusion, sir, if perfusion is still there, then I think, again, it depends if it is, if the patient is preserved. If you suspect an intracranial atherosclerotic disease, it is always better to manage conservatively, because if you open an ICAD, you are going to end up in stenting. And once you end up in stenting, your antiplatelets, your hemorrhagic transformation, all these things are entirely different. So if you suspect an embolic stroke, obviously the patient will not have collaterals. They'll have massive deficit. Then you go ahead and open up. And it's primarily dependent on perfusion scan.
Any questions from David?
Good afternoon, sir. Yes. Good afternoon, sir. It was a very long, sir. I am Dr. K. Amrita, Associate Professor, Kamini Medical College, sir. My question is with respect to the test that is high resolution vessel wall imaging, So at what point of time after, or is it before test or after interventional neurological procedure test, and how effective it is in assessing the prognosis of the disease?
See, when you're planning an intervention, you don't need high resolution visual imaging. If I do a DSA, I get all the information I get from a DSA.
Okay.
Because the pattern of stenosis will give us a lot of information.
Okay.
Only if we are uncertain about the diagnosis, because see, it needs a 3-test MRI. It is a HRVW, it needs a 3-test MRI. First we need to have a 3-test MRI. And then it is adding up to the cost. Whenever we are adding up something to the cost, unless we have a specific indication, if I can see intracranial atherosclerotic diseases on basic time of flight imaging, I don't have to do a vessel wall imaging. I can see that off imaging and I can see that. If you are not certain about a diagnosis, if you see a young patient who has a stroke and suspected ICAD with no other risk factors, then we have to differentiate it between a vasculitis and an intracranial atherosclerotic disease. Then probably vessel wall imaging helps. But it's not a routine investigation, but it's in selective cases it gives a lot more information.
Okay. Next question, sir. It's like you mentioned about intracranial vasculature zones, outside and inside zones. No, sir. Out of those two zones, which zone is associated with higher mortality? Like, is there any study suggesting that this particular zone is?
No, there are no studies related to that.
Yes.
There are no studies related to that, but our understanding of hemorrhagic transformation has grown leaps and bounds with this phylogenetic boundary.
Okay.
Because, see, in this phylogenetic boundary, whatever that is there inside are supplied by striatal or choroidal vessels. Whatever that is there outside are supplied by the cortical vessels, neopallial vessels.
Yes.
But the venous drainage is not like that.
Okay.
The venous drainage is not like that. The venous drainage, the cortical veins empty only the outward 1/3 of the cortical sinuses. And then more of the venous drainage in the white matter is by medullary veins.
Okay.
If it's a white matter problem, and if there is a compromised medullary venous drainage, we are more likely to suffer hemorrhagic transformation.
Yes.
So I look at a delayed phase. Before I do an intervention, your DSA should always look at the delayed venous phase. See, if the outlet is blocked, or if the outlet is genetically determined not to be emptying the way it should be emptying that area, automatically you open the inlet, your outlet is not good, automatically there is a hemorrhagic transformation. So it gives us a better understanding about the complications rather than complications or deciding on treatment rather than one size fits all kind of thing.
Okay. Yes, sir. So long you've been your interventional neurologist. So is there any case where you felt that we should not go for any intervention and conservative management is the only?
I told you 4 or 5 cases. No, I get recurrent, I get TAs presenting with strokes. A lot of times we take them for procedure, and on table we assess the angiogram and we avoid the procedure.
Okay.
See, it is better to avoid the procedure.
Yes.
You should always look for a cause, look for a reason to avoid the procedure. Because doing is very easy, but case selection becomes more difficult. And then the best thing to avoid complication is not do the procedure.
Yes.
So automatically.
Yes. Sir, one more gross question, sir. Sorry, I just want to ask one more gross question. What are the various? Are there any absolute contraindications for interventional neurologist procedure? Absolute contraindications, like even after stroke. Absolute contraindications for
No, there is no contraindication. You can do in pregnancy, you can do at 90, you can do at 20. Now there is data that you can do in pediatric people also.
Okay.
So there is no contraindication.
So even in elderly, it is like positive outcome has been.
Elderly it is easier because you don't see 90-year-old person coming, you see 100 microbleeds, you don't want to thrombolize them.
Okay.
Then it's easier to. But they have a complex arch, calcified vessels. Intervention also becomes very difficult.
Yes.
That is what. See, you do a DSA. If collaterals are better, if the patient is preserved, then try to avoid the procedure.
One last question, Dr. Kaur. Anything you would like to add? excellent lecture. That's what you have really covered all the dimensions. And as we were discussing, I think genetics will have a great role to play because whatever our guidelines are, they are all based on cohorts. This is that aspirin should be given. It's a decision based on the study in cohorts of 40,000 people. But patients don't come to us as cohorts. They come individually. So therefore, we have to, I think it will happen in the next 5-10 years, which patient is prone to bleed, which patient is prone to infarct, and I think that is the future. But your talk was just excellent, super. Thank you. Thank you.
Thank you, sir, for the comprehensive talk.
I request the chairpersons to hand over the memento to Dr. Chaitanya, sir.
Zoom లేదా నీ కెమెరా ఫ్లాష్ ఉంది జూమ్ ఉంది జూమ్ లాంటివి ఉండవు
Sir, look. Sir, close. Sir, close. Close. Sir, look. Up.
I request Dr. Ratnasari, sir, to hand over the token of appreciation to the chairpersons.
Sir.
As the past president of Indian Stroke Association and Indian Academy of Neurology and was awarded the Telangana State Teacher Award. Please join me in welcoming Dr. Subhash.
Thank you, Dr. Jalal. It's really nice to see
colleagues who were our students now cheering the session.
Honor and privilege. He is my mentor and teacher.
Yeah,
Honor and privilege.
it's a joy. It's a joy to see all of you. As a matter of fact, when Jalil said he's a jovial person, everybody in the house smiled. So, you know, joviality is infectious. It spreads immediately. People don't want serious people. You know, Lakshmi, it's really hats off to you that on a Sunday, up to this time the hall is full. And stroke is something which everybody should know. Whether you are a urologist or a clerk or anything, you have to know stroke, because it can happen to any one of us or our relatives at any time. And the time is the premium. You cannot waste. Stroke is not a disease where you can think to which doctor I will go. You have to immediately take action. So let me take you to University of Maryland, Baltimore, where I did my fellowship in 94 to 96. This was the top stroke center in Maryland, USA. And this is me, how I look like then. And this was my mentor. And I came to know in this place, these two giants, they are the stroke gurus of our time. Whatever you are knowing about stroke today, whatever is the grammar of stroke, like lacunar stroke, carotid artery disease, carotid endarterectomy, cardioembolism, all these terminologies have been given by this gentleman whose name is Miller Fisher. Miller Fisher is a stroke physician, but surprisingly he is the same Miller Fisher who has given us Miller Fisher syndrome also, which looks like a GB syndrome. So you know they had a universality of knowledge, right? And this is Miller Fisher's student, his name is Louis Kaplan on the left side, and Louis Kaplan is the surviving stroke giant in this country. He's now 87 years old, and but even now he's active and he keeps on coming to India, and the people who are in urology and stroke know him very well. And Louis Kaplan, as he was a resident of Miller Fisher, the elder man, he wrote a paper in 1982 in Archives. It was called Fisher's Rules. 17 rules of Miller Fisher. Means how you should see a patient, how you should listen to patient, how you make a diagnosis, so on and so forth. And about 25 years after he published Fisher's Rule, he wrote one more article. It was called Kaplan-Fisher Rules. So Fisher's Rules continued, but he added some more rules to that. And last year I met him in Mumbai. So I asked him, Dr. Kaplan, why do you add to? He said, you see, because in these times, in these last 20 years, much more knowledge has developed. And I have developed much more experience. So therefore I have added further to the rules. And I think you should see that it will be available in the net, Kaplan-Fisher Rules, in which he tells you everything about stroke and how to diagnose, how to suspect, how to treat anything. So therefore, after taking inspiration from him, I thought I will also add a little bit to those rules. And I thought that I'll call Kaplan and Fisher Rules. But I didn't do that, because I know my stature is not like them. So I called them 15 Rules of Ischemic Stroke Management. Do's and don'ts. Rule 1. And you know, these rules which I am taking, they are based on my personal experience. The fingers I have burned, the fingers my colleagues have burned, and from the literature. So remember these rules. Consider every sudden deficit as a potential stroke or TIA. This is the first diagnosis. If in this hall somebody is thinking, I'm having some difficulty in talking, it can be a stroke. Whether it is or not, but consider it. Because you cannot afford to miss it. Don't send him home. He may come to emergency, don't send him home. Make him stay there. Do his ECG, do his echo, do his Doppler, even though he is normal. Spend some time, because once he does these tests, at least 2-3 hours will pass in that. And that is the time when he is in the hospital, he is being observed. And in these patients who are having fleeting deficits, doctor, yesterday I was in the car, suddenly I found that my hand has become a little uneasy. Now I'm all right, I'm perfect. Don't leave him. He is the patient who may come after 2 days in your casualty and you realize that he's a massive stroke and he had come to us 2 days back. And we reassured him and told him go away. I'm sure if you keep a hand on your heart, those who are physicians, they must have done this error. So any transient thing can be a stroke. And even if it is not, consider it, because you can't afford to miss it. and do their MRI. And MRI is better than CT. In a normal stroke, you can do CT scan. CT scan is okay. But when it's a TIA, MRI is much better than CT scan because it can pick up some markers, radiological markers, which will make you feel that yes, it was probably a vascular event. Now, these are my own patients whom I have seen. They have come to me with sudden confusion for 5 minutes and then they were normal. Diplopia for 2 seconds. You know, normally you would, 10 years back I would tell them nothing, don't worry, go to ophthalmologist. Transient numbness, brief unsteadiness. And there are many such, and they are called non-consensus TIAs. Forget about localization and MCA territory and ICM. No, any neurological symptom, even if it's transitory, is a potential TIA. And in many of these, when you will do an MRI diffusion rated, you will see this small dot which you are seeing here. This diffusion dot. This is a small clot which has gone to the brain, which your CT scan will not show. So this is rule 1, that any transient deficit is a stroke. It may not be a stroke, it doesn't matter, but you don't miss it, you do his profile. And if you are still in doubt, put him on some blood therapy. Rule 2, do focused neurological and general examination. It should be focused. Gone are the days when a neurologist used to do a neurological examination for half an hour. He used to get his bag, and then he used to get his hammer, and then he used to do higher mental functions, and rest of the patients in the ward used to observe him as if he's some magician or something. Those days are gone. Right? Do a quick, focused, mindful neurological examination. Check quickly his pulse, heart, temperature, fundus. Right? Pulse because you will pick up atrial fibrillation like that. Heart because you will pick up mitral stenosis from that. Temperature because this may be infective endocarditis, where all the blood thinners are contraindicated. And fundus because this may be a cortical sinus venous thrombosis. Quickly it has to be done, mechanically, like a robot, we have to do this. Check his speech, eye movements, visual fields. Just by talking to him, look here, look there. No thinking, mechanically you have to do this. Check his facial asymmetry, uvula and tongue. So good to know about his palatal function, about his brainstem. Make him walk on the line, do pronator test. Never examine a patient in the wheelchair, it's always deceptive. The wheelchair patient says, I'm all right. No, ask him get up and walk, show me how you walk. And you will pick up unsteadiness there. And it should not take more than 3 minutes. It should not take more than 3 minutes. This is the average time in which your neurological examination should be complete, and based on this information, you will easily say, is it a left hemispherical stroke? Is it a right hemispherical stroke? Is it a brainstem stroke? Or is it a lateral stroke? Because, you will get those findings. And general examination, well, have it just quick, cursory look. This is one of my patients, and you can see this molluscum contagiosum. These are angiokeratoma on his skin, and this was a patient of Fabry's disease. Very rarely you will see it. But quick general examination and a focused examination, and you will be able to make a clinical diagnosis. And these days, what's important is to don't miss aphasia, visual field deficits, because they are the sign of large artery disease. And large artery disease is for mechanical thrombectomy. And this you have to clinically only do, right? Rule 3, if the patient is drowsy, don't check his throat or anything, just trust your eyes to him if he is drowsy. But even if he is alert, make sure can he sip a gulp of water or not. Because in our culture, there's a tendency to put things into his mouth. Ganga jal or orange juice or something like that. The family will come, the cousin will come. No. The moment he comes, first check yourself. Can he swallow? If he can swallow, only then you give him. Because one of the causes of mortality in strokes is aspiration pneumonia. Many times, from the time the patient is brought from the hospital, from the home to the hospital, in the ambulance and in the home, he's fed so many things. And then he gets aspiration. Rule 4, don't lower blood pressure till thrombolysis is decided. So they used to give previously the nimidipine, sublingual nifedipine, which would precipitously drop the blood pressure and the patient would get a hemiplegia. Okay. So till you have decided that I am not thrombolizing this patient, you don't take that decision. If you are thrombolizing the patient, then you have to lower the BP. Then you have to bring it to 180 by 105. But if you are not thrombolizing the patient, don't touch his blood pressure. for next 2 days because it reduces the perfusion, it increases the deficits. Of course, if the patient is having a myocardial infarction at the same time, acute renal failure, aortic dissection, then you have to lower. But that's very unusual. Most of the strokes will not have that. So in majority of strokes, don't touch the blood pressure for next 2 days unless you are thrombolizing, in which case you will lower it with labetalol. And never give aspirin before doing CT or MRI. This is a tendency, particularly by general physician. You know, copy it from the cardiologist. You know, move it down to thoda sa. Give him 1 tablet of aspirin. At least jab tak hospital pahunchega till that. And no, that can be done by cardiologists because cardiologists don't get heart hemorrhage, right? We get brain hemorrhage. So therefore, this is an absolute rule. Never, whatever is the pressure, no way, till at least a CT scan has been done and this has been ruled out. And now this is an acute stroke and you do a CT scan. CT scan invariably will be normal. In the first 3, 4, 5, 6 hours, CT scan is normal and that's why you can thrombolize these patients. Your main job is to rule out a brain hemorrhage. And there's no brain hemorrhage on the right side scan, so you can give it. But on the left side, you can see that there's a massive hypodensity. So whenever there is a hypodensity, which is more than 1/3 of the MCA, it should not be thrombolized. This is massive hypodensity. Here you cannot thrombolize at all. But even if it was half its size, as per the latest guidelines of 2026, thrombolysis should not be done because they will bleed. And then, suppose if you have done MRI, learn to look at the MRI yourself. If doubt, go to the radiologist, check with him. Because MRI has to be, there are many sequences of MRI. You have to look at each sequence. Now, look at this patient. On the right side, you can see, that there is a small diffusion hyperintensity, right? Now, this looks like an infarct. This is a real patient, right? We didn't thrombolize him. We were about to thrombolize him in the night, but probably fortunately he didn't have money or something. We didn't thrombolize. But next day when I came for the round, I'm looking at the GRE image. That's actually a bleed. So, acute stroke, whether hemorrhage or whether infarct, they look same. They are diffusion hyperintensity. So therefore, you have to look at both sequences. When you look at the GRE also, there will be a black area there that you can see there. So always we should learn to look at all the sequences of MRI before thrombolizing these patients. Rule number 6. Thrombolysis has to be done in patients who are having stroke clinically. Clinical stroke is a requirement. Not radiological stroke. Radiology is not required. Radiology is required only to rule out brain hemorrhage. If you look at the criteria, it says stroke by clinical assessment. So any acute hemiplegia. CT scan will be normal anyway. But even 5% of the MRIs are also normal in the acute stroke. Particularly if they are small brainstem strokes. So if a patient comes with a sudden dysarthria and hemiparesis, and MRI is completely normal, don't worry about him, thrombolize him also. And after 2 days, 3 days, you may get an infarct. So therefore, it has to be stroke clinically. Now there is a chance you may commit a mistake. It may be a stroke mimic. It may be a functional hemiplegia, and the guidelines clearly say don't worry about it. You can thrombolize even the mimics, also the chance, but I'm not encouraging you to thrombolize the mimics. You still have to be sure. But suppose by chance you are not making a mind and you don't know is it stroke or not, should I thrombolize? Go for it. Do it. The chances of bleeding in a mimic of stroke are extremely low. And there are papers and papers of that. Okay. And of course, conventional treatment of thrombolysis is up to 4.5 hours, but now that window is extended, which I will tell you in a short while. Before you thrombolize, ask the patient, is he on ticagrelor? Because these days many patients are on ticagrelor. Cardiologists have completely left clopidogrel. They have just given it up in the dustbin. It has been completely taken over by the ticagrelor. Now ticagrelor has got a higher chance of bleed after you give them IV thrombolysis. And guidelines are silent about it, tightly, because nobody knows. So therefore, if a patient is a cardiology patient and he is on ticagrelor and he comes with acute stroke, it is not a contraindication, but it is a high alert. You have to inform the attendants that look, your patient is on aspirin and ticagrelor, he may bleed. but we can still do it. But you have to guide the patient. Finally, patient cannot become a doctor in 5 minutes and you tell him these are the choices and you decide what you have to do, or will decide. If we can't decide after 30 years, how can he decide in 30 seconds? But we have to inform him and guide him. And the way I have done it for myself is, if it's a non-disabling stroke on taking a lot, I will not traumatize. I will not take that chance. But if it's a disabling stroke, I will take the risk. After informing him that, look, in your case, chance of bleed is a little high, but I am still taking that because otherwise also you are disabled. Ask about anti-amyloid therapy. Anti-amyloid therapy for Alzheimer's dementia has arrived in Hyderabad. That representative is coming to me. Every day he is coming. Sir, have you identified some patients? Sir, have you identified some patients? Now, this is a dangerous therapy. Anti-dementia therapy, it's anti-amyloid therapy. It is costing about 60 lakhs per year. At discount, they are giving 30 lakhs now. I'm going by 30 lakhs and the city of Hyderabad, I think enough people are there to take it. Right? So I used to think nobody will afford it. But I think there will be. So there, and I know there are still some people, they are getting it from foreign countries and all, they are taking. Ask whether he is on anti-amyloid therapy. Because anti-amyloid therapy can cause either edema or hemorrhage in the brain. That's called ARIA, A-R-I-A, amyloid-related inflammatory angiopathy. So ask him, is he by any chance, and these days of international travel, people come here from America or US or Sweden and suddenly get a stroke here. And for all you know, he may be on the anti-amyloid therapy. So check that. Because in them it's a relative contraindication. You will tell them that there is a high chance of bleeding if you are on anti-amyloid therapy. Ask whether the patient is on oral anticoagulant plus aspirin. Another favorite recipe of cardiologists. They give aspirin, along with that they give ecosprin. These fellows are at very high risk. Now, none of them are absolute contraindications, but they are relative contraindications because of high risk of bleed. So in them, if you have a block of the major artery, it is better to go for mechanical thrombectomy. If not, you have to inform them. And this is the example of the ARIA-H. You can see these small microbleeds in these patients. Rule number 8, and this is a good rule, don't exclude patients from IV thrombolysis based only on age. Because the original criteria were keeping 80 years, 17 to 80 years. And you don't have to be less than 80 and you don't have to be more than 80. But I think those criteria are very old now. I have thrombolized myself, a person who is 98 years old. And she was mother of a. Some of these patients are generally VIPs only. Either mother of your director or some minister or something like that. Very high situations for patient as well as the doctor. Right? So, but I have thrombolized. 98, God was great, the patient recovered completely. 98 age. But in the literature, I have found that patients have been thrombolized at 102, 103, 104. So don't worry. Lower limit also has been relaxed as per 2026. They are saying anybody from the age of 28 days can be thrombolized. But if it's 26 days, then you can't thrombolize him. But 28 days you can thrombolize. And that's a nice thing to know. The second thing is that don't exclude any patient who has got cancer or who has got dementia. Provided there is a reasonable life expectancy of 6 months. So if the patient is having a dementia and he has all the comorbidities and his creatinine is 13, and he's almost dying, then no need to thrombolize him. Right? Similarly, if the patient has cancer and he has metastasized everywhere and there are all complications, then probably we should not thrombolize him. But if these patients are stable and the doctor feels that they can live for more than 6 months, they live for 1 year, there are formula, people can tell you what is your life expectancy. Then this option should be given to patient. I have seen in our culture, in our Indian culture, families want to keep the patient there. If it is their mother or father or uncle, even if he is disabled, they want to keep. They want the body. This quality of life is a Western concept. Is he eating breakfast himself? Is he brushing teeth and all? I think in India, people want the body only, even if he is demented. And they do his seva and so therefore we have to inform them that we can thrombolize him. It's no longer a contraindication. It used to be a contraindication. Patient with dementia, patient with cancer, no. Now it is, if there is a life expectancy and if the family is interested, we should go ahead. Rule number 9, and this is an important rule, and it has taken away a lot of stress from our life. It's clearly said that do not thrombolize a non-disabling stroke. So, and these are also the stress-giving patients, and generally VIPs. The patient will come and he'll say, my hand has become a little clumsy. But I can do everything, but hand has become a little clumsy. My foot is, I'm feeling little numbness on one side of the body. Now, do you thrombolize them or not? Right? And so an important trial called Aramis trial has been, the results came last year, they have found that the results are as good as thrombolysis with double antiplatelets, with much less bleeding. So now this matter is solved forever. That if it's a non-disabling, now what is the definition of non-disabling? So they have given criteria also. Mild aphasia, means he can talk but few words he is missing. Just facial droop. Mild hand weakness, particularly if it's a left hand weakness. Mild sensory loss. So in other words, basically if the patient is having a minimal deficit with which he can live, it's not a don't treat him, but double antiplatelets are as effective as thrombolysis without the risk of bleeding. This we have to tell us. And thrombolysis. But in this there is one more thing. As there are many societies, and as per the European society, this is the European problem, that these minor strokes, if there is an associated block of the responsible artery, which means patient is having a right hemiparesia, and he is having a right hemiparesis, very minimal, but the appropriate artery is blocked, then you may give them IV thrombolysis, because there is a risk that blocked artery may further extend the deficit. But as a general rule, minor strokes, minimum strokes, you can go ahead with double antiplatelets and no need of giving thrombolysis. Rule 10, tenecteplase is a clear winner now compared to the tissue plasmalogen activator or TPA. This is a thrombolytic agent, as you know, and the advantage of tenecteplase is efficacy-wise it is same, but it is more fibrin specific, less chances of bleeding, and you give it in a bolus. You don't have to wait for 1 hour and all that thing. So you give it a bolus. So and clearly all the studies all over the world have shown that it is a clear winner. So tenecteplase, no doubt about it. But if you are doing extended thrombolysis means that the patient has crossed the window of 4.5 hours, then you should give alteplase or TPA. Now why? Why? What is the reason? The reason is only one, that those trials were done on TPA. They were done on alteplase. Otherwise there is no other reason. That trial, that was called extend trial. In the extend trial they gave thrombolysis up to 9 hours. The chemical which they used was the alteplase. So that is why. But if it's not available, you can use tenecteplase also. But it is generally because some attendants are nitpickers and all, particularly if their relations are in USA and all, why you gave this and why you. So this knowledge is important. That once you cross 4.5, you may give another thrombolytic. But important, and these days you can now thrombolyze up to 24 hours also. And this has come in guidelines which I will show you. But you have to be very careful when you cross 4.5 hours of Lakshman Rekha. You have to be very careful. You cannot do that till you have done a study called perfusion MRI. Up to 4.5 hours you don't need anything. Up to 4.5 hours you need only a CT scan. Nothing exotic. But after 4.5 hours, if you have to give IV thrombolysis, then you need a study called perfusion MRI. Now what is perfusion MRI? This is the example of the perfusion MRI. In this there are some parameters which we have to understand and which we have to know how to detect them. Now you are seeing on the right side this pink area. This pink area is the area where cerebral blood flow is less than 30% of what it should be. Cerebral blood flow should be measured. And if it is less than 30% of what it should be, that means it is dead. So this pink area is dead, right? And this is called, this is the infarct. This pink area is the infarct, because the cerebral blood flow is less than 30%. Now go to the other side of the picture. You are seeing that green area. That green area. That green area is where blood is coming with a slow speed. The speed of the flow, the velocity of the blood flow is less, right? And it is called T max. T max means where it is taking more than 6 seconds for blood to reach there. More than, the computer measures it all. And that means when it's taking more than 6 seconds, some of it is dead also. But whole of it may not be dead. Because whatever is dead is the pink. And wherever there is this green area, that area is dysfunctional. Some of it is dead, but some of it is dysfunctional. Now, how much is dysfunctional and how much is dead is known by the ratio of these two. So that green area is completely dysfunctional. And out of the dysfunctional area, the pink area is the dead area. So you see a ratio of that. That's called a mismatch ratio. Mismatch ratio. And you can see here, this is the mismatch ratio. This red area is the dead area. But surrounding the dead area is some area which is not dead yet. But it is dysfunctional. And as per our criteria, if it is more than 1.2, right? So if this is the 100 ml is the, if the 100 ml is the volume of the red area, and if the area of the green area is 120, you can go ahead. And the more the mismatch ratio, the better is the viability of the brain. So some people have a, when they come to you, they have a mismatch ratio of 10. They are excellent people to thrombolize, right? And it all depends on how good collaterals they have. If they have got good collaterals, then anyway, if they have got good collaterals, then they will survive. For a lot of time, that brain will remain viable. So remember, this we have to, any patient who comes after comes after 4.5 hours, and if we want to thrombolize him, we need to have this perfusion scan. And in that, we have to see how much is dysfunctional, how much is dead, which we will come to know by the ratio or the mismatch ratio. And these are the 2026 guidelines, latest guidelines, and it clearly says it's a 2A recommendation, which is a strong recommendation, that you can thrombolize a patient from 4.5 to only admitted 2 days back, and you can see there's a small infarct. There's a very small infarct. So just next day after having thrombolysis, you can start him on DOAX. So DOAX is not a problem. You don't have to wait and build up and all like when you do it. Rule number 12. Any patient who comes with a massive stroke, we need not wait till he becomes drowsy, till he gets pupillary asymmetry. Early decompressive hemicraniectomy is ideal, right? Because my experience with neurosurgeons, and you have to, I think neurosurgeons are there, Dr. Jalil is there, and Dr. Jalil is very energetic neurosurgeon. But there are some neurosurgeons who just want to avoid doing this. And in some hospitals, some neurosurgeons, I'm not naming anybody, but this is my previous experience, that when you would get him early, they would say, it's too early, it's fine, he doesn't need it. And when you get him later, he says, it's too late, now there is no use. So a neurosurgeon should be our friend. It's very important to have a good neurosurgeon, like your wife has to be. A lot of your success in life depends on how good your partner is, whether it's your wife or whether it's your neurosurgeon. He has to understand, So early hemicraniectomy should be done. Don't worry if the pupil is not dilated, he's not drowsy, he's not, no. There's such a big infarct, it has to be done. It should be done. And there are no guidelines which are clearly given the mandate. If we want to save the life of the patient. Rule number 13 is that avoid intensive physiotherapy in first 24 hours. Avoid dose trial, whatever, because some people thought I will start physiotherapy from day 1 only, then he will improve better. But it was found they worsened actually. Once you put so much of demand on their brain and their limbs and all that, there's ischemia of the infarctive tissue. So first 24 hours, let him peacefully lie in the ICU, do his positioning of his limbs and all, right? Provide aspiration, put a Ryle's tube, and after 24 hours, we can start gradually the physiotherapy, and the best rehabilitation technique is thought to be early mobilization. Early mobilization means if the patient is conscious, semi-conscious, try to make him sit in the bed. On the 3rd day, if he is able, try to make him sit in the chair. This is called early mobilization. And this is very helpful. So early mobilization, and you will be surprised, you will find so many papers on this. Rather than lying the patient, in our time, 30 years back, nobody would bother about stroke patients. They would be just lying in a corridor. People don't even see them, just glycerin drooping from their mouth. But those days are gone now. Early mobilization is the key. And the other thing is that when we go to make stroke rounds in the morning, we should try to talk to the stroke patient. We should not think he's some comatose dead body there. We should tell him, hello Mr. Rao, how are you? The basic tenets of decency. And then, as per the 2026 guidelines, you should add mild antidepressants to these people. Not because the antidepressants will improve his power. It used to be thought at one stage that antidepressants improve power. No, but it will improve his mood. So there's no question whether he's depressed or not. All stroke patients are depressed. All families of stroke patients will be depressed. So a mild, small dose of SSRI, 10 milligram of escitalopram should be added to all stroke patients. And, as neurologists, we are very worried about the infarct size and progression and all, but the patient's attendants are worried about that he has not passed stools for the last 2 days. That is their major concern. So we have to make sure that we give them stool softeners. These are important things. We make sure that he's catheterized properly and informed, talking to the family and talking to the patient. These are very important because we are talking to patients. And patients are human beings basically at the end of the day. So this is very important. Now comes to the rule number 14. So I'm going to end my talk very soon. Don't continue double antiplatelet beyond 3 months. And you will see many of the patients who are coming from outstation districts for second opinion to you, and they are on double antiplatelets for years together. And how you recognize it's a double antiplatelet? Gold over will be written there. Primark or gold. Something like that. The gold is that reason. And people get this gold for 3 years, 4 years. Many times they come with brain hemorrhage to us. So it's a strict thing that don't give any gold beyond 3 months. Actually they are saying lesser the better. 3 weeks is okay. But Chaitanya has talked a lot about ICAD. So in ICADs you have to give up to 3 months only and not beyond 3 months. But there will be some patients who will get a stroke after 3 months, and then you may have to extend. That is personalized medicine. So that we have to identify with the help of any Hassan and genetics who are good. So sometimes you have to go, because I have some patients, you have to go. But generally, as a rule, gold should be stopped at 3 months. But in those vasculopathic patients who keep on getting 10 strokes, 12 strokes and the moment, then Celestazol is a good combination. And it has been shown that it does not cause excessive bleeds. There are patients who are having bleeding as well as infarcts. One time bleed, next time infarct. Next time infarct, next time bleed. You will see many of these patients. Their vessels are just, and they are very fragile. And such patients are more in Japan and China. So Celestazol has been developed in Korea, in those countries. So any patient where there is a past history of bleed or who has a bleeding complication, at the same time he's having an infarct and at the same time he's having a recurrent, give him this combination of Celestazol and aspirin. In this there is no limit of 3 months. You can give 3 years also, 4 years also, 5 years also. Because the clinical trial which was done, that was called CSPS, they had themselves given for 3 years. And there was no excessive bleeding. And now this is rule number 50, it's the last rule, that the moment you find that there's a carotid stenosis, don't do immediate endarterectomy or stenting on them. Wait for at least 1 to 2 months. That's very important, because if you don't wait, this is a patient, you can see there is a stenosis on the right side, and this is the post-stent. Stent was successful, but patient got a bleed. And the reason why patient got a bleed is that the moment you open that blocked segment, there is a floodgate is opened. This artery was blocked for the last 5 years. And suddenly you open floodgates, and the area of the brain is very soft. It's ischemic, it is mushy. So it bleeds. Of course, if your patient has only TIA, or if he has a very minor stroke, then you can do. But otherwise, wait for at least 1 to 2 weeks. This is a real patient. And the only mistake in this patient was that it was done prematurely. On the 3rd day only, they did this endarterectomy. So wait for at least 1 to 2 weeks for doing endarterectomy in patients who have an infarct. And as far as the MCA is concerned, MCA stenting, I'm happy Chaitanya talked to you. As of now, in MCA, and this is the example of MCA, this is the terminal ICA and this is MCA. Here there is an infarct, this is another M1, M2 segment, you can see here on the right side. In these patients, first try double antiplatelet. And many of them will be controlled on double antiplatelet. That gold has to be given for 3 months, along with high dose statins, with good accessories. And don't go for stent immediately for the simple reason that our stent technology is still not perfect. After the stent, many of them get infarcts because of the perforator blocks and all. After the stent, some stents rupture, some stents get thrombosed. But I'm sure there are new studies which are showing better stents. They are going to come. But as of today, if you have, that's the difference between extracranial stenosis and intracranial. Extracranial, you go ahead and wait only for 2 weeks and do it. But intracranial, try your double antiplatelets. Now there are new drugs coming. Ticagrelor is even more powerful than clopidogrel. But give them high dose statins, check their lipids, give them PCSK inhibitors, but try to manage intracranial medically. And only if they fail medically, then you go for the stent. And the other therapies which have been very much being talked about, and a lot of doctors are also giving, is anti-inflammatories in these intracranial diseases. And colchicine is very much accepted now. So you can give them double antiplatelet, colchicine, and maintain their blood pressure high. Means 140 by 90 is good enough, not very high, in the patients of intracranial stent. So in summary, dear friends, somebody said the only rule in life is that there is no rule. But I don't think in stroke you should think that. We have to be careful. There are rules. It is good for the efficacy and it is more better for the safety of the patient. So knowing the rules is important. But rules can be modified in the given clinical context. For instance, I told you that give double antiplatelet only 3 months. But if you know this patient has a past history of it, then you can extend for 6 months and take the consent and you can modify them. But the fact that brain hemorrhage should not be thrombolized is an unbreakable rule. You cannot, so you have to know the rules. So you are allowed to break the rules only if you understand the rules and the basis of them. This is true in stroke and this is true in life also. Only those people can break the rules who understand the rules. But those who don't understand the rules just follow them. Thank you very much.
Sir, thank you, sir. That was an excellent presentation. Kaplan-Fisher rules, we don't know. There are many students here, sir. It's a medical college. I think from now onwards, maybe Dr. Kaul's stroke rules, if you know these 15 rules, you all will become strokeologists. So, please remember all these rules. They are the golden rules.
Yes.
Sir, I have few questions, sir. Simple. Actually, the representative leaders are coming. Sir, Altiplace is not going now, and everybody is using Tenecteplase. So please help me. I said, we are comfortable with Tenecteplase. Why I should go for Altiplace? He says, Tenecteplase is the original molecule from Boehringer. Now, whatever we are having in India is a biosimilar, which is 70% efficacious. It is not a bioequivalent. They have a bioequivalent. So is it true, sir? I mean, we are using a biosimilar and the efficacy is less. Is it true?
No, you see, that study has not been done. During COVID times, in All India Institute, they have done an observational study. And observational, it's not a randomized controlled trial or biochemical. And they have found that it is same, the results were same. In the AIMS Delhi, it's published also. And right now, ICMR is doing one trial by Rohit Bhatia, where they are studying the same question, whether is biosimilar same as. So we'll know the results. But by and large, going by the superficial experience of people, they seem to be same. You see, in rheumatology, oncology, it's almost completely they are using biosimilars only, going by their example. Because the other drugs are very expensive, 3 times, 4 times. But you're right, that point is valid. Yeah. But it doesn't mean that it's ineffective. Because we are also seeing by our experience, but as far as hard data is concerned, it will take 1 or 2 more years.
Whatever I have thrombolysis, sir, I never seen a bleed with Tenecteplase.
Yeah.
But bleed I seen with Altiplace. So that's why I wanted to know whether that is working and this is not working.
No. If you have not seen I'll tell you one thing. If you have not seen a bleed with Tenecteplase so far, you will. Someday you have to only wait for some time. Bleed will happen.
Sir, another thing, wake up stroke, sir. What is your experience? Because nowadays flare diffusion mismatch, based on that you are thrombolizing sometimes.
That is
it true? Because we have to get a perfusion scan after 4.5 hours.
You see, I tell you, wake up stroke using diffusion flare is a very good thing because it's available. You don't need perfusion. But those flare things develop by 4 hours or 4.5 hours or 5 hours. So if your stroke has happened by 4 hours, you can do it. So that is good. But suppose your patient wakes up and there is no mismatch, which means flare is still there. You can still do a perfusion. And if on perfusion you show a mismatch, you can thrombolize that. So in other words, diffusion flare is good enough. But if you have to go beyond that, because diffusion flare will tell you only 4 hours strokes, 5 hours strokes. So that's it.
Sir, the last one, sir. We have one patient, he had a bilateral occlusion. 100% IC occlusion. IC. And let's say 95%. He is getting repeated attacks of stroke. He is dependent on vertebral circulation. In those patients, what will be your suggestion? Go for endarterectomy or just put a stent in the available 5% this thing?
You can do either endarterectomy or stent. They both are by and large equal these days if he is symptomatic. It depends on who is doing it. If there is a good endovascular person, I will go for endovascular. But if my surgeon is very good, I will go for that. Now, this is a very high reward and high risk situation. Reward is also high, but risk is also high. That we have to explain. But I would definitely open that if he is having recurrent attacks, because you don't know how long that posterior circulation will support it. It can fail also at any time. But you can do any one of the two, provided who is good. That you have to know. That is very personal,
Thank you, sir.
Yeah.
Thanks for the very exhausting, very practical, clinically grounded talk, sir. We are very much benefited by the talk. I just have a comment saying that. So these stroke rules are very good, excellent, very practical. But what I want to say is that the patient has to present in that particular window for us to be able to do all kinds of advanced stroke management. I believe that most of the public, even doctors also, are not aware of stroke symptoms. The pain of a cardiac disease brings the patient to the doctor rather immediately. In case of stroke, we fail miserably, because I see in my 30 years of clinical practice, I see hundreds of patients coming with the minor strokes and TIAs, which are going completely unrecognized even by the doctors, sometimes physicians too.
Yes.
So this has to be publicized, and in my small clinic, I would have given at least 100,000 pamphlets to all my patients, even if they are not stroke patients. So I request all of you, all the doctors, to involve in spread of this message. The public as well as the colleague doctors who may not be able to understand the way we understand a stroke. Thank you, sir.
I think, as I had said earlier, my first comment regarding Dr. Subhash Kaur, the way he presents, the way he talks, the way he's jovial and the way he's witty. You cannot stand to live. Dr. Naveen was saying he has not seen a case of bleed with receptors. So similarly, when I was a first year resident, and Dr. Rajareddy was asking my consultant, I said, whether while putting a burrow, anytime when I entered into the brain, when you put a burrow, this thing goes into the brain. He said no, and by the time he realized I was saying, sir, and it just went into the brain. So it happens. One time was around the soul.
One day or the other, someday it will happen. You'll remember that anyway. You'll remember me.
Thank you very much.
Thank you, sir.
Chairpersons to hand over the memento to Dr. Subhash sir.
Sir, look here, sir. Sir, close. Sir, look here.
But in between, I think I asked you this question second time. I was asking you second time.
Okay.
I'll tell you something. He said, Ravi, he has a lot of experience. He said, I've never got it. 50 years. I said, how many you have? I said, how many you have? He said, about 7. I said, it will happen. I said, it will happen. I said, it's a joke. I said, you were right. It happened. But how did you say 14th patient? That's the data. 6% of lead. It may not have happened 14th, it will happen 15th or 16th. But on a short note, I will tell you. One month then for the rest of you follow the video. So one day, my grandfather was running a bus in Kashmir. And in his bus, one person kept his coat. This is I bought boat sticker. What option do you have? He said, I've never seen a boat on the seat of a bus. This was the first time. Nice to see you. Okay, thank you so much. What a meeting.
I request Dr. Anna Sahan to hand over the token of appreciation to the chairpersons.
Sir, look here, sir. Okay.
Previously, this was
Sir, look here, sir.
without this bag. Too difficult to carry.
Okay. Sir, look here, sir. Okay.
No, but now they will give it. You can also see.
So there is no special introduction or special talk for you, sir.
आप बताओ सर आप कैसे अच्छा अब कम काफी
As a consultant neurologist at Medicover Hospitals, he completed his DM in neurology from NIMHANS and holds a fellowship in neurovascular interventions with additional training at Breach Candy Hospital. He previously worked as a consultant stroke neurologist at Narayana Mallareddy Hospital and Sri Sri Holistic Hospitals and also served as senior resident at NIMHANS. He is a gold medalist in MD Medicine and has multiple research publications in sleep disorders, movement disorders and neurovascular conditions. We are very happy and glad to hear to you, sir. Please welcome onto the dais.
Good afternoon, everyone. It's a post-lunch session. I think it's a fertile ground for sleeping. The crowd is already very thin. I will keep the theoretical part to the minimal extent possible, and I will try to focus on some cases which will be helpful in our practical day-to-day practice. So, till now I think we have, after a very great lecture by Dr. Subhash Kaur sir, and now this talk and the next talk is mainly based on the issue window. So whenever we heard of acute stroke, either in the emergency or anywhere, we will talk of the time duration, that is how long from the time of onset. So many things have passed on initially from the NIMS RTPS trial, where the IV RTPA was introduced. The time duration used to be 3, and after that it has extended to 4.5 hours based on the extent trial. And in the similar way, if you come to mechanical thrombectomy, initially it was up to till 6 hours based on the MR Clean, SWIFT, Prime trials and other trials. Beyond the 6 hours, the mechanical thrombectomy has extended up to 24 hours based on the landmark trials of Dawn and Diffuse. So we'll focus on those things also. And this talk and the next talk by I think Dr. Surya sir has some resemblance, or means there is some overlap. I won't be focusing more on the imaging part of the physics because it is mainly radiology related, and probably you can ask him. So this is the overview of this lecture. This beyond time window, what is this tissue window, and the pathological basis of core, penumbra and the salvageable tissue, and the advanced imaging briefly, and then we go to the landmark trials and cases. So the normal blood supply to the brain means it is around 50 to 60 ml per 100 gram of brain tissue per minute. Means it is the blood flow rate. Means it is different for grey matter and the white matter. For the grey matter, the blood flow will be on the higher side, it is around 50 to 60, and for the white matter, it will be around somewhere around 30 to 40. So if the blood supply reduces below the 10 ml per 100 gram of brain tissue per minute, then it will be, means the apoptosis or the death of the brain tissue will happen, and that is what we call it as the core tissue. Means that irreversible damage was already set in. If the blood supply is somewhere around 10 to 20, means that is called the penumbra, or in other ways it is the salvageable brain tissue. Means the brain tissue which is clinically means not active, but it is a viable brain tissue. If we reperfuse with either thrombolysis or thrombectomy, depending on a case to case, we can means bring back the salvageable tissue to normal state. That is the whole purpose of stroke management or the advanced stroke management in the recent decades. So rest of the things means we all know means as we delay for each and every minute we may lose almost 2 million of neurons per minute. Means roughly for every hour the brain will get aged by years. So what is tissue clock and what is time clock? Previously, as we have discussed, there is a definite time window. Means if it is up to 3 hours or if it is up to 4.5 hours, we need to give thrombolysis. But if a patient comes beyond that period, what we should do? So this problem is not being addressed for all the patients because all the patients are not same, and so to address this problem, now initially the first trial was this. One of the first trials was extend trial and wake up trial. In the wake up trial, what they have taken is, as we don't know the exact time of onset, means that is the last known normal, they have taken the diffusion and the play study of the MRI. If it is there on the diffusion, means if there is an acute infarct according to the diffusion ADC, and if it is not expressed on play sequence, then it indicates that the complete damage, means the cellular level damage has not yet completed. Means such patients will benefit by reperfusion treatment, and that they call that it has a tissue window. The tissue window may be beyond less than 4.5 hours. So in such cases, when you give thrombolysis, the outcomes are good statistically. So now beyond the time clock, this time clock may not be reasonable for each and every patient. Some patients, even though they are in the window period, the infarct might have been already set, and it is, as already sir also has told, the MCA infarct is more than 1/3. Then in such cases there is no point. So we need to look at the salvageable tissue, whichever is there, to bring back the tissue. So why some patients will progress rapidly and why some patients will be progressing slowly, it mainly depends on the collaterals. Means the penumbra or the salvageable tissue is a matter of collaterals. Means if the collaterals are good, the salvageable tissue will be more, or it can be, means the chances of progression will be less. Those are the persons, those are slow progressors, and those are the persons we need to pick up because they will benefit more after reperfusion therapy, whether it is thrombolysis or mechanical thrombectomy. So after this tissue clock, means if the core area is the already dead tissue, that is less, and the penumbra or the salvageable tissue is more, then such cases will benefit definitely. Means along with this diffusion imaging, we can also do the collaterals. We can do a CT angio, either multi-phase or single-phase CT angio, to address or to identify the collateral status. In compared to the time clock, it is more personalized. Means we can identify on patient-to-patient basis, unlike the time clock rigid time window. So I am not going in detail of this perfusion imaging. This perfusion imaging, actually to say, this is a very advanced imaging. In Hyderabad itself, there is, I think, hardly there is one center where the automated rapid software is available for identifying the patients. By this rapid software, obviously we can pick up the patients early, but this may not be available at each and every place. So how to circumvent this? Means actually the trial which I spoke, that is the Dawn trial which came in 2019, had taken the inclusion criteria of clinico-radiological mismatch. Means a patient presents with a large infarct clinically. Means large means he has got a, along with dense hemiplegia, he has got cortical signs. Let's say aphasia. Let us say praxia or some gaze deviation or hemianopia. Means they are cortical signs. It indicates that the chances of large vessel occlusion, means large vessel in the sense either terminal ICA or M1 occlusion may be there. Means the chances of having a large vessel occlusion with cortical signs of aphasia, gaze deviation, hemianopia or apraxia is very high along with the dense hemiplegia. So if you find clinically bedside any patient with this large vessel signs, then immediately you need to think of along with the routine imaging, you need to think of either CT or MR angio. If at all you are doing an MRI and if you found the core to be very small, but the deficit is very high, it indicates that there is a clinico-radiological mismatch. Means the diffusion infarct core is small, but the deficit is very high. That is the clinico-radiological mismatch. This is the inclusion criteria or entry point in the landmark trial of Dawn. Means along with this clinico-radiological mismatch, obviously they have taken rapid software, means perfusion imaging also, but that is not an inclusive criteria. Means they have taken the patients with clinico-radiological mismatch and those patients have benefited. So perfusion imaging, basically they will see three parameters. I am not going in detail. Cerebral blood flow, means that is the rate, how much ml of blood is going to per minute per 100 gram of brain tissue, and blood volume, that is the amount of blood in the brain parenchyma, and it is Tmax or mean transit time, means the time taken for the blood to go into the tissue. If at all if there is a hypoperfusion or if there is a cutoff, then the mean transit time will increase and the cerebral blood volume will be reduced in case of core, whereas in case of salvageable tissue, cerebral volume will be increased, but the rate will be less. Means the blood will be flowing at a flow rate, so the volume will be more, whereas the transit time will be taking more. That is, Tmax will be more than 6 seconds. Such cases you need to select. If at all you are using the rapid software or automated software for perfusion imaging. This is the so these are the images. This is the normal hemisphere, and on this side, that is on the left side, you can see there is blue means the blood flow is very less. This is the cerebral blood flow volume and the mean transit. So to identify actually core means, if at all we compare to the opposite side, if the cerebral blood flow is less than 0.3, we will be calling it as the core. Penumbra will, I told you, will identify based on a Tmax. That is that if it is more than 6 seconds, then based on the volume of the Tmax. If the volume is at least double to that of the core, that's what has been taken in the landmark trial of Dawn and diffuse. More the salvageable tissue or the penumbra, better are the results or outcomes. So again the same thing. So as I told you, this software, rapid software or the perfusion imaging may not be available everywhere. And in metropolitan city like Hyderabad only, if you see, hardly there is one center where it is available. So there is proxy to this, what we'll call it as arterial spin labeling image is available. This arterial spin labeling image, what they will do is they won't give any contrast, but they will be labeling the protons in the neck with radio label. Means it calculates the time taken for the blood. This means the protons in the blood at the neck to reach the damaged brain tissue. They will be subtracting from the normal side, and they will be calculating the hypoperfused area. Means it is not an exact one, but it is like similar to the perfusion imaging. So bedside, without much delay in time and without much cost, we can identify the penumbra, means the area which can be salvaged. So if needed for giving advanced management like mechanical thrombectomy. So that's what this is the advantage. There is no gadolinium is not needed, and you can repeat if you want. But the issue is with this is it has got a low sound noise ratio, means it is impeded by the motion of the other artifacts, and it will take more time, slightly 1 to 2 minutes more than the perfusion imaging. So this is the arterial spin labeling. Here you can see this is the diffusion imaging. The acute infarct is small, but if you come to ASL, this is all the hypoperfused brain tissue. Means this infarct will expand to all this area if you won't address this patient in the right time. Means looking at the hypoperfusion, it can be a M1 occlusion, or that means large artery occlusion, so large vessel occlusion. We need to address that. If it is not addressed in the right time, this whole area can get converted into a core or established infarct. So what is the difference between the arterial spin labeling and perfusion MRI imaging? Perfusion MRI imaging is basically done with gadolinium contrast, and it takes slightly less time in compared to the ASL sequence. But because we are using gadolinium, we can't repeat it if the patient moves. In case of acute stroke, the patient can be irritable and moves, we can't repeat, whereas ASL, there is a chance of repetition if is required. So the entire means the hero of this advanced mechanical thrombectomy or treatments for acute stroke is mainly because of the collaterals. The collaterals is the game changer. Means whenever the collaterals are good or best, the outcomes will be good. Means if the penumbra is volume is more, it indicates that the collaterals are very good. Such patients, if we offer the treatment in the right time, they will benefit hugely. And this collateral status is the one which decides how the patient deteriorates. If the collaterals are good, they will be very slow progressors, or sometimes they may not progress as well. But you can't leave it like that. You need to address the stroke cause. The collateral status depends on multiple factors. So these are some of the factors. One is means in compared to means why this if a patient I think we already discussed, the patient gets MI, means everyone will be very scared, and they will be running. But it is not the case with the brain. Why? Means it has got circulophilis and very good collaterals. Means it is a natural mechanism through the evolution process. So most of the times whenever the stroke comes, no one is bothered because anyway it will improve. Because it is mainly because of the collaterals, either through circulophilis or through the leptomeningeal collaterals. But in some conditions like metabolic conditions like diabetes, when there is hyperglycemia, the collaterals may not sustain. Whenever there is fever or hypothermia, the collaterals may not sustain. Whenever there is dehydration or because of any other reasons, the collaterals won't sustain. So other than that, if at all there is a tight stenosis proximally, means proximal to the occlusion, either in the large vessel, means let's say in the carotid or else in the basilar artery, means already the flow will be minimal or narrow, and the collaterals won't be sustained. Suppose the infarct size is large and the edema is there. This edema will compress upon the collaterals, and they will progress rapidly or they will fade up easily. So I am not going much into this. Now actually this is one more recent concept which says that the net water uptake, means just based on the plain CT imaging, we can identify, means based on the hypodensity. If at all it is very hypodense, it indicates that, means based on the Hounsfield units we can calculate, if it is very hypodense, then it indicates that the damage, the cellular level damage is started in, and more the hypodense means the damage might be complete. So, this is basically a formula. This has been evaluated in few non-RCTs and retrospective studies, but it has not been validated with the RCTs as such. What it says is, in compared to the normal side, the abnormal side, what is the Hounsfield units you need to calculate, and you need to calculate the difference. If the difference in the percentage, if it is less than 7% or so, then the chances of improvement even beyond the window time is more. Means the complete damage has not yet finished. If this percentage is more than 15% or so, the chances of hemorrhagic risk is very high. Means you need to aggressively address the patient with proper measures. Means depending upon if needed, BP should be reduced, whatever is to be done. If at all this percentage is more than 11% or so, it indicates that even though the midline shift has not yet started in, the chances of progression for decompression are very high, and such cases to be given for early decompression. Means we have spoken, I think Dr. Subhash Kaur sir also has spoken, means which cases you will decide for early decompression. Means if you do the decompression early, the outcomes will be better. So based on this, we can identify this is what means the brief is showing. If at all, means these percentages are not exact numbers because it has not yet validated, but if it is very high, the chance of hemorrhagic risk and the chance of progression is high. If it is less than 6 or so, the revival is more. If you can remember this much, this is more than sufficient. So these things also I think already we have spoke. So just a brief understanding, because the crowd is very heterogeneous. There are many emergency physicians and general physicians. So this is the aspect score. Aspect score is basically not uniform one. It is Alberta stroke program early CT score because it has just developed there in Canada at Alberta. So there are different regions. So first one is at the level of basal ganglia, and second is at the above the level of basal ganglia. So this is caudate, this is lentiform nucleus, this is internal capsule, this is the insular area, and this accounts for this deep grey matter, or total it constitutes 4 regions. And the rest of the 6 is anterior 1/3, middle 1/3 and posterior 1/3 at this level and above this level. Means crossly you can remember like this. So all the stroke trials initially which were done were based on aspect scoring. If the aspect score is more than or equal to 6, then they have taken as the inclusion criteria, and this is mainly in the anterior circulation. So I will come back to this. So, but what happened is these trials were in 2015. Now, suppose what if a patient comes beyond 6 hours? Will you leave the patient like that? Is there any way to go about? That's what the landmark trials of Dawn and Diffuse have changed. It has brought this perfusion imaging, and more relevant to our setup is this clinico-radiological mismatch. Means a patient with dense deficits and small core on diffusion, those patients are very likely to improve. This is one of the inclusion criteria in Dawn trial. So the number needed to treat means, according to this Dawn trial, is less than 3. Means if you do mechanical thrombectomy in the 3 patients, one patient is going to become almost normal, means MRS of less than 2 at the end of 3 months. It is one of the best treatments in stroke care ever possible. Not only in stroke, maybe in neurology maybe per se. This diffuse file is up to 16 hours, whereas Dawn trial is up to 24 hours. And so this is what the number needed to treat. According to the dawn, it is less than 3, 2.8. According to diffuse lethal, it is 3.6. Now, what means these trials have based on the clinico-radiological mismatch or the advanced imaging of perfusion imaging. Based on that, if at all the salvageable tissue is more, then we need to address the cause with mechanical thrombectomy based on. Now, after this 2018-19, what has happened is, shall we give the treatment beyond that time frame, means beyond 16 hours or up to 24 hours, or the aspect is less than 6. So for that actually there are trials. These are angel aspect and selective trials. In these trials also, because I told you already, this aspect score is not uniform, means the volume can't be exactly calculated based on the aspect scoring. Some areas are more prone for hemorrhagic transformation and some areas may be more eloquent, so the deficits may be more. So applying aspects may not be the right choice in each and every cases. So we need to select the patient on case-to-case basis. So based on that, this late thrombectomy trials or where the aspect scale is more, means in high aspect score, the thrombectomy was performed. The number needed to treat high thrombectomy is also less than, means around 5 to 7. That's what all these trials show. Means these trials have been followed for long term. After 1 year, the long term which has shown that the benefit is quite high. If we leave the patient like that, most of the patients will be like a vegetable or potato. Means previously we spoke, just by lying like that is not going to help them. The person should be functionally independent. That is only of help. So at the end of 1 year, even in this large strokes, most of the patients are becoming functionally independent. That is in the MRS of 0 to 3 or sometimes up to 2. So that's what this slide shows. So MRS 0 to 3 is achieved in around 1/3 of the cases around. But however, it doesn't improve the mortality. It is not focusing on the mortality, but it is focusing on the functional independence. Just being lying there is not going to help. So these things I think we have already spoke. These are the trials I think already we have spoke. Now we'll see some practical case scenarios. This is one patient who is 74-year-old who is a smoker and hypertensive along with diabetic. He has all the notorious caution and he has presented with TIA with right hemiparesis and right human facial palsy 10 days prior to. And this is the MRI which has shown some acute to chronic infarct in the left frontal region on the CT. And he has presented, actually he has once again had recurrent aphasia and right hemiplegia, and this deficit is persistent. His NIHS score at the time of presentation is high, it's around 15, and when MR angio was done, there is a tight stenosis of 90 to 95% at the origin of the ICA. So this is the shower of tiny infarct. Maybe it may be an embolic shower from this side of tight. You can say it as tight occlusion. It is critical. So from this side, maybe there may be embolic showers from this plaque. But the deficit is disproportionately large. Means for the infarct, what we are seeing, and for the deficits, what is there, what we call it as the clinico-radiological mismatch. However, there is no large artery occlusion, but there is only tight stenosis. So we can call this as hemodynamic stroke. Means whenever there is the blood flow is reduced because of whatever reason, means the deficits are going to be flared up. So that's why for most of such patients we'll ask them to keep the head end flat and to maintain the hemodynamics or to maintain the blood pressure before doing any active intervention to prevent the further progression. So for him, carotid artery stenting was performed, and after the 4 days after the stroke onset, means this is the burning topic. So 4 days after the onset, the carotid artery stenting was done, and still the patient has improved. Non-table recovery was seen with reversal of aphasia and right hemiparesis. And at the time of discharge, the patient NIHS has dropped from 15 to 4. And this is the imaging at the time of discharge. And these are the DSA images. This may be a bit complicated and weekend-like, but I will try to explain briefly. This is the left ICA origin, which is showing tight stenosis prior to procedure, and this is the stent which we have put here to here. And here you can see, so prior to procedure there is no, the flow is very sluggish. This the ACA territory is not being filled, and here the perfusion has improved both in the ACA territory as well as in the MCA territory. So the follow-up is also very good, not only immediate follow-up after 3 weeks, but after 1 to 1.5 years as well. The patient is independent and doing all that as on his own. Coming to the next case, he is a 45-year-old male who has referred with something like a space-occupying lesion in the frontal. So, but when you go to the history, he is more of you can call it as something like akinetic mutism or abulia. Abulia is a severe form of akinetic mutism. If bifrontal lobe is involved, they can mimic like something like cognitive disorder. So along with that, he had gradually progressive quadriparesis, urinary incontinence, and aphasia. He has the risk factors of smoking, but he doesn't have hypertension and diabetes. The CD is not that much. But he doesn't show any definite changes in this window. Coming to the MRI, but there is a flare changes in the bifrontal region. So this may be the reason for his cognitive impairment or something like abulia or akinetic mutism kind of presentation. So when we see the angio, it is surprising. Both the ICAs are occluded, and there is a single vertebral artery. You can see these are the DSA waves. This ICA is occluded, this ICA is occluded. What we are saying is external carotid. Here also, there is a single vertebral artery, and this vertebral artery is also showing stenosis at two sides. What we'll call it as a tandem stenosis. So that person is surviving on a single artery, that too with severe stenosis. So whenever the blood flow is reduced, he is getting more and more symptomatic. So the brain means the blood flow which is available from the stenos vessel is not sufficient as such to survive. So what we have done is we have done angioplasty, then followed by stenting. So this is the left vertebral artery after angioplastic stenting, and after that you can see. So the single vertebral artery is supplying the entire brain, not only the posterior circulation but also the bilateral MCA territories. So following this, the person actually had a rapid recovery. He started speaking by day, and he started walking on his own by the next 4 days, and he recovered almost completely in 2 weeks. And his NIHS score at the time of discharge was 3. So that patient also actually, what it shows is means that infarct size is small, but clinically, if you see, the patient is very much means he had quadriparesis, aphasia, means which just can't be explained by the size of the infarct. Means there is a clinico-radiological mismatch. Means we need to address the tissue which is salvageable. Now coming to the next case, she is an 80-year female who has presented with 2 episodes of TIA, and the third episode happened in monitoring. He had transient loss of vision on the left side with right hemiplegia, and the CT is actually unremarkable. MRI is showing tiny infarcts in the deep white matter, more in the, this is the, we call it as internal watershed territory. We see the top MR angio, there is a tight stenosis in the similar side, that is the left ICA origin. So what we did is a stenting, and following that the next day power has increased and she started moving on her own. So she became ambulant on her own and she became continent, and her NIHS score has improved to 2. So this is the image. You can see it is critical, almost narrow. There is no flow here, and this is the one which is after the stenting. Means this also shows that what is more important rather than time is tissue window is more important. So this is the intracranial flow which has improved in comparison to before the stenting. So follow up at 6 months and no neurological deficit, and the patient drives two-wheeler back. So these are, I will show 2 more cases where we have done this. We have spoken about the anterior circulation as well as aspects. But what about the posterior circulation? All the trials initially were focused on the anterior circulation. The posterior circulation, basically there are 2 landmark trials, this attention and basics or Boucher trials, which showed that the mechanical thrombectomy or the intervention can be extended up to 24 hours in posterior circulation as well. The posterior circulation, the brainstem structures actually in fact are more resilient to ischemia in compared to the anterior circulation. They are evolutionally they are older structures, and they have got more resilience to ischemia than the anterior circulation. Here there is a case, a 37-year-old who has presented with vomiting, dizziness, slurring and imbalance along with neck pain. He came from outside, somewhere peripheral parts of the Telangana, and by the time he was presented to the hospital, he is in a drowsy state, and this MRI was done. So I just want to tell you the posterior circulation aspects also, just to have an idea. This is the thalamus. Bilateral thalamus has got 1 point each, and this is the occipital cortex has got 1 point, and this is cerebellum. This has got 1 point, and this pons and midbrain. These are the 2 important structures. So pons has got 2 points, and midbrain has got 2 points. Whenever in case of posterior circulation, if there is a basilar artery occlusion and with sparing of midbrain and pons, that is the brainstem is spared, then such cases beyond the window or beyond the 6 hours, up to 24 hours, you can do mechanical thrombectomy. Means such patients are going to get benefit. If the brainstem is already involved, then there will not be much benefit. Even if you do, if at all pons is involved, it may be in a locked-in state. So that has got more points because of that. The brainstem, midbrain has 2, and pons has got 2 points. So this patient, you can see there is no basilar artery in the MR angio. There is supposed to be basilar artery, supposed to be seen, but it is not there. So there is an infarct in the cerebellum, but there is no infarct in the midbrain and the pons. So we have taken up this patient, and so here we have opened up the vessel. You can see the tag here. Means actually probably the person might have had a dissection. He is an inpatient. He had a dissection, and probably the thrombus have occluded the basilar artery. So in this case, actually, sometimes if needed, you can do a stenting, but doing a stenting in an acute setting is always more risky, and it can get occluded. We have waited for 30 minutes on the table, and there is no occlusion. So we have managed with the means. We have not done stenting. Without stenting only, we have gone ahead. And already the edema is more, so the person has needed decompression, posterior fossa decompression, and after that the person is doing fine. Means he has improved. On the follow-up visit at around 1 month, he is admitted. So this is one more case. This is a wake-up stroke in a similar situation. Was presented with drowsy and vomitings. The time from the last known normal, what we'll call in the wake-up strokes, is 20 hours, more than that of the 6 hours which has been told. Here also, if you can see, the brainstem impact, the bottom impact is very minimal. So, and the basilar artery is not seen. This is a sagittal sequence of MR top, and here the basilar artery is not seen. This is a fetal peacock, which is coming on to the right side. So, such cases, if we do mechanical thrombectomy, those will benefit. Opposite side vertebral artery is actually hypoplastic. This is the main vertebral artery, and this is occluded. There is no distal flow into the basilar artery. So, after doing the Solomola technique and removing the clot, the flow has been re-established. We have seen this side, it is a fetal peacock coming from the anterior circulation. So, it is looking as if it is occluded, but it is coming from the anterior circulation. So, the TK3 flow has been established, and the patient actually is doing good. We have extubated the patient on the next day, and the patient is doing good. So I am not going into these guidelines anyways. So we have this is the attention and the basic trials for the OCA circulation. If at all if you ask what is new, so this is one point, wake-up stroke. One thing is new, and if you want to do thrombolysis beyond 4.5 hours, you need advanced imaging like perfusion according to the guidelines. If you don't have perfusion imaging, means we are not supposed to do thrombolysis beyond 4.5 hours. So what are the practical advantages of this tissue clock? Means tissue clock means so you need to remember this word, clinico-radiological mismatch. Means if there is a mismatch, it indicates there is a salvageable tissue. Whenever there is a salvageable tissue, the tissue is not died, means such patients need to be addressed. So if you take the definite time criteria into consideration, we may miss almost 1/4 of the cases, and sometimes the patient may come within the 3 hours or less. But if we see this imaging, means if we see properly, already the infarct might be established. In such cases, even if you do mechanical thrombectomy, it is not going to be any help, because already the apoptosis or the irreversible damage has already happened, and it is going to be a futile, useless thrombectomy. So that's what this extended window trials, these are the DAWN issues already we have spoken about, and we can address personalized based on image to image basis and patient to patient basis, we can address. So just after 4 hours, that's what, no patient benefits from thrombectomy. It is a myth. The fact is, we need to do the perfusion imaging, or we need to look for the clinico-radiological mismatch. So good NIHS means no LVO. It is not always the case. If the collaterals are good, the NIHS can be still low. Means just based on the NIHS, if NIHS is less than 5, doesn't mean that it is a perforator territory, or it doesn't mean a capsular stroke, or it doesn't mean a basal ganglia stroke. So it may be because of good collaterals, the person may be sustaining. Always and always, you need to identify the cause of stroke or the mechanism of the stroke. Just doing a diffusion imaging or CT is not sufficient. You must do an angio. You need to identify the mechanism of the cause of the stroke. Always remember to cover the neck vessels in your angio. Doing an angio from the arch of aorta will be able to identify. Previously already we have spoken about ES/US or cryptogenic stroke. In ES/US and cryptogenic stroke, almost 1/4 of the cases are because of the carotid disease, which we are blatantly missing because we are using Doppler, which is very much subjective, and the information which we get from Doppler is very less. So always try to do an objective imaging and try to cover the angio from the arch of aorta. So one more with this TBA is useless beyond 4.5 hours, but it has been proved wrong based on the extend and wake-up trials. CTP means perfusion adds too much time in acute stroke. It is not the case. There is rapid software. Now, if it doesn't have a software, you can think of whether there is any clinico-radiological mismatch. So sometimes there are trials which says that bridging therapy is not significantly benefit in comparison to the direct mechanical thrombectomy. Suppose the patient presents within 4.5 hours, you can do thrombolysis and can shift him to the cath lab for mechanical thrombectomy. But that is called bridging therapy. That bridging therapy in comparison to direct MT has not shown any significant difference. So if the patient is in a peripheral setup, then you can do thrombolysis and you can shift. That we will call it as spoke and hub model. Means you can do thrombolysis at some outside setup and you can shift to a patient to a setup where there is advanced procedures like cath lab and mechanical thrombectomy facilities are available. But if the patient is right in your setup, and you can even think of direct MT. So these are the trials, chronological trials from 95 weeks RTPA to the recent last trial which has got large score thrombectomy. So I am concluding. So always tissue clock has replaced the rigid fan windows. Look for the core size and look for the collaterals and look for the penumbra, that is the clinico-radiological mismatch, and if it is more, go for next step, that is the means based on mechanical thrombectomy or stenting, whatever is required. There are advanced images like rapid software or CT perfusion, and this collaterals is the game changer. Thank you very much.
Thank you, sir. It was a very extensive and elaborative talk. But first of all, let me congratulate you because, like all the cardiologists have now trained themselves in interventions. I think one day will come very soon where all neurologists mandatorily will get trained in stroke interventions because it's our bread and butter. Stroke is our first choice of treatment anywhere, wherever you go. So in that, we are lacking the expertise. So well appreciated thing that you are doing. So let me ask you a few things which were running through my mind. How many of us blindly believe the time of onset of symptoms that the patient or the relatives declare? Do you think, is it reliable really? Because the person with aphasia or hemiparesis and he is lying down there, he doesn't know the exact time of onset and even we don't know. But blindly, all through these years, we were treating it. Now, the medico-legal aspect also, and evidence-based medicine also, we definitely need to incorporate AI, especially the rapid AI software that has been introduced in KIMS. So, we were, trained in few classes where AI will give you the direction. Of course, we need not blindly follow it, but unless we are equipped with the knowledge, these guidelines, we cannot fully utilize the AI. But definitely it is going to change the game and we all need to update ourselves. So the thing is, do you practice as a defensive practice, offer these interventions to everybody, or do we have to blindly follow the guidelines?
It is patient to patient basis. We can't use blindly to each and everyone. That's what the whole talk is focusing on, means the penumbra sign. We can't just draw a watershed high border, means if it is less than 6 hours, if it is less than 24 hours, means we can, it is not like that based on the salvageable tissue, means if the deficit is more and the salvageable tissue, means salvageable area is more, such cases are going to benefit in a great way. Means
especially in stuttering strokes.
That's what, stuttering stroke may be because of multiple reasons. Yes, as you told rightly, it can be because of ruptured plaque, which may be throwing showers. So, you are right, ma'am. Means based on patient to patient, we need to select rather than a uniform thing. That's what I am trying to highlight. We need to.
One more point I wanted to emphasize. All my professors and teachers used to tell me how the collaterals are. That's the only soul and whole factor that will determine how much the patient will recover or survive the stroke. The second thing I learned in the practice or in many studies is that neuroplasticity, which as neurologists, even we are not training our brains or even our family members or friends. We need to educate ourselves and our kids at least to build the neuroplasticity, which will preserve our speech or our motor functions in future if at all we get exposed to stroke. That's the only thing I wanted to say.
That's the beauty of the brain. It will improve on its own. That's why we are able all these maneuvers for the procedures. Or else we will be.
Thank you so much, sir. Because something beyond being explored here, that is always luxury for a physician. So I'm not a neurophysician, but outside the neurophysician point of view. So now, as since morning I'm listening, the timeline has been extended based on collateral point of view. So now it's creating a grey area between IVT versus EVT maybe. Like if somebody coming around 9 hours or 10 hours, now you are saying like maybe up to 6 to 9 hours I can thrombolyze. You have an option of EVT also when it comes to the 6 to 9 hours. So based on availability, maybe like. So if you have availability of both, what do you choose? Like how you suggest, like which one you choose or which you suggest?
So that's what, sir. If at all, if you want to do beyond 4.5 hours, means that is especially thrombolysis, you need advanced imaging. That is the perfusion imaging. And in the perfusion imaging, if there is a salvageable area of penumbra, based on that, you can do thrombolysis up to 9 hours. That is mainly in patients where there is no large vessel occlusion. That is mainly for patients where there is no large vessel occlusion. If the large vessel occlusion is there, I think in such cases, rather than doing thrombolysis, we can straight away go for endovascular thrombectomy or mechanical thrombectomy. Because the number needed to treat will be high and the chances of bleeding will be more. Because the more the infarct size, the chances of reperfusion hemorrhage will be more. Because already we are beyond time period. When you are doing thrombolysis over it, the already infarcted tissue, what will happen is, just like when the pipe is opened all of a sudden, the gush of blood will flow and the chances of, because it is a lighting, the chances of bleeding will be more. That's what the bridging therapy means, thrombolysis followed by mechanical thrombectomy. Direct MT means in beyond window period, that is beyond 4.5 hours. Mechanical thrombectomy may be better rather than bridging therapy.
So it's like large vessel is the deciding factor, and because already brain tissue barrier has been affected, so bleed risk is high.
Yes.
So like, do you think this will even beyond extend beyond 24 hours?
No, it may be, sir. Means at this point of time, the trial says up to 24 hours. Means actually, that's what I have shown some case scenarios.
Because I see because 4 days after that you presented.
Exactly. Means the trials above, means those are not classical occlusions. Those are more like a the trials will be done and it time according to the guidelines it says maybe up to 20.
Like as you mentioned, like because the availability of these all high end like areas will be less. So
has a rapid software. Means, but still, most of the intervention persons are doing cases. Means, if there have the luxury of rapid software, it is well and good. But lack of rapid software or the advanced imaging doesn't mean that you should not intervene. So that's what. It is a game of collaterals.
When the support of backup support of that is not available, stick to guidelines.
Like I don't understand, like as you mentioned, like if it is a larger occlusion and they presented early and they presented up to like 18 hours or 20 hours, do you think there is any difference between doing the both?
That's what.
That's what my thought was in this.
It is like means exactly we can't predict. Suppose if a house is on fire, we won't wait. No, sir, we will immediately call the ambulance and we will try to subside it as early as possible. It is just means better the early is the means intervention, better are the outcomes. Obviously, it depends on the collaterals. Means before doing the intervention, we don't know how the collaterals are given. Means to ideally to assess the collaterals especially like pile or leptomeningeal collaterals, DSA is the gold standard. Means thinking that the collaterals will be good, we can wait till 24 hours, that should not be done. We must do as early as possible. So as we delay, by each and every minute, the neurons will be dying and the brain will be getting aged. For every 1 hour delay, the brain gets aged by around 4 to 5 years.
So, there is a last question. Do you think, is there anything you can do to increase my collaterals? Any condition, because my heart, because somebody had to prevent MIs, they cardiac condition, they do ask cardio, they do exercise, they control all this. Anything like just a curiosity, I'm asking, anything I can do with this to increase my collaterals?
No sir, as of now there are no such drugs to improve the collaterals. Maybe in future it may come.
Thank you so much. Thank you so much.
If there are any questions from the audience? If no further questions, we'll conclude the session. Any question? Yeah. One question from the audience.
Sir, if patient is staying within 7 hours of window, that large 1/3 of MCI territory is involved, but aspect score is 3. In that scenario, we do mechanical thrombectomy followed by hemicraniectomy and alone hemicraniectomy, which is greater and why?
That's what these high aspect score trials. There are almost 5 trials, Select 2, Angel Aspect, Last, and there are 2 more trials. In these trials, what has been proved is, I have shown you as well. These are the trials where the cases have aspect score of 3 to 5. Means high means lower the aspects, large is the pool. Means as we go down, the chances of outcomes will be worse. But 3 is also included in such cases. Obviously, we need to take on patient by patient basis. But aspect score of 3, we can do. It's better to go with mechanical thrombectomy, then followed by decompression, early decompression. Because at the end of 1 year, when you analyze those trials, the functional independence is more. That is, they have reached almost MRS3 in high chunk of patients are around 1/4. Means it may not be helpful in mortality terms, but functional independence terms, it is definitely of advantage and helpful.
So, like in one comment. So, for collaterals, you were asked, right? So, collaterals, it was noted that when patient has diabetes and high sugar, the collaterals are really bad. They do really fast progressions. So that is why in those patients with high metabolic risk factors, the progression is fast and the intervention doesn't do well. IVT doesn't do well, EVT doesn't do well. For good collaterals, metabolic health is important. There are studies, but there is no drug, as he said. Exercise and metabolic health.
Good afternoon, sir. Sir, as sir asked about collateral, is there anything that we did about collateral? I just wanted to know, are there any studies suggesting correlation between cognition, improvement in cognitive function and collaterals? It's just curiosity that I wanted to know. Like if we work on cognitive function, will the collaterals also improve, like the chances of
Obviously, ma'am, obviously. These collaterals for each and every part of the brain, and the cognitive function, when you measure the cognitive assessment, there are multiple domains in it, and with the different better collaterals, the cognitive outcomes will be definitely better. Cognition is one thing which will be ignoring in case of acute stroke cases, but you follow you can definitely see that there is cognitive impairment also. In patients who have got recanalization or with better collaterals, the cognitive outcomes also will be better.
Thank you.
Thank you. Let's conclude the session.
Thank you, sir, for the insightful session. I request the chairperson to hand over the memento to Jagadish, sir.
Sir, look here. Sir, sir.
I request Dr. Ravichetan sir to hand over the token of appreciation to chairpersons Dr. Venkatamna sir and Dr. Nivedita ma'am.
Sir. Sir. Up. Sir. Up. Okay, ma'am. Okay.
I request Dr. Lakshmi Lavanya ma'am to hand over the token of appreciation to Dr. Ravichetan sir.
Okay.
Due to speaker unavailability, the session on advanced imaging and interventions in late window period will not be held. Sorry for the inconvenience. We now proceed to the next session. For chairing the next session on recurrent stroke, I request Dr. Neelofar Ali ma'am, consultant neurologist at Astor Prime Hospitals, Dr. Shivasai sir, consultant neurosurgeon at Kamini Hospitals, LB Nagar, Dr. Varun Reddy sir, consultant neurologist at Yashoda Hospital. And I request Dr. Shivasai sir to introduce the speaker of the next session, Dr. Muralidhar Reddy sir. Thank you.
Good afternoon, one and all. I am Dr. Shivasai, working as a consultant neurosurgeon here in this Kamini Health Center. So I'd like to introduce our next speaker, Dr. Y. Muralidhar Reddy sir. He's a lead consultant neurologist at Renova Century Hospital. Sir completed DM neurology from Nizams, and also he did DNB in general medicine from NIMS, and also he holds some fellowships in American Board of Electrodiagnostic Medicine and also neuroimmunology and neurosonology. And sir has more than 50 index publications, and he has received awards from recent 2022 INCON and patrons from in 2022. So we would like to welcome Dr. Y. Muralidhar.
Thank you. Thank you very much. At the outset, I'd like to thank Dr. Lavanya for actually inviting me for this presentation. I have actually not met her before. This is the first time I'm actually associating with her. It's nice to actually have interaction on phone. So the presentation that was given to me was recurrent stroke. This is more of a preventive kind of thing and the practical problems that we face in day-to-day life, day-to-day clinical practice. Actually, the outline of my presentation would be I just run through the incidence and also the morbidity of the recurrent stroke. You all know, as physicians, general physicians, emergency physicians, and neurologists, you all know that once a stroke happens, there will be definitely a recurrence. So, and I just show some studies about the causes of the recurrence. Many causes actually the practicing neurologists will be already knowing. So I'll just put it in a systematic way so that I can synthesize some synopsis and show some cases which from my practice and give some take-home message at the end about what to be done in patients with recurrent stroke. This is actually a stroke registry. This is HSDR stroke registry. This is an ICMR driven trial. Our center is also actually going to be part of it. So they collected data from more than many centers from all over India. So this is a collective hospital-based stroke registry data. It actually shows that even in this data, this is as latest as 2025, there is a recurrent stroke of about 11.1%. So that is the incidence of the recurrent stroke. Usually also, we also must be seeing around the same number in the clinical practice. 11% if you see 100 strokes, 10% probably will recur. So the causes will be many. And as you can see, actually the MRS is also very much worse. In patients with recurrent strokes, the patients will serially actually deteriorate. They become from MRS 2 to MRS 3. That means they require support to do activities, later slowly become bedbound, and some recurrent strokes patients could die also. So there is a lot of unmet need actually to prevent these ischemic strokes, to prevent these strokes. So I just show some meta-analysis. There are some very, very good studies which are done from India also. This study is actually a very good study. This is actually the collective evidence of all the studies right from 2000 till recent things. I have just submitted actually. There are various mechanisms. So mechanism of stroke is nothing but Toast classification or Oxfordshire classification. Dose classification is all that we use. Actually, the large artery disease strokes have high risk of, as per the systematic review, it has high risk of recurrence, and cardioembolism has high risk of recurrence. Small vessel diseases will have less risk of recurrence. I'll tell you, small vessel diseases, if you see a vacuum in a clinical practice, we actually send them, but after some time they come with a cognitive impairment. So the recurrences in small vessel disease happen actually silently, whereas recurrences in patients with large artery atherosclerosis and also cardioembolism, they are very obvious. So in small vessel diseases, the patient will be fine, there won't be anything. At the end of long duration of the vascular risk factors, they come with some kind of cognitive impairment. They may be having these things. So the recurrence in small vessel diseases will be silent unless we control the risk factors. The recurrences in large artery disease and cardioembolism will be very overt. This is what the message I wanted to convey. And not only the mechanism, it is also about the high risk recurrence. These are all the conventional risk factors for stroke only. But among these risk factors, if you don't control these risk factors as per the systematic review, these are the risk factors which are shown to have high recurrence rates: uncontrolled diabetes, hypertension, smoking, and atrial fibrillation also. We think actually we are giving some drugs, rhythm controlling drugs, but there could be, patients will be throwing, there could be some bouts of paroxysmal AF in between also. So prior stroke and higher MAHs. So these are all very common language which we all understand. And this is an process which was done, but it is always not a rule like this. So there are other studies which actually also showed that the recurrence did not differ between the LAA and also cryptogenic strokes. They are all same, and these are the p-values of patients with hypertension, multi-territorial infarcts, and also dilated areas. They have high chances of recurrence, and suggesting that usually in patients with recurrent strokes, the source usually is the cardiac source. So this is again another Indian study which was actually concentrating on the young adults, showing that actually rheumatic heart disease, uncontrolled diabetes, and coronary artery disease, these are the risk factors for recurrence. So this is another study which has been recently published in JAMA, suggests that the recurrent stroke even in the young adults also are more, but usually in young strokes we should actually search for cervical artery dissections and also other rare causes of strokes. So, and one more important thing is actually we prescribe the drugs for patients as per the guidelines, whatever is there, we impress upon them. But DAPT compliance is one of the very antiplatelet compliance is very one of the main and important factor of the stroke recurrence. So this is one of the studies of the characteristics of the recurrent stroke. As you can see here, out of all the risk factors, what I actually run through in the previous all slides, actually it has been just shown that DAPT compliance is one of the major factors that determines actually the recurrence of the stroke. We tell patients, but patients don't take because of many reasons. So just continuing to this study, I will just show that there was a wonderful study by Thomas Matthew et al. From Bangalore. Actually, he has shown why actually patients discontinue. These are all the reasons that you may be come across. Lack of awareness, patients come, patients get treated, and after that they will blame us. They will tell that I don't know, I was not told. So he became normal and they discontinue the medication. And some people in India, they resort to alternate medications, which are very popular also in some districts and some places. And medication side effects. They don't come and discuss with the doctors. They just stop by themselves. If there are any bleeding piles, if there are any tooth extraction, they stop, and after that they continue stopping it. They don't discontinue. And if they are going to multiple doctors, actually the repeat prescription, some antiplatelets will be usually missed, and it will continue like that. So these are all the common problems that we encounter in clinical practice. And financial constraints, that is definitely very pertinent to our country. Beyond aspirin, people may not actually afford. Sometimes if you actually give ticagrelor or even clopidogrel also, some people may not take. And some patients, especially people who are they actually wrote no assistance, but some people may be dementic after strokes. They may keep forgetting whether they have taken medicines or not, and some people may not have that much independence to take the stroke also. Some people may be depressed after stroke. You must have encountered many people who come to the OPD after stroke. There is nothing. They feel so depressed, and they discontinue the medicines by themselves also. So these are all the risk factors that have been jotted. These are the group of patients where majority of the patients who they actually showed that recurrences are very high. And as you can see, this time is also very important. Sometimes we see patients even for dental procedure, if they stop antiplatelets for 1 or 2 days also, sometimes they come with not bad strokes also sometimes. So if they stop for, the proportion of the patients who develop stroke is very high if they stop for 2 to 15 days, and beyond that, whatever statistics have shown. So these are all probably we all know all these things. Maybe it has been put in a very systematic and a very nice study by the authors. And one more thing that has been coming up after the RescueBT trials was actually the clopidogrel resistance. This we actually have not heard, at least when I was getting trained, but over time actually there is a lot of now past 3-4 years clopidogrel resistance assays and many things are being done. So clopidogrel resistance is very common in India. We have to actually test for that. We actually get it tested now, at least when there is a recurrence only, not on a routine basis we don't check. So, but we make sure that actually patients, the clinical features, when do we suspect clopidogrel? These are the genetic polymorphisms which we have to look at. This is 3CYP2C19, 3 and 8. Actually, whether it is a wild type, whether it is the genotype is a wild type or a non, and the other things we should also check, and whether we are giving the proton pump inhibitor, especially the drugs such as the omeprazole and other things, because both actually get metabolized by the common CYP450 only. So the metabolism of the clopidogrel can get impaired if you give PPAs along with the same. And this is more common clopidogrel resistance in elderly age and female gender, and especially in patients with diabetes also. These are all the indications how we have to suspect clopidogrel resistance. So this is another thing, resistance. And there is another important thing is behavioral problems, and also not taking all these things as presence of depression, presence of memory problems, and even after the stroke, if it is a minor stroke, actually patients they will have that kind of, even as basic humans, we also have that. If there is any health related issue, we also concentrate on our health for initial first effect, maybe 1 month, 2 months. After that will not be, because that is a basic thing. Actually after that they don't be so particular about controlling their risk factors, and they resort to the old habits, and again there will be recurrence also. Actually this is one of the very good studies, Sprint India study, actually where we were also part of when we were in Care Hospital. Actually this is a study where there was a booklet that was being given to one set of patients. A booklet was not given to one set of patients. The booklet contained the material for the stroke and everything, awareness of the strokes. So people who have taken the booklets, ultimately it didn't change the outcome at the end of the study, but their LDL and also their taking medications were slightly better, suggesting that if you educate the patients and if you spend time and give some material to them, probably they are better actually. There are many secondary analysis and studies which have been published based out of this data, which I am not going to that. Why I wanted to show this study is actually behavioral, educative material and also behavioral education for the patients can actually address these some unmet needs of recurrences. And this is another very important, very useful slide. If the patient has a large artery disease, one study of recurrence events. So the large artery studies, large artery patients mostly will have large artery diseases only in the next time if they have the stroke, recurrent stroke. But patients who have lacunar stroke, if you see, they can have a diverse types of stroke in the next time. It need not be always lacunar. Actually, this is the conclusion of this graph which I wanted to tell you, that second stroke need not be of the same mechanism, it could be of different mechanisms also. So this I have just taken a picture of this. So these are the various prediction models which have been put. We can actually do all these things, but ultimately care is always individualized patient to patient. There are some parameters which I am not sure what is the relevance without combining with the other factors like the mean platelet volume and other things. So there are some prediction models like framing heart, and there are prediction models like that even in patients with recurrent stroke. So summary of the causes, putting all this literature into this, why actually patients develop recurrent strokes? Because of the mechanism. Usually the large arteries and also cardioembolic strokes are more prone to recurrence. Second thing is inadequate workup for the mechanism. There are many reasons for inadequate workup for the mechanism. It is because of the limited investigation, availability and in the particular center, and even the patient factors like they are not affordable, some investigations are costly, if you have to go on investigating for the very, very minor, rare causes, actually we spend a lot of money. So there are many things, and many strokes also end up with the physicians, so they may not do the adequate complete workup also. All these things are actually important. And basic human behaviors also, the inadequate risk factor control. Inadequate risk factor control is very important, and it can lead to multiple strokes also. And inadequate antithrombotic therapy. So after practicing, and even the neurologists who are chairing and even in this session also must be knowing, there is no best antithrombotic medicine. Despite giving the best antithrombotic regimen also, patient go on recurring. I will show some cases, you'll understand. There is another mechanism, there should be another mechanism of stroke. So I will show some cases also, you will understand. We must have thought it is a lacunar infarct, but it may not be lacunar infarct actually to look like that. So, and other determined causes, we may have not searched for dissection, we may have not searched for the symptomatic, sync, the non-stenotic plaques, we may not have searched for the carotid wells, we may not have searched for the many other things which I will tell you in the subsequent slide. So all these things, they determine the appropriate, the antithrombotic medicine and also the duration of the therapy also. So I'll just put it as a summary of synopsis. See here, actually there are some patient-related disease, patient-related factors, some doctor-related factors, and even some factors associated with the disease-related factors. Like patient-related factors, poor adherence. It is a very important, and inadequate workup because of the low-income patients, and even in some hospitals with poor availability of the test, and poor control of many risk factors. Depression, memory problems, these are all the patient-related factors which are responsible for the stroke. And from the doctor side, if you inadequately work up for the mechanism and cause, then also we may end up giving very low doses or inadequate doses of the drugs. And there are some factors like patient-related factors. For example, patient has multiple comorbidities. If the patient has gastric ulcer, if the patient has piles, if the patient is going on to any major surgery or any kind of thing, so we actually tend to hold antiplatelets. So these they will be at the crossheads. So we have to decide about the appropriate. We don't go on giving aspirin in a patient with bleeding peptic ulcer like that. So, and we should not miss out on cancer and the therapies, other determined mechanisms and the global. These are all actually I have been repeating in a different perspective. So I'll just show some cases here. So this is a constellation of around 7-8 cases. So I mean these are all the cases from my practice. So so this patient is a 57-year-old female. Yes, this patient is a 57-year-old female. She is only dyslipidemia. Actually, she came to us around this time. She came to us in February 2025. Actually, she was managed at a district place in 2024 July. So she had right hemiparesis, left hemispheric infarction. I don't have the scans of that time. And this patient used antiplatelets, but as usual, son came and saw, okay, she felt better, she was doing all her activities, and she stopped antiplatelets. So what happened? Again in February 2025, she had stroke. After February, she must have come to us in July, something like that. June, 2 months later. She came 2 months later to us. That time somebody has started DAPT at 3 months. And what I did is, okay, you continue DAPT for 3 months because it looked like a large artery disease. And after that, I changed to CPD, that is, gave only aspirin. So what happened? On aspirin, again in June, patient had a stroke. This time again she came. From this time actually she was coming to us. So this is the time when she had again right hemiparesis. Actually she was telling actually that from this right hemiparesis she did not improve completely. She had some problems. She has some cognitive problems, also some dystonia, food dystonia because of many basal ganglia problems and other things. And in June 2025 she came. That time again she had a recurrence. And this time on a single antiplatelet she had a stroke. So she had an active plaque on an MRI. I show the images, and from then on actually we started on aspirin and ticagrelor. Actually after that also she had a loose stool. She did not come again. So she had a loose stool followed by again weakness, and she's almost bedbound. So despite best antithrombotic therapy for the large artery disease, still the patient had a stroke, and that's the reason why that's what I was telling. There is no best drug. Actually, there is a new therapy that is coming, like factor 11A inhibitors, which are milvexian, and these are all the latest trials. Actually, this is actually if I have to tell a little bit about milvexian or factor 11A inhibitors, it is something like a it was discovered that there is a molecule such as factor 11A inhibitors in some snakes. They actually have they can actually they can help in physiological thrombus formation, not pathological thrombus formation. That means if you are taking milvexian, if there is any bleed inside, microbleeds, they will actually heal by themselves physiologically. But pathologically, if there is an injury or anything, they will help that time actually in forming the clot formation. That is a concept based on which factor 11A inhibitors are being introduced. I think they will come into market soon. So this patient, what I'll show, this is actually July 2025 scan. You can see the old stroke, some atrophy, whatever is there. The angio, you can see this is the ICA for the physician, for the general medicine people, and this is the MCA. The MCA is completely blocked. So MCA blocked does not mean on MR angio is MCA blocked always. Actually, MR angio can overestimate the stenosis always. We have done the vessel wall imaging because the vessel wall imaging is becoming more and more popular of late. The MR vessel wall imaging series is actually a non-contrast sequence. You are seeing some hyperintensity along the vessel. When there is a hyperintensity on a non-contrast sequence, this is actually an intraplaque hemorrhage all along the MCA. So this is a sagittal sequence. This is a sagittal sequence, zoom sequence, this is a coronal sequence, and these are the contrast. Actually here contrast did not add much. It is adding just to show that there is an enhancement in the subacute infarct. So this is the role of actually MR vessel wall imaging, what I mean to say. Maybe after learning from this case and actually going through the literature, I am not showing that. Actually I feel in a large artery disease, now the consensus is give dual antiplatelet agents for 3 months, after that change over to CPD. But actually whether to continue dual antiplatelets after that, we have seen many patients in large arterial sclerosis recurring after 3 months of made into CPD also. We don't know what actually is happening inside in the patient, but what I feel is we have to do one vessel wall imaging, which is a very sensitive technique to actually pick up the active plaque. And if the vessel wall imaging does not show active plaque like intraplaque hemorrhage or outward remodeling or anything, probably we can change over. But this is nothing. I feel maybe such kind of trials may come. So what the lesson from this case is, actually you can see here the lesson from this case is patient stopped antiplatelets. It is a poor adherence. And even after giving the adequate antiplatelet therapy as per the guidelines, still the patient has recovered, still the patient has the problems. Actually, even after giving dual antiplatelet agents, still the patient has recovered. The lesson from this case is the reasons for so many recurrences is an active plaque which is there, but there is no best anti-thrombotic regimen that we can give for this patient. Some people do give Plexin, some people do give, some people do give maybe acitrons and other things, but I am not sure it will help like that. So these are the causes of recurrences in this patient. And this is another case. Actually, this patient came in April, just recently only. So this is a 72-year-old male patient, hypertension, diabetes, hypothyroidism, coronary artery disease, triple vessel disease. He was referred from a cardiologist. So when we get reference from another doctor, that doctor holds all the grip on the patient. So whatever we tell, we cannot release that grip. So cardiologist had a grip. So why I tell you all these things? Because practicing neurologist must be experiencing all these things. So in August 2024, there was a left hemiparesis. With that, actually, he was referred to me. So there is a right hemiparesis. And that time, actually, right cervical ICI, it was a near total occlusion. Near total occlusion, we mean 70 to 99% stenosis. So ideally, at that situation, we should do carotid revascularization. Either we have to do stenting or either we have to do carotid endarterectomy. Without those two procedures, even the best antiplatelet agent sometimes cannot save the patient. So accordingly, we suggested, attendants are also doubtful, surgery, all these problems. We don't want to get it, and probably cardiologist has influenced them. And what happened? There is CAD, all the risk why we do antiplatelets, and they continued like that. And in November they did not come. Even they did not come to our hospital. He had a left hemiparesis, and he was not changed on to any other treatment. He was continuing the same antiplatelets, dual antiplatelets only. In April 2026, when he had a third attack, after a diarrheal illness, he came to us. So at that time he came to us. By that time what happened? Actually, ICA was completely occluded. So this is the infarct that he has. Even on the left side also you can see a small infarct is there. But this is an acute and chronic infarct on a diffusion imaging. So this is acute infarct. So this is a flare. You can see so much of gliosis which is there. So, and you can see the angio. The ICA is not visualized here. There is only intracranial top imaging, and CT angio shows complete occlusion of the patient. So this patient was completely, now it is point of no return. We have to just wait to just improve the collaterals, and we suggested bypass for the patient. Maybe that's what we can help them in that way and prevent any kind of any BP drops, rapid BP drops, and any other things, maintain the perfusion, that's all. So this patient, actually the cause of recurrence in the patient is patient was not willing to undergo we could not control the source. The source is actually here the carotid plaque which is there. So unless we control the source, here we define the mechanism, but we could not control the source of the patient. So unless we could not control the source, probably, and the patient recurred like that, and ultimately he himself went on to develop complete ICA occlusion. So what I mean to say, the lesson from this case is we have to actually treat the source properly. So if at all the patient is a cardioembolic source, for example the heart rate, AF is there, and we have to control the heart rate. May not be rhythm control, the heart rate control we should do. Heart rate control is very important. If you don't control the heart rate and keep on giving apixaban or dabigatran, even it can also cause recurrence. It can lead to failure of those drugs. So controlling the heart rate less than 98 is very, very important in those patients. So this is another case. So the third case, She is yes, she is another very difficult, troubling patient. She came recently. So 69-year-old female. She has been following up with me from the previous hospital. And in December 2021 she came. That time she had dysarthria, small infarct around this area. I'll show the old imaging also. So same like that. And we thrombolized the patient. We thrombolized. No, she didn't come that time. She had an SPD and she was put on SAPD. She came in May. That time she had left-sided weakness, right frontal infarct, and we thrombolized that time. Actually, we do a very decent workup. We have done CTA, we did PE, we did Holter, 48 hours, 7 days. Everything was negative. No AFs, nothing. So probably ESAs only. So, but still with some pinch of thinking, we gave DAPTs followed by SAPTs, and the patient was an SAPT. In June, she was admitted into the another unit of our same hospital. Actually, with a diarrhea illness, that time there was an occipital lacunar infarct. Actually, this was not the territory she had before. She had right frontal, and this was an occipital lacunar infarct. And okay, SAPD I continued because everything was normal, and she didn't have, that time actually she was admitted with diarrhea, post-GEARF kind of picture, encephalopathy kind of picture. This is in April 2026 that she came again to us with actually left facial brachial hemiperipheral, TIA. It is like a TIA presentation, not TIA present. I won't say TIA. By the time she came to us 1 hour, it was a stroke. MRI showed this. So it is a stroke. But we thrombolized the patient with now TNK. We thrombolized with TNK. So we did CT angio. We did MR vessel wall angio, new modality. We did TE. Now people are doing cardiac MRI. We did cardiac MRI. We did, and she kept on actually having same, sir, every day morning rounds. My left is in front of me only. One day actually patient had weakness, and she is conscious only. So they are all TIAs. Patient was actually getting TIAs in the same territory. Whenever there is any same territory complaints, actually we should always think the problem in the same vessel. But the vessel was completely clean. Even MR vessel was imaging, it was clean. So I got ictal EEG. Ictal EEG is also normal during the episode. There is nothing. So I don't know actually this case. This is the. You can see in the diffusion there is some the old gliosis which was from the old stroke. The MR angio is so clean. I am not showing the serial MR cine images. This is the vessel wall imaging which is also clean. Cardiac imaging which is also normal. So I don't know. So this is actually a patient of ESAs, real ESAs, everything done. So this patient actually right now there is no recommendation of starting anticoagulation. But I started an apixaban for the patient. I don't know, she may throw one more MRI and come. So this is again a case of recurrent stroke where actually mechanism, despite what I am trying to tell is there is no best antithrombotic therapy even now available. Patient will keep on having strokes, we don't know sometimes, despite the best workup. This is another patient. Actually, she had in 2023, a young lady, 2023 TIA-like presentation. All the workup was normal. That time she had a right frontal acute infarct. So TIA, frontal acute infarct, it is ABCD, I score. So, okay, young lady, always anxious. So all the workup is negative. Okay, use antiplatelets. And she came to me in 2020, actually in February or something, or almost 2 years later, I stopped antiplatelets. You stop antiplatelets, nothing will happen. Nothing, no risk factor. How long I have to use? Sometimes the patients also tell, how long sir I have to use? Okay, you stop now. 2 years there is nothing. Just see. So again, TIA, MRI was showing no acute infarcts. We stopped antiplatelets in February, and again she came with a stroke. You can see here, she came with a stroke. Actually, I don't know how we missed her. So second time when she came, actually there was a carotid web. So this is a carotid Doppler. There is a carotid web. We did CT angio. We didn't have the images. Actually, carotid web was there. So this is a young lady. You can see 27-year-old lady only. So these are some of the rarer causes of stroke we have to search for such kind of things. Previously, carotids webs were just thought they are just lying there, they are not related. But now there are simple webs and also complicated webs. Complicated webs associated with atherosclerosis. They are shelf-like projections. They can have the pooling of blood and they can cause local turbulence and it can throw the emboli also. So we have we have to be on antiplatelets forever. And if it is a complicated web, sometimes we can resect them also. We can open and resect them also. That is also one type. This is another patient, young boy, again 23-year-old. He is a medical student. He had no comorbidities. Actually, he came around May. This is the time when he came to us. So he told that retrospectively 6 months before I had some diplopia which recovered. Okay. Retrospectively after the history we thought it could be a TIA. So when he came to us, he came with a posture circulation symptoms. As you can see, there is a midbrain and also midbrain infarct. It is just in that. So okay, we have started on apixaban and letrozole. I tell you why. Actually, young boy. So medical student, they are also worried. He is also worried. There are so many questions. Conventional imaging, everything is normal. This is normal. This is DWA. CT angio is very clean. Okay, Holter is very clean. So when they were doing TE, actually Holter we didn't do, I think. Yes, we did because cardiologist suggested. Holter we did TE. TE was showing a thrombus sitting in the pulmonary vein, and this is actually pulmonary vein thrombosis. Pulmonary veins actually drain into left atrium. There was thrombosis just adjacent to that. This pulmonary vein thrombosis and thrombus is very common in patients, is usually seen in post-CABG patients and any bypass patients. So this is actually a case report that we have actually published. So this patient actually was treated as per the cardiologist. We give apixaban, okay, give and again give antiplatelet, now give an antiplatelet. So in ESUS patients, sometimes these things we have to actually rule out. I don't know. I mean, it is a pretest. Finding these things as a pretest probability is less, but maybe in a patient who is asking, who is willing, we should test all these things also. And this is another patient, last but one. She is just a few days back we discharged. 52-year-old male patient. She is a diabetes, hypertension. She was again referred from a cardiologist. She underwent PTCA in our hospital in December 2025. So December 2025, just 6 months ago. So she was on dual antiplatelet agents only. So what happened is actually she developed some hematuria, I think 15-20 days ago. She called cardiologist. He told her, okay, stop antiplatelets temporarily, get some urine test and all those things. Okay, she stopped. And she came with left hemiparesis of 1 day duration. So examination showed left hemiparesis. Okay, this was slightly larger than vacuum. I saw an OPD. She came, she had complaints on Sunday. She came on Monday to us, no OPD. Okay, like larger. There were, admission, we have to get admitted. Children are there at home. Okay, then you go, no problem. We'll monitor in the OPD. I told, okay, then on the verge of OPD, I think some discussion happened. They told, no sir, we'll get admitted in the hospital. So I admitted the patient. So MR angio is normal. So thing is actually because there was hematuria, routine investigations show she's not a CKD. Creatinine was 1.7. So 1.7 creatinine, okay, you get ultrasound abdomen. Ultrasound abdomen was showing actually endometrial thickness, which is, see the postmenopausal lady, almost 15. And she had nodes and also radiologist was telling. And after that, right hydroelectronephrosis, we'll get NCCT, omental caking, many other things they told. And we did a PET CT. PET CT shows multiple metastasis in the lung. So we did endometrial biopsy. I thought, thank God, actually they are admitted. So this is actually a patient of a hypercoagulable state secondary to occurred malignancy. These things we have to actually rule out. So these are all the causes. If you miss out on these things, no, patients can keep on throwing emboli. Maybe if not me, somebody would have picked up. Practically, we should keep an eye on this. And this is another last patient. Yes. This patient is a 79-year-old male patient with a history of diabetes, hypertension, many other things. Actually, she was on clopidogrel and he was on clopidogrel and rosuvastatin, cardiologist. So examination showed dysarthria and right hemiparesis. So you can see here actually patient had an infarct here. So if you see actually patient came with right hemiparesis only. He came with right hemiparesis only. No? This is the right-sided weakness only. Even in the pons, the infarct is only on the right side. So we thought it was ipsilateral hemiparesis. The mild irregularity of the basilar artery was there. So we did MR reservoir imaging. There was an eccentric enhancement which is being seen here, suggesting that there is active atherosclerotic plaque. This is a large artery disease, not a. It looked like actually a small vessel disease, paramedial fontaine, but it is not. It is a large artery disease, and he was managed with the dual antiplatelet agents initially. So he was on clopidogrel. I added aspirin. So then, okay, we got this genetic test done. He was actually resistant to the clopidogrel. He is a poor metabolizer. So we again changed based on that to aspirin and ticagrelor. He is doing fine. So these are some of the cases where actually there were recurrences. We learned what actually happened, went wrong, and many other things. So this is a checklist actually. This is a checklist from the AHA only. So these are all the standard stuff for secondary prevention. The LDL, HbA1c less than 7, blood pressure 130/80, LDL less than 70. They tell now even 55 also LDL, and all this smoking, everything, all these things we should actually maintain a checklist. So what I wanted to impress upon you is whenever there is a recurrence of stroke, actually we should try to find the reason. So we should first think whether the mechanism that even the doctor who has actually worked it up, or even we have worked it up, whether is it correct or not. So for example, last case I was just thinking it is a small vessel, slightly branchiootomatous, we'll leave it, but it is not like that. So mechanism was not correct. So we have to review everything in total. And is the mechanism inadequately worked up also is very important. There are now so many investigations in preventive care, not like rapid other things. We can use CT angio, vessel wall imaging, TE, cardiac MRI, and PET scan also for any occult neoplasms, and to plaque imaging, extracranial plaque imaging to know the symptomatic, carotid and aortic arch atheromas, carotid webs, PFOs by doing the bubble test, PVTs, pulmonary vein, and even cancer. So all these things we have to actually keep in mind. Only when you rule out all these things, if the vessels are clean, then we should be okay, label it as thesis. Now another thing is there any drug interaction with the clopidogrel resistance? Getting PPIs in India is very easy. Over-the-counter medicine, they must be taking medicine. Sometimes they come to OPD, they tell some gas stuff, they don't know the names also. So we should always see whether there is any drug interactions and also clopidogrel resistance. We should also think, are the risk factors under control or not? So if they are not under control, we should optimize and emphasize it. And if the source is adequately treated, like I have shown one carotid endarterectomy case which was actually missed, and also like heart rate control and even heart function control also in patients with LV function and all those things. But despite all these things, also I have been emphasizing there is still no best antithrombotic regimen for stroke. So this is what I can show you from my experience and also from literature. So thank you for that. So at the same time, I would like to take this opportunity to invite to the conference. We are planning one conference, that is the Neuroimmunology and Neuromuscular Conference in July in Taj Deccan. People who are interested, please register. Thank you.
Thank you, Murali sir. It was a very extensive and informative session. And you made this session very interesting by quoting the case examples. I'm sure all the audience might have enjoyed this session. So I have a few questions here. So in cases of stroke with large vessel occlusion, so how long do you recommend dual antiplatelets and how frequently should we monitor? Like what is the exact approach you do for these cases?
Actually, we give for 3 months only.
Yes,
3 months, and after that I changed to SAPTs unless the patient had any other cardiac or any peripheral vascular disease. Then I do continue dual antiplatelets. The common dual antiplatelets that I use is clopidogrel and aspirin only. And if the peripheral vascular disease is involved, anything maybe stillose or anything, if the, for example, patient has GI bleed or any other thing, maybe silastazole in place of clopidogrel or aspirin I may use. But from our experience, we have been doing vessel wall imaging. I felt that actually at the end of 3 months, seeing the activity of the plaque by vessel wall imaging would help to determine whether to continue antiplatelets or not. There has been literature after reviewing that it can help actually. So right now the standard stuff of giving for 3 months is what is actually doing, and after these clopidogrel resistance things that have been coming up and I have actually shown a poor metabolizer. There are many patients with intermediate metabolizers also. That's the reason why I actually don't give single clopidogrel. I give only aspirin only nowadays.
Because many a time we encounter situations like maybe after 6 months or after 1 year when the patient comes to us with other non-specific symptoms. Sometimes the patient gets the imaging done outside and they bring the MRI with the angiogram. So in that case, still there will be like large vessel occlusion. So yeah,
Okay,
in those
there is
situations.
complete occlusion.
Yes, sir.
Complete occlusion, you mean to say?
Yes, complete or even, yeah, yes, sir. Significant occlusion.
Complete occlusion.
Intracranial, yes, sir.
Intracranial complete occlusion, I don't think we can do anything right now with any kind of therapy. But extracranial occlusions also we cannot do if they are, if for example, if there is stenosis, maybe we monitor the stenosis. Like we can get lipid profile and also do a carotid topper every 6 months and to see for the IMT. Maybe I made it like that. I heard from people in other places also that we have to reduce the statins only if the IMT is normal. Even if IMT not just based on the LDL. Okay, so that's what actually I do. But still patients do recur.
This question might not be related to the present topic, but I just had this question in my mind. Nowadays, most of the patients are on newer anticoagulants. So how do you approach if the patient is present within window period with the stroke?
Newer DOACs.
Yes.
DOAC patients actually, if dabigatran, it is very standard only. We actually give praxibine and then thrombolize. If the patient is on apixaban and other things, we are actually right now, it is not a standard of care, but we are actually giving the prothrombin concentrate. After giving prothrombin concentrate, we are reversing it and then thrombolizing the patient. So we are using prothrombin concentrates. Actually, in ISA, recent ISA, they told in the first lecture only, I think, there is nothing like prothrombin concentrates. And in a large scale study, it did not help. That means they also tried to use and see. But in whatever 3-4 patients I used who developed stroke, prothrombin concentrates did help. They did not cause any problem. So praxibine, if praxibine we use.
And the last question, sir. Patient, like on evaluation, if the patient has a aortic arch athyroma or an ulcerated plaque, so what is the drug of choice antiplatelet for the stroke prevention?
Don't know. It is better to tell. We are not sure. But there is one study, ARCH study only. You must be knowing ARCH study. That is actually the aortic arch study. It showed that actually dual antiplatelets or anticoagulation comparison between that it did help. So we are treating arch athyroma like any other large artery disease only. Large artery disease.
Antiplatelets are preferred.
Antiplatelets only. And yes, if it is very ulcerated plaque, it is then maybe when admission we find it, we give just for plaque stabilization for first 5 days anticoagulation. If that we do for any ulcerated plaque, any high grade stenosis, we are giving for 5 days anticoagulation, low molecular weight heparin only, followed by the DAPTs. After 3 months, SAPT.
Thank you, sir.
But these are all actually my practices are not rules. Maybe these are all debates. Every conference, these are all debates only.
Very detailedly explained, sir, regarding the recurrent stroke. We understood that it is very difficult to manage this condition, painful for the patient and even the treating person also. One more thing, sir, regarding this ticagrelor there is an increased risk of intracranial bleed and everything. That is the reason I think the neurologists are a bit skeptic regarding starting ticagrelor when compared to the cardiologists. Sir, what is your take on that ticagrelor?
I have not experienced so much of bleed. I don't remember any patient actually who had a bleed. At least people tell, but if at all there is an indication, definitely. If at all the patient has failed the conventional drugs, yes, ticagrelor is a must. But as a first line ticagrelor giving, we have not given. We give standards to aspirin and clopidogrel.
And giving anticoagulation along with a single antiplatelet, this kind of regimen, you advocate?
You are all approaching controversial things because you may be right, I may be right. Yes, when there is a CAD patient and also AF, or when there is a large artery stenosis and at the same time patient has an AF, something like that, then in that cases, actually it is because you are telling DOACs is because of the reason is heart only, no? So in that patient, it is better actually give a single antiplatelet and also give adequate things. But we should also in such patients consider left atrial appendage occlusion also. We should open that window for that we can go in a better way.
And standard duration for ticagrelor with 3 months only.
Yes.
Beyond that. Any questions from the audience?
Actually, I have a question. So after 3 months, you are telling that whenever other vascular risk factor is there, you are choosing the dual antiplatelet. So again, deciding factor to convert to single antiplatelet, it is by the cardiologist or other vascular surgeon or the neurologist. After 3 months, patient is having another vascular risk factor. If you choose dual antiplatelet, how long we have to continue?
Other vascular risk factors in the sense, actually, I mean to say severe peripheral vascular disease or coronary artery disease. So, I mean, if there is a severe coronary artery disease, they will invariably put stent. They will put stent or they will do any femoral bypass or other things. But after that also, they continue for almost more than a year, dual antiplatelet, after putting any kind of. I don't remember actually consulting like that for any consultant like that. But I mean, we may have discussed a case by case basis, but I don't remember exactly.
If there are no further comments, we will close the session.
So there was a particular case where you mentioned that the patient right in front of you had weakness of the lower limb, I think left side, repeatedly. Oh, sorry, upper limb, sir. So, do you have any experience using, even though this is not capsular warning syndrome or progressive stroke, any IV tirofiban for such cases?
Yes. We use tirofiban. I have not shown cases here. We have had good series of tirofiban. We presented as a poster somewhere. I mean, previous hospital we presented. Actually, tirofiban we use when there is a stroke which is actually worsening in front of us to just stabilize for that 72 hours. 72 hours is the we give for that duration. So, if you ask me specific indication, if the patient has been thrombolized and if the patient has not recovered or has been worsening despite thrombolysis, but there is no significant large artery occlusion or anything, yes, we have used tirofiban, one. And the second thing is if the patient presented within 96 hours, within 4 days, but within the 4 days only, from the first day to second day, if the patient has worsened, we give tirofiban to just stabilize it. And if there is early neurological deterioration, what I mean to say, there are various definitions for early neurological, 7 days, some people tell 5 days, some people tell. If even that cases, we use tirofiban. The standard dosing is as per the SQBT2 trial only. Whatever they have used, we have been using. I remember using for almost more than 15-20 patients. I cannot name it. I cannot tell you that exact, but majority of them stabilized. And they have not improved, I don't say. That fluctuation at least has smoothed down. Okay. Good afternoon, everyone. Sir, as you have mentioned that
Hello. Salute. Hello. Up. Salute. Up.
I request Dr. Kishan Singh sir to hand over the token of appreciation to the chairpersons.
Madam. Sir, okay, sir. Sir, okay. Okay. Sir, okay. Okay.
I request Dr. Lakshmi Lavanya ma'am to hand over the token of appreciation to Dr. Kishan Singh sir.
Yeah, look here. Up.
chairing the next session on stroke, chameleons and mimics, I request Dr. Naveen Reddy sir, consultant and HOD Department of Emergency Medicine at Kamini Hospitals, Dr. Sri Krishna sir, consultant physician at Kamini Hospitals, LB Nagar, Dr. Soumya ma'am, consultant neurologist at Kamini Hospitals, King Koti, to chair the session. I request Dr. Sri Krishna sir to introduce the speaker for the session, Dr. Lakshmi Lavanya ma'am.
Very good afternoon to everyone. So our next speaker is Dr. Lakshmi Lavanya Mupala, consultant neurologist. Dr. Lavanya completed her MBBS and MD in General Medicine from Pilanmeni Siddhartha Institute of Medical Science and Research Foundation, Vijayawada, and she completed her DM Neurology in Andhra Medical College, Visakhapatnam. She is a gold medalist in DM Neurology 2018 from the Dr. NTR University of Health Sciences, and also a recipient of multiple award-winning academician, recognized in neurological, national, multiple quizzes and conferences. Dr. Lavanya has five publications to her credit and also serves as a reviewer for Dr. NTR University of Health Sciences, Jaisalmer. Please join me in warmly welcoming Dr. Lakshmi Lavanya.
Thank you, sir. Thank you for the introduction. It's almost last session. I'm not going to take much time. I have to finish it as simple as possible. So coming to my topic, stroke, mimics and the chameleons. Name itself is telling that mimic is something is mimicking like the stroke. Chameleon means stroke, it presenting like atypical, so that we are thinking something else but we are missing the stroke. So already we have learned from the counsel that we have to follow the stroke rules. But sometimes what we have to think that not every stroke may not follow the rules. Why? Because stroke may present notoriously various type of presentation. Especially for the frontline warrior, for the emergency medicine patient. If you miss the stroke in the early hours, it sometimes leads to the patient morbidity and mortality will increase and sometimes leading to the death of the patient is also. So especially in the acute stroke case, so we have to believe, especially if the patient presented with the atypical presentation, we have to believe our clinical institution more and imagine gives some guidance, especially in the atypical presentation. So according to the definition, the diagnostic definition of the diagnostic error is failure to establish an accurate and timely explanation of the patient's health problem, and also at the same time failure to communicate that explanation to the patient is also a diagnostic error. So this is very important, especially in the present era, to protect ourselves from the various from the society or lawsuits. We have to be communication is also very important to the patients and the patient attenders. So any acute neurological symptom, if the patient is presented, broadly we can divide into, it's an obvious stroke. Any patient presented with elderly vascular risk factors, a sudden neurological deficit of weakness or something aphasia, we can obviously say that it's a stroke. At the same time, we can tell that it's not a stroke, like without any vascular risk factors. And if the patient is having unilateral element facial palsy, we think that it's not a stroke. The third entity is the stroke mimic. Something is mimicking like the stroke. So, for example, hypoglycemia. So, it is notoriously can present like any type of asymmetric or symmetric, any type of the neurological type of presentation. So, we have to think mimical also, but we have to rule out, especially hypoglycemia, we have to rule out any acute emergency care. And the stroke chameleons are atypical presentation, presenting like something else. But we have to keep in mind that we have to identify that. So nothing but true condition, stroke, stroke-like presentation, stroke. It's not a stroke, but presenting like stroke is the mimicker. And true condition but presentation atypical is the chameleon, and last entity is the non-stroke. So these mimickers are false positive, so it leads to overdiagnosis, overtreatment and burden to the patient. And chameleons are the false negative, leading to the underdiagnosis, sometimes chances of morbidity and mortality also we can see. So any acute neurological patient from the morning, we are listening that timely and the correct diagnosis is very important. What we have to consider in any patient with acute neurological complaint, abrupt onset of neurological symptom, we have to think about the stroke. Some patients, we already told that may present with atypical presentation. In those patients, complete and systemic neurological examination will give clue us that even though with the atypical presentation, whether we are dealing with a stroke or something neurological or the non-neurological. Sometimes even advanced imaging can miss the diagnosis, especially in the early hours. Negative imaging we can see. In those situations, we have to believe our clinical institution. So even in this advanced sophisticated investigation era, technology may support the diagnosis, but detailed history taking and the careful clinical examination is the cornerstone for the diagnosis of any patient. So we have to listen to the patient. He's telling diagnosis sometimes for us directly. So why accurate diagnosis is very important? Because stroke chameleons leads to misdiagnosis, leads to the delayed treatment, and at the same time mimickers leading to the avoidance of the unnecessary investigations, thrombolysis and the treatment burden to the patient. And also we may delay the actual treatment of that particular condition, especially if it is a hypoglycemia. If we don't treat, it leads to the permanent neurological deficit to that patient. So this is the journal published in 2025. From the last 30 years, they have published that the misdiagnostic rate can be seen at all possible stages of the caretakers. The misdiagnostic rate, but pre-emergency or paramedics is around 28%. In the hospital with the emergency medicine residents, it's around 12.5%, and by the neurology residents, it is around 6.3%. So already morning counsel told that it's not a harm to giving mimickers thrombolysis, and the risk of the thrombolysis is less in mimickers in comparison with the actual stroke. It's around 0.5%, but the risk of bleed sometimes will land up into soup or unnecessary lawsuits. And at the same time, we will treat over-diagnosis, over-treatment and cost burden to the patient. So there is no pathognomonic feature that can really differentiate mimicker or stroke or actual diagnosis of the chameleons. But the points, some things can give us clues of history taking and the examination or young patient, but nowadays we are seeing more and more number of the young patients also without any vascular risk factors and previous history of any migraine, seizures or cognitive impairment like that. It gives that something we are dealing with that mimicker condition. The presenting symptoms of altered confusion, chest pain, gradual onset, fluctuating course, it can give you that maybe some atypical thing or the mimicking some other disease. At the same time, on examination, normal eye movement, normal neurological examination, the patient is presented with some abnormal stereotypical movement, then we clue that maybe functional disorder or something else we are dealing. So many conditions can present like focal neurological complaints. Even abrupt way of the presentation can be possible. The most common one are the metabolic. Among them, we have to rule out hyperglycemia. It's must, and we shouldn't miss this one. And also hyperglycemia, warning is encephalopathies, other metabolic encephalopathy, hypoxia, hypercarbia related, and some infections, meningitis, meningoencephalitis may present like abrupt neurological complaints. But on history taking, we can have some clue that it's not a stroke. Even other neurological condition can mimic like the neurological deficits like seizures, migraine, and some functional disorders. Miller-Fisher variant of Guillain-Barré syndrome, sometimes we may think that brainstem stroke like that. And even toxins and tumors also may present with sudden onset of the neurological complaints. So before giving thrombolysis, from the morning we are hearing, but checking of the glucose is very important. Even we find that the hypoglycemia is there, we have to treat, but again we have to do the imaging. It's not a stroke, but we have to correct the hypo or hyperglycemia at a time, and we have to work up for the acute stroke case. So I already told that hypoglycemia is globally metabolic abnormality that can present at any focal neurological deficit. In all potential stroke patients, it is mandatory to check the blood glucose levels. If not treated, I already told that it leads to the permanent brain damage. But again, we have to keep in mind that if the patient, we are suspecting that hypoglycemia, but in glucometer it's normal. We have to think some conditions like if the false elevation, we can see in some conditions like severe anemia, hypoxia, and high pH situations. We may glucometer falsely show the high glucose levels. And even the peritoneal dialysis patients also, the acute strip may show high glucose levels because of the maltose concentration. Again, operator error, simple presence of the dextrose fluid on the skin of the strip can cause the hyperglycemia. So, based on in those situations, if clinically we are strongly suspecting that patient is having hypoglycemia, it's not a harm giving the dextrose fluid before going to the imaging. So again, another mimicker causes the stroke, seizures. Seizures can mimic like the stroke at the same time. It is the first presentation of the stroke also. So actually the mimickers mostly focal motor type of seizures, sensory seizures, aura type, and a post-ictal confusion we consider as some weakness stroke-like presentation. But based on the previous history and other things, we can come to the diagnosis. But it is the first time seizures. We have to consider along with the seizure whether we are missing something, any structural lesion or vascular thing we are missing or not. So clinical clues plus lack of vessel occlusion on the angiography, and again if we are strongly suspecting and something is there on the imaging, we have to believe we have to go through the perfusion studies. So usually in the stroke we see that hypoperfusion, and also if anything is there, it usually follows the vascular pattern. Whereas in the seizure, usually multiple sites don't follow the vascular pattern. And again, we see that in the ictal phase, we see that hyperperfusion and sometimes normal perfusion. Very rarely, 26% of hyperperfusion is also possible. So again, in the seizures, we see that presentation of cortical or hypoxic prone areas are mostly involved. So in those situations, we have to think carefully. So another entity which present like a stroke are the migraine. So again, we have to keep in our mind that migraine present like a mimicker, and at the same time, we have to keep in mind that migraine has a risk factor for the stroke also. So usually, hemiplegic pattern of the migraine and migraine with aura, especially visual scotoma positive type of aura and brainstem type of aura, we may think that it is something we are dealing with something. Not a migraine. It may be vascular, it may be demyelinating, we may misdiagnose it. So, but what we have to keep in mind that migraine itself is a risk factor for the ischemic stroke. There is twofold increased risk of the risk, especially uncontrolled chronic migraine patients. So, if they are also having underlying other lifestyle adjustment, smoking or any substance abuse or using any other drugs, other vascular risk factors, they have a very high risk of prone to the stroke or any vascular risk factor. So migraine with aura can be both a stroke mimicker at the same time as a risk factor for the stroke. So why this migraine is causing atherosclerotic risk? Because over a period of time, because of endothelial dysfunction, it leading to changes in the microRNA level, leading to the genetic changes at the CGRP related, causing the atherosclerotic risk. So especially what I want to convey is that any migraine, uncontrolled, chronic, repeated patients, we have to encourage them healthy lifestyles, and at the same time we have to treat whatever vascular risk factors are there to them, we have to address them appropriately. So coming to the chameleons, various non-classic presentations of the stroke are there. These are the some of them. Non-localizing symptoms like neuropsychiatric type of presentation, acute confusional state, or altered level of consciousness. We can see especially whenever the reticular activating system or bilateral thalamus or right hemispheric pattern of the strokes are there, patient may present like this. And sometimes patient may present with abnormal movements. I already told that like seizure or first time hyperkinetic disorder or alien limb type of pattern. Patient may present it with the abnormal movements also instead of weakness or aphasia like that. Sometimes patient may present with peripheral neuropathy pattern like isolated hand syndrome, like foot drop, wrist drop, and also acute vestibular syndrome type of the pattern, and also cranial nerve deficiency. So another atypical presentation are isolated dysarthria, dysphasia, sometimes stridor, and occipital strokes may present with Anton's and the balance syndrome type of presentation. Even sometimes cerebellar infarction may be presented like isolated headache. So in the peripheries, they may miss the case as a normal headache also sometimes. And again, we have to keep in mind that in the early phases, MRI may be negative. So in those situations, again, we have to believe our clinical suspicion based on the clinical and underlying vascular risk factors. So I want to discuss some various presentations of the stroke. This is the journal publishing regarding the article hand knob area. So usually we all know that each body represented specifically in our brain. So this is the hand area, what we call as the cortical hand knob. So if this area is specifically affected, patient may present it with the hand weakness. And again in this part, only medial part is involved, patient may present like ulnar neuropathy type of pattern. If it is affected on the lateral side, patient may present it with radial neuropathy type of pattern. Again on clinical examination, it gives us clues that associated sensory and other involvement of particular flexor and extensor group of muscle. It gives clue that whether we are dealing with neuropathy or the stroke. So if the patient is presented with a wrist drop, if you ask them to fist, clenching the fist, usually in the central wrist drop, there is some elevation because of synchronic wrist extensors still intact. But whereas in the peripheral wrist drop, if you ask clench the fist, there is further worsening of the wrist drop. Some clinical clues will guide us whether we are dealing with the stroke or central cause or the peripheral cause. So this is another patient of 40 years old, presented with sudden onset of the dental pain in upper and the lower jaw, and no neurological examination findings in the limbs and other cranial nerve involvement. And MRI, it shows that lesion in the right side of the pons. So, but again we have to keep in mind that isolated severe sudden dental pain we can also see in the internal carotid artery dissection. So these are the various sites of atypical painful stroke presentation. We all know that thalamus and the parietal lobe are the most common sites present like a sensory type of presentation. And again in the pontine lesion, that the sensory part can present like transient eye, nose, mouth type of pain, and sometimes patient may present that salt and pepper type of sensation, especially over the face, particular eye region. In those situations, if other possible things are ruled out, we have to suspect whether we are dealing with the central cause or not. So this is another study publishing regarding around 5 patients presented like acute coronary syndrome. In those patients presented with epigastric and the chest pain. And, we all know that any patient presented with sudden epigastric and chest pain, the first thing we do is the cardiac evaluation. Here also they have done the cardiac evaluation and everything is negative. And finally they have suspect central cause of the pain, and MRI was done and find out as the stroke. Even the neurologist, acute stroke centers also, here they have missed the case, even the presented in the window period. So any patient in the acute presentation, if the cardiac evaluation is ruled out, again we have to suspect any other pathology is, central pathology is causing the pain. presented like a typical presentation. So coming to the hyperkinetic movement disorders, there are various types of hyperkinetic presentations can present like the stroke or any vascular responses. So usually most common in the acute phase what we see are the hemichoria, hemiballism syndrome, astrexis and the episodic paroxysmal dyskinesias. We also know that over a period of time as a permanent sequelae we can see dystonia, tremor, vascular PD and vascular chorea we can see. What we have to keep in mind that traditional teaching that chorea, caudate nucleus, hemiballism, subthalamic nucleus. Sometimes this role always not be rule. It can be hemiballism can be seen in caudate nucleus pathology, putamen and the thalamus also. So this is the case of a 64-year-old female diabetic and hypertensive. From the last 7 months complaining of episodic involuntary shaking movements affecting her left arm and leg. Those are precipitated by whenever she is trying to get up from sitting position to the from lying down to the standing position. And again, those complaints are subsiding when the patient is sitting on the lying down position. Usually, those attacks are lasting for about few seconds, and in between the attacks, patient is TIA is because of the contralateral artery stenosis. Whenever maneuvers, the patient try to have like a cerebral hypoperfusion situations, patient is having those type of the presentation. Here we can see that stenosis of the internal carotid artery and infarction in the coronary artery. So these limb shaking TIA are the brief, repetitive, involuntary stereotype, arrhythmic, jerky or shaky type of movements. It can be seen in isolated arm, hand, leg or sometimes completely unilateral. Usually last for the second. Usually patient described as I shake when I stand up. So these are the conditions caused by usually critical stenosis or occlusion of the internal carotid artery. And these are triggered by the standing up, walking or exercise, neck extension, whatever the maneuver which worsen the cerebral hypoperfusion and improve with the sitting under lying down position. In those situations, caudal nucleus of the oculomotor complex and find out the infarct. So this is another study, another case presentation. This case was presented in COVID era. A 19-year-old boy presented with sudden onset of the 2 weeks history of continuous cough. So during that period, everyone thought that it's a COVID. So patient was tested everything for the COVID, but they didn't examine the patient. How is the nasopharynx or gag reflex? After 2 weeks, patient lined up into the full-blown stroke, and they have seen during that period after MRI, it's a lateral medullary syndrome. And again here, two phases of both acute and the subacute phases of the infarcts are there. So that after exclusion of all the possible things, based on these two acute and subacute infarcts, what they have concluded that this acute continuous stroke might be the infarct in the lateral medulla lateralmost zone. So this is another interesting case. This patient presented like sudden onset of the inspiratory stridor. Again, what clue here we have in this patient is, again with the stroke usually stridor, what we see that in deep sleep or in the resting position, usually patient is having the stridor thing. But here the patient is having stridor whenever he is trying to talk or explosive type of thing. But she is not having any stridor type of things in the resting position and the sleep. On laryngoscope examination, patient is having bilateral vocal cord abduction with bowel counter. So on workup, this patient is having the left paramedian pontine infarct. So again another entity, this patient presented like sudden onset of unilateral isolated diplopsis. Nothing but the patient is presented like auditory illusion, like hearing one sound and after again the sound is repeating after the sample. So after ruling out the peripheral causes on imaging, what they have found that lacunar infarct in the connecting networks in the temporal lobe to the auditory. So again we know that the hyperterritorial strokes can present with sudden onset of the hearing loss. So any patient is presented with sudden onset of hearing loss with associated vertigo, tinnitus, after ruling out the patient is having underlying vascular risk factors, we have to think that hyperterritorial stroke also. So usually in our day-to-day practice we see more and more number of acute vestibular syndrome. So just I want to discuss next 3-4 slides regarding the acute vestibular syndrome. So acute vestibular syndrome is any patient presented with sudden onset of vertigo or giddiness lasting for more than 24 hours associated with nausea, vomiting, gait instability, nystagmus and head motion intolerance. In those patients we have to differentiate whether it is peripheral or the central. The patient is having red flags and it is a clinical boom for us. We can directly think that we are dealing with the central cause. So if the patient is not having any red flag signs, we have to check for the HINTS test. In those, just for the HINTS is the head impulse test, nystagmus, test of skew, and plus is the hearing test. In the head impulse test, usually normal patient, if we do that, there is no corrective second. Even in the central also there is no corrective. But in case of the peripheral pathology, there is corrective second we can see. Regarding the nystagmus, usually in the peripheral, it is the unidirectional. In whatever direction we move the head, the direction of the nystagmus is unidirectional. Whereas in the central, it is the direction changing nystagmus. And also it may be mixed one or the pure torsional nystagmus will be clue that we are dealing with the central cause. And test of skew, that is cover and uncover test. In case of the central pathology, when we do that cover and uncovering, we can see that vertical component either upward or downward type of the movement. Whereas these vertical movement absent in the peripheral pathology. If the patient is having peripheral pattern and acute hearing loss, we have to suspect that we are dealing with the labyrinthitis. But if the patient is following the central thing on the hints, along with hearing, we have to think about the eye. So simply on head impulse test, usually abnormal in the peripheral, that is corrective second we can see. Nystagmus is unidirectional, and on cover and uncover test there is no vertical correction. If the patient usually hearing loss is usually normal in the peripheral pathology, unusual in case of the central cause. But patient are following the hip central pathway and presented with acute neurological deficit, we have to think about the hereditary stroke. So again, what we have to keep in mind that in acute, in the 24 to 48 hours, the most dangerous flu is the normal head impulse test with other abnormal signs, and when in doubt, we have to treat it as the stroke. And again, avoid false reassurance from the normal, even the normal MRI also in the early phase. When hints suggest stroke, do not delay imaging or the stroke management. So again, the right hemispheric strokes are very deceptive. They can present like anything, like neglect, alien hand syndrome, visuospatial disturbances, behavioral, psychiatric, anxiety. So in the periphery, there is chances of misdiagnosis and delay the treatment is most common with the right hemispheric pattern of the stroke. So coming to the conclusion, the take-home message is not every sudden neurological deficit is stroke, but every sudden neurological deficit should be treated as stroke until proven otherwise. Stroke unit can lead to overtreatment and stroke can lead to mistreatment, and both can harm the patient. The most important thing what we have to keep in mind that diseases do not respect organ boundaries. They may arise in one system and manifest in another, so it may be looking like something else. So the art of diagnosis lies in thinking beyond the specialties and maintaining a broad differential whenever required, and seeing the patient as a whole will give the correct clue and the appropriate treatment. So even in this AI-driven world, today and tomorrow, what we have to believe that commitment and compassion to the patient and proper clinical judgment and experience and clinical examination are the main pillars for the medicine. It gives us very important clues while dealing with the patient. Technology may advance, but healing will always be human. We have to keep in our mind. With this, I want to conclude my talk. Thank you, everyone.
Thanks for the insightful and also clear slides about mimics and chameleons. As such, I am from Department of Medicine, and I think I see more of chameleons, and also there are some mimics. Patients come with metabolic dysfunction to the OPDs, or they come to the emergencies with emergency something like hypokalemia or hypertensive urgencies. So at that time, immediately the emergency people will be seeing for the neurological deficits, and they will be calling the general medicine people to overcheck. And over the time, also like patients come to OPD like with hypokalemic periodic paralysis. They don't have this awareness of going to neurology immediately, but they want to come to a general doctor, so they will come to general medicine. And also, if at all we keep on asking history, if at all we take a detailed history, then we get to know by the history that this person might be having some hypokalemic periodic paralysis. In the same way, many people come with proximal muscle weakness. They are unable to stand up from sitting position. They are unable to do their daily labor which they were doing previously. So all these are chameleons which we come across. So like as madam said, if at all we are clearer about the approach, how to see and diagnose the patient, it is the patient condition will be diagnosed fast and it is treated better. And we'll be hoping and continuing collaboration with the neurology department always, and we'll be continuing that. Thank you so much, ma'am.
That was an interesting rare case scenario, ma'am. So just a little tidbit for the residents over here. In case we are suspecting a posterior circulation stroke and our MRI comes negative, before we jump to whether it is a chameleon or a mimic, it is better to also get a coronal or a sagittal DWI, diffusion restriction imaging, to identify if there is a posterior circulation stroke, so that at least we can thrombolize during the window period instead of looking for alternative causes of the deficits.
I request the chairpersons to hand over the memento to Dr. Lakshmi Lavanya ma'am.
Sir, look. Okay. Sir, look. Sir, close. Madam, close. Good. Okay.
I request Dr. Kamlesh sir to hand over the token of appreciation to the chairpersons.
Sir, look. Okay. Sir, look. Okay.
निसार पेन ड्राइव किसमें होता ना निसार का पेन ड्राइव
ఇప్పుడు ఇచ్చిన సార్ రెడీ ఓకే
क्लोज है
So, as we come to the end of this second program, it's my privilege and honor to propose the vote of thanks to everyone, to express our sincere gratitude to our chairman sir, MD sir and Director ma'am for their constant encouragement and unwavering support in promoting the academic programs. And we thank from the bottom of the heart all our esteemed speakers and the chairpersons for sharing their knowledge, experience and valuable insight, making CME a truly enriching educational treat for all of us today. And our sincere thanks to all the delegates who have travelled from all the way and for their enthusiasm and participation and making this program very memorable and meaningful to all of us. And we would like to acknowledge and thank all the family marketing department, especially Satyanarayan garu, Satish garu and Gangadhar garu, for behind the program and how helping us conduct this program very smoothly. And our heartfelt appreciation to all the specialty community departments, all the specialties for their cooperation, encouragement and making this program very grand success. And also I would like to thank our pharma companies, all the 6 divisions of the Sun Pharma and the Genova Group for their contribution and their help for making this program smoothly. Thank you everyone. And also I would like to thank all the supporting staff and whose hard work, dedication and commitment helped this program to run smoothly. And also I want to thank all my PGs and our department and all the interns for their contribution. And on personal note, I would like to express my big gratitude to all my teachers, gurus who guided me throughout my journey. Finally, and the most important about my head gratitude to the Almighty and whose blessings are very important in all my journey. Once again, thank you all for coming all the way and making this program very memorable and success. Thank you everyone.
लाइव दिखेगा